Morning to those in the room here at the National Academy of Sciences building, and good morning to our guests that are joining us online. My name is Ivory Clark, and I am the director of the Culture of Health program here at the National Academy of Medicine. And I want to just welcome you all into the room today and into our virtual space for what we know will be an informative and engaging meeting today and tomorrow. I want to first begin, though, with an acknowledgement here. We begin each of our meetings at the Culture of Health program by acknowledging that we gather on the traditional lands of the Anacostan and the Piscataway peoples, both past and present. And we honor with gratitude the land itself and the people who have stewarded it throughout the generations. We honor and respect the enduring relationship that exists between these peoples and nations and this land. And we thank them for their resilience in protecting this land and aspire to uphold our responsibility to their example. We do invite you, if you're joining us here in the room or those that are joining virtually, to go to native-land.ca and enter your zip code and learn about the land that you are currently existing on. Next slide, please. I'm just doing a brief welcome to you all because we've got two amazing speakers behind me that are going to do a more formal welcome and opening remarks. But I want to do some housekeeping for those of us that are here in the room, and particularly those that are online. We want you to engage with us today and tomorrow via Slido, where you'll have the opportunity to add in your questions that you want to ask to our moderators, to our speakers, our panelists, our authors. And the way to do that is to enter our event code, which is up on the screen now, 3501958, or you can scan the QR code. And throughout today's presentations, you'll see the Slido QR code and the code available on the website and the screens here. Please feel free to drop in questions and comments for our speakers and panelists today. And with that, I'm going to turn it over and introduce Dr. Victor Zhao, who's the president of the National Academy of Medicine. He's not able to join us today in person, but he has provided some pre-recorded remarks. And so with that, I'll turn to you, Dr. Zhao.
Good morning. I'm Victor Zhao, the president of the National Academy of Medicine. And I'm so glad I can join you today virtually in this important meeting. Today we meet under the National Academy of Medicine's Culture of Health program, sponsored by Robert Wood Johnson Foundation. And together we'll examine the system's impact on historically and currently marginalized population. You know, the issue of health equity is central to the mission of the NAM. Back in 2014, when I was appointed the president of the NAM, and from my very first day in office, I believe strongly that a proactive approach to health equity is needed. And it has to be sent in the forefront of everything that we do. Therefore, as soon as it became the NAM, and a year later, after reconstitution of the IOM, we added the words accelerating health equity to our mission statement. To my knowledge, this is the first time, certainly in the academies, but I think in other organizations where health equity is part of the mission statement. But within the world of health and medicine, the NAM is uniquely positioned to elevate the evidence base and move our focus beyond an overly general discussion of impacts of oppression, marginalization, discrimination. Instead, it is our goal to provide research-based guidance and strategy to tackle the important systemic discrimination, harm, and exclusion on the historically marginalized population. In 2015, we launched the Culture of Health program in partnership with Robert Wood Johnson Foundation. And our intent was to identify strategies to create and sustain conditions necessary to support equitable health and improve outcomes for all. The Culture of Health program has achieved many significant milestones, which I'm very proud of. We have released 4 consensus studies on pathways to achieving health equity, including integration of social care and determinants to medical care delivery. the importance of taking a lifespan approach to health equity by addressing barriers to equity for children and adolescents. And we held a nationwide community art project inspired by young leaders, developed a community documentary series, creating a model for communities to develop strategies to promote health equity locally. We traveled the country to learn how communities are promoting health equity on their ground. As I said, I'm very proud of this initiative and the work we've done to communicate and collaborate with those who are advancing health equity on the ground, as many of you are. Importantly, the NAM has an obligation to speak up in defense of science and health and lead changes for the better. For this reason, we've cultivated a proactive public response to major national and international developments and spoken up on behalf of the academies on public policy issues. So after the senseless murder of George Floyd, I made a public statement committing to ensure that all people, especially people of color, feel safe and supported while working within our organization, as well as pursuing racial equity in our organizational policies and procedures. At that time, we recommitted to using our platforms to improve the lives of people who experience disproportionate health disparities because of socioeconomic inequity, bias, and structural racism. Since then, we've worked tirelessly towards these goals. And not only do we go forward with the goals that we set, but we also work to listen, learn, and work with those impacted by structural racism and other drivers of health disparities and inequities. I also know it's important to examine our own internal structures and practices to be sure that we are practicing what we preach. So in August 2020, we launched an internal committee to advance racial equity called CARE, led by Ivory Clark, to operationalize NAM's commitment to inclusion, diversity, equity, and anti-racism. CARE is in the process of finalizing a set of guiding principles that will guide the NAM to hold itself accountable in action and activities to confronting, challenging, and addressing structural inequities within our own organization. Each unit within NAM will be asked to develop a plan on how these principles can be demonstrated in everyday work and life within our academy. Well, that is where we've been. We know there's a lot more work to be done to accomplish our goals. And at the NAM, where our purview is health, we understand structural issues, including systemic racism, are major drivers of poorer health outcomes for people from groups that have been marginalized. Today, we're happy to announce Culture of Health's next major project, the development of a paper series publication based on systems impact on historically and currently marginalized population. Now, this publication series will be a unique opportunity to focus on the role of various systems influencing disparate health outcomes. It includes the historical and current context of how structural racism perpetuates oppression via unequal power relationships. So we hope to identify ways in which marginalization flows through the system to perpetuate inequities, then identify opportunity to dismantle structural systemic racism for improved patient health outcomes. As part of the series is our goal to highlight the social construction of race and ethnicity, describe the shifting definition of race and ethnicity over time, and elevate how existing racial ethnic definition can cause harm and misinterpretation of diverse population. We know that racism and other major structural factors play a significant role in limiting opportunities and access for large swaths of the population. Last month, we saw a clear reminder of these results when the National Academies released a consent study entitled Advancing Anti-Racism, Diversity, Equity, and Inclusion in Science, Technology, Education, Math, and Medicine Organizations, STEM organizations, beyond broadening the participation. This report from a committee advancing anti-racism, diversity, and equity and inclusion in STEM education describes how individuals from minoritized racial ethnic groups continue to face systemic barriers that impede their ability to access, persist, and thrive in STEM higher education workforce. This report underscores the need to go beyond simple principles of diversity and inclusion to remove barriers to entry and participation to foster a culture of inclusion, thriving success. I always said that many organizations define diversity, equity as numbers. Do we have enough underrepresented minorities? Do we have enough Latinos or Black? I say it's not the numbers, it's making the numbers count. Something that we echo in the mission and vision of Culture of Health program. We know that historically underrepresentation of people of color in medicine and biomedical science is just one factor perpetuating inequitable outcomes. We must take active, intentional steps to dismantle policies, practices, and cultures that confer power privilege to a select group of people and to certain groups. It's our hope this new paper series from Culture of Health program focus on understanding how structural racism works within and across systems to perpetuate health disparities will provide illustrative examples of opportunities for systemic change. Very important meeting, very important publication. I know you're going to hear more details of the program journey from Dr. Antonia Valerio in just a few moments, and more details on paper series from Dr. Velma McBride Murray tomorrow. So the remainder of your time together over the next 2 days will focus on jumpstarting discussion on this topic, leveraging historical and contemporary context for health equity, understanding race as a social construct and not a biological construct, and potential levers to create system change. Tomorrow, you have the opportunity to discuss the publication series in further depth, including where development stands to date and how we might best maximize the opportunities for sharing and potential impact. We have a wonderful set of speakers, and I'm looking forward to hearing more from each one of them, as well as from all of you in attendance. Everyone here has something important to contribute to this discussion. And I hope this meeting allows for creative thinking and productive conversations. And I thank you again for allowing me today to open this very important event. Thank you.
Thank you for that message
Good morning.
from Dr. Zhao. So it's my pleasure to introduce and ask Dr. Antonia Villarreal to come up to the front and offer some additional opening remarks for our meeting. Tony is our chair of the advisory committee, in addition to her role at the University of Pennsylvania, but I'll let her introduce herself more formally. So thank you, Tony.
Good morning, everyone, and good morning to everyone online. It's really exciting to be here today. With my fellow advisors, we've been working on this for a number of years, and I'm so used to only seeing you in the Zoom box that I didn't realize how tall you were or how blue your eyes were or anything else. So again, it's great to see and be with you in person, along with many of our distinguished guests, and welcome to everybody online. As Ivory said, my day job is Dean of the University of Pennsylvania School of Nursing and the Margaret Bond Simon Dean, and I serve as the chair of the National Academy of Medicine Culture of Health Program Advisory Committee. I've had the privilege of being part of this group since its inception, and I can't believe it's almost 10 years. I've had the privilege of working and championing and supporting our work to advance health equity in a multitude of ways, along with many colleagues and community partners. At its core, the mission of the Culture of Health program is to identify strategies to create and sustain conditions that support equitable health for everyone in America. I thank Victor for highlighting the many accomplishments of the program to date and underscore the critical contributions of this work. The program has and will continue to elevate the evidence base, including the lived experience, to communicate and disseminate evidence to bring understanding of the strongest science and lived experience to those working to advance health equity, to engage the full range of experts and expertise and stakeholders working at all levels to eliminate health equities, and finally, to create pathways to sustain this critical work. Many of you have joined, supported, and led aspects of this work, which we continue now in the second phase of the program. In our first phase, we had a broad focus on health equity, a focus on the social determinants of health, and amplifying community knowledge and expertise in this work. In this phase, we continue with both of these elements, but also address two underlying root causes of inequity that were highlighted in our 2017 Communities in Action Pathways to Health Equity report. And that is addressing systemic and structural racism, and by extension, addressing the unequal allocation of power and resources. Borrowing from our program website, the program remains grounded in the understanding that everyone in this country deserves the opportunity to be healthy and to reach the full potential, no matter who they are and no matter where they live. Yet we also know that some groups face barriers based on factors like where they live, their race, ethnicity, gender identity, country of origin, that have a direct and sometimes negative impact on health. These barriers are systemic and they're structural, nor are they random or accidental. They are a direct result of structural and policy decisions from the national to the institutional level that create and sustain social and economic inequality and structural racism in this country. Anyone who believes this is part of the past need only to look around to see the assault on women and reproductive rights, on LGBTQ individuals, and the number of anti-woke legislation that we're seeing across the country. This is something that we have to address now. The Culture of Health program is intentionally focused on elevating and creating evidence-based solutions that address root causes of inequity. Victor has highlighted some of the ways that we are taking through this, and one is through the publication series, which you will hear more about from my fellow advisor, Velma McBride Murray. I'll tee up now just briefly that in this series, one of the critical elements is to acknowledge and bring light to those environments and experiences of different groups that are shaped by similar and unique barriers and biases that were developed yesterday and prevail today. Ultimately, what we seek in this series is to bring a unifying perspective and action on how to address these inequities to improve health. So again, acknowledging differences, but also recognizing the commonalities and how we can work and amplify our individual work. Through this series, we will bring to bear the full strength of evidence, both what is often termed as traditional evidence, as well as the critical evidence and expertise of lived experiences. This program has delved into working with and being guided by communities to help shape in several activities. Embedding and being in partnership, truthfully, transparently, and honestly with communities will continue. The Culture of Health program journey, and frankly, that of the National Academy of Medicine, has been one of innovation, boldness, and learning. And I will say that this occurred because of the Robert Wood Johnson Foundation, who challenged the National Academy of Medicine and believed that the National Academy of Medicine could and should lead in this space. I want to acknowledge and thank Victor Zhao for accepting the challenge and for being part of this journey. I know he was with us remotely, but I will assure you he is not only supported from afar, but has been an active participant. And I think the work that he has done to examine the work of the National Academy of Medicine is very bold. And again, grateful to him for his work. We continue to recognize the privilege that a platform such as the National Academy of Medicine has, and we strive to be good stewards of the platform to amplify the voices that need to be heard and to provide guidance grounded in science to propel us to a more equitable future. Before I turn to my fellow program advisor, Steve Wolf, to lead off our first session, I want to thank my fellow advisors of the program for their commitment to the work that are here. And for those in the audience, if you could just raise your hand, my fellow advisors, because I need to see who you are too. Very good. Thank you. Thank you. And again, welcome others who are here, who are taking the audacious task of threading the needle of history to present and identify impactful solutions for decision makers and address the legacy of structural and systemic racism in the country. So can our author and author groups also raise their hands so we know who you are? Fabulous. So excited for you to be with us here. I want to thank each of you who are joining us today and tomorrow for continuing to engage in this work in whatever you do through your thoughtful participation in our meetings and the work that you do outside. I want to thank the Culture of Health program staff, Ivory Clark, who has been with us since the beginning as well, and who has done the many twists and turns as we have moved forward. Elizabeth Solomon, Julie Tarrant, Shanae Taylor, and Christina Wint for putting together a thoughtful and engaging program with representation of the critical expertise to advance our meeting. I also want to recognize Julia Morita from the Robert Wood Johnson Foundation, who not only supports us, but also guides and shepherds and stewards and challenges us here. Again, grateful to have you with us today, Julia. Just to refresh our objectives, which I think are posted someplace, are to discuss the significance of understanding the history and systems impact of oppression, racism, and widening racial disparities in light of current and social political contexts, to highlight the social construction of race and ethnicity, to describe how structural and systemic racism moves through systems to drive health outcomes and provide examples of the levers of systemic change for advancing health equity within and across racial and ethnic populations. And with that, I'd like to welcome Dr. Stephen Wolf from the Virginia Commonwealth University School of Medicine and Dr. Gail Christopher, the Executive Director of the National Collaborative for Health Equity, to the front to kick us off. Thank you.
Good morning, everyone. It's really a pleasure to be here. My name is Steve Wolf, and I am the Director Emeritus of the Center on Society and Health at Virginia Commonwealth University. Before going any further, Tony was kind enough to point out the great contribution of Ivory and the staff, and I just wondered if you could give her the whole staff a round of applause. We'll no doubt do this again at the end of the meeting, but those of us who are on the advisory committee know how much hard work the staff have already done just to get us up to this point. So this opening session is going to get us started on the right topic. Just a quick overview of the outline. I'm going to make a few remarks and then introduce our guest speaker, Gail Christopher. And then after that, Gail and I are going to have a informal discussion, and we're going to hope that you all get directly involved because we want this to be a interactive participatory process. I've been asked to remind you to use the Slido tool, which I have never used before, but up there is the barcode or QR code and ID number for you to log into so that you can ask questions along the way. So we just heard that we're here to discuss in this two-day meeting the role of systems and structures in producing the racial and ethnic inequities that we struggle with in this country, and also to talk about the unequal allocation of power and resources. We all say to our students that this has a history. This didn't come about by accident. And so we begin our program, as we should, by thinking back and reflecting back on that history. We're going to talk about we're going to take a look back to understand how that history informs our future. Gail will be describing the role of systems to inform policies and practices that have led to widening health disparities and reflect on opportunities to advance more equitable systems in current social and political contexts. She's really one of the greatest thinkers to be able to get us oriented around this topic. Let me tell you a little bit about Gail, who I've had the pleasure of knowing for 20 years, I guess. Gail is the executive director of the National Collaborative for Health Equity. She's known for her pioneering work to infuse holistic health and diversity concepts into public sector programs and policy discourse. But for many years, and this is the period during which I got to work with Gail initially, she was the vice president of the W.K. Kellogg Foundation. And at Kellogg, she was the driving force behind the America Healing Initiative. And very importantly to this meeting's discussion, and what we'll be talking about during this session, the Truth, Racial Healing, and Transformation effort, which if you don't know about, I'd encourage you to read up on it. Among her many other hats, Gail currently chairs the board of the Trust for America's Health. She's a senior scholar with the George Mason University Center for the Advancement of Wellbeing. And I did not know this, but the APHA honorary vice president for the United States. Among her many other accomplishments, many of you may be familiar with Heather McGhee and her tremendous book, The Sum of Us, which talks about the problem of, I'm forgetting the phrase, but you know the book. Anyway, this is Gail's mom. And so that's I think we all take pride as parents in the accomplishments of our children, and Gail has very good reason to be proud. So without any further ado, we're going to go ahead and get started and have Gail make her initial remarks, and then we'll go into a panel discussion. I think we're allowed to just stay right here.
Good morning. Is my volume okay? Thank you. Thank you. Thank you, Stephen, for that gracious introduction. And thank the creative folks that have organized this session. I was honored to be invited to share with you today, and I applaud the Robert Wood Johnson Foundation for investing in this really cutting edge and important work. I will bring a perspective that I hope will continue to inform your work, and it's an outgrowth of more decades than I like to count, really, of trying to do something about racism in our society. And I've learned some lessons, and I'm going to share those lessons with you and hope to impart the passion that I have for the urgency of us really getting to the root, if you will, of our challenge. Yes, it is systems, and yes, it is policies and practices, but who creates those systems? People. And so we don't have the luxury of these false dichotomies that tend to emerge, in academia and in philanthropy and in social justice advocacy, where we try to say, well, it's either this or it's either that. And what you'll see in the Truth, Racial Healing, and Transformation framework is that we don't have the luxury of that. It's really all of the above that we have to deal with. And I'll talk about that. This morning, I woke up to the news that the Justice Department had released its report on Louisville, Kentucky's police department. I know many of you may have heard that. And after the brutal killing of Breonna Taylor, they decided to investigate. And their findings for the people there, for the people of color, one of the people interviewed said, well, finally, we're being affirmed as a community. What we said was happening is really happening. The Justice Department talked about the excessive force. They talked about the over-policing. They talked about the brutality and the over-discrimination. And the mayor apologized. But my question is, why did it take a federal investigation and the death of Breonna Taylor and the protests to acknowledge what for so many of us is so obvious? And so that's kind of where we are today in terms of needing to create not just a critical mass, which I used to say, but in actuality, a supermajority that will stand up for what we know to be the necessary work in our country of transforming our cultural ethos. And while I think the anti-racism work is critically important, you know, I jokingly say sometimes, you know, there are a few advantages to growing older and none of them are physical. But one advantage is, I think, the wisdom and the lessons, several advantages, the wisdom and the lessons that come. And one of the critical lessons I've learned is it's not just enough to assert what you're against. So while the anti-racism framework is important, more important is what are we for? What, in fact, are we creating? And where is the science to undergird the necessity of creating something new? And what is that new thing? I've come to understand, yes, it is a culture of health, but what makes a culture? A culture comes from the things that we believe and hold most dear. The framers of this conversation today said, let's look at history and let's figure out how we leverage history so that we can understand better what to do. I want to remind us that history is a very long arc. And the history that we need to consider extends beyond the history of the engagement of Europeans with the Americas. It extends beyond the history of the capturing and enslavement of Africans. The history that will give us the light for creating a new future is a history that honors the humanity, the cultures, the dignity, the creativity, the brilliance that predated colonization and enslavement. That's a very important part of our work because we have to learn to honor the humanity of all. And part of the education that will give us that capacity is the immersion in the truth of the humanity of all. Now, in this age of technology, many of us are afraid of identity theft. And in some ways, racial hierarchy and racism is a form of identity theft. People took away our true identity so that they could benefit and we would suffer. But I even take it a little further. It's really humanity theft. And what gives permission for the unjust treatment by police systems, for the insane snatching of children from immigrant families at the border, what gives permission for any number of atrocities is a deep-seated belief in the less than human status of people of color. Now, I know some of you will say, oh, no, that's not the case. I don't believe that. That's not true. But look at the evidence. So if we're going to truly change the systems and the structures, we're going to have a massive campaign to build our capacity to engage one another as equal human beings. And we can put on Band-Aids forever, and I've lived long enough to see a lot of Band-Aids. But until we go beneath the surface and we deal with the thinking and the believing and the consciousness that defines this culture, we will continue to be in this loop. Now, health inequities and health disparities, you all are experts in that area. But for me, I think the most important organizing frame about that is to understand the chronic nature and the debilitating nature of stress. Could I have the stress and allostatic load slide? Could we show that one? Okay. And if you look at that, and this is the work of McEwen and others, I think Sapolsky does the most creative treatment of the effects of cumulative and protracted stress. But what we see is that every one of the major chronic disease syndromes that is burdening our healthcare system and is disproportionately burdening communities of color is a function of an ongoing stress response or an allostatic load. And to live in a society that denies our humanity creates that kind of ongoing, some people like to use the word trauma, that kind of ongoing distress and demand for energy adaptation. And after COVID, we could certainly add vulnerability to infectious diseases to this list. And so the necessity of creating environments that counter the burden and the weight of exposure to beliefs that deny our full humanity, we can't underestimate the necessity of doing that. I'm going to talk a little bit about the truth, racial healing, and transformation work. After many decades of dealing with the consequences of racism on so many levels, after having been catapulted into this life's work by the loss of my firstborn child at 4 months of age, that was what introduced me to the concept of infant mortality and maternal mortality and all the various health inequities and disparities. And I spent the next 40 years trying to do things that would help to mitigate exposure to stress, trying to create more opportunities for well-being in communities, trying to change policies. But ultimately, I realized, and I was privileged to be in philanthropy, and we are privileged to have a philanthropic sector in this country that can make investments that are catalysts for real change. And so at the Kellogg Foundation, we invested in a decade or so of what we called America Healing, where we worked with hundreds of communities around this country that had the courage to take on racism. And then from that, we learned some core lessons and created a framework for a national truth process for America. America hasn't done it. Over 40 countries have across the world, but we have yet to do it. And I believe because we hold on so dearly to this belief that there's something other than full humanity that can be ascribed to people of color. And as my daughter's book embodies, people view that in a zero-sum way. They believe if I give full humanity to people of color, somehow that will lessen my humanity. That will lessen my opportunities. And I encourage you to read that book if you haven't. She does a really good job of refuting this zero-sum framing. But in the truth, racial healing, and transformation framework, we understand that so much of this work must be done locally and it must be done nationally. But it is not a commission. It is not talking heads. It is not moments of apology. It is a comprehensive, steady work that is transformational in all of our systems and structures. So very briefly, let me describe the components of the framework for TRHT. And the first is narrative change. I talked about the belief in a false hierarchy of human value. That belief is based on stories that are narratives that are simply untrue. I really emphasize the necessity of embracing that the cultures and the strengths and the wisdoms and the identity of cultures, indigenous cultures, it's very important to creating a new narrative. Life didn't begin when European cultures encountered people of color. They had lives, we had cultures, we had systems. Changing our narrative to one that doesn't deny and doesn't spend all of its energy blaming and shaming the dominant culture in America. Because if we do that, we end up with the backlash that we have today. We end up with this anti-woke dynamic. We have to understand that ignorance has given rise to many erroneous concepts throughout history, and who knows that better than the medical profession? And ignorance gave rise to the false ideology of a hierarchy of human value. And science has shown us, the genome work has certainly shown us that there's more difference and variation within the races than there is between them. And so this nonsense of racial hierarchy, it is not just a social construct, it's a fallacy. And so we have to be about creating a new narrative. The second pillar is, of course, doing what I believe is the most difficult work, which is building the capacity at individual, organizational, and ultimately at the societal level to demonstrate empathy and compassion across perceived differences. And there is a body of psychological science and social science that has emerged over the last few decades. We know how to do this. We know what reduces bias, but we've got to take it to scale. And so relationship building across racial lines, that's a critical part of the sustainable change that we need to make to get to that supermajority that a democracy requires. And then as we've created new narratives and we're building that supermajority, then we can tackle the structural manifestations. And briefly, we asked ourselves in designing this, we said, if human hierarchy is a lie, how has it been maintained so successfully for so long? And we came up with three primary, and I'm going to use the term buckets, very scientific, three primary avenues for maintaining racial hierarchy, maintaining structural racism. And the first one is through myriad forms of separation. No matter where you turn in history, whether it's redlining or taking children from their families in the child welfare system or over incarceration, Native American encampments and so-called reservations, they're all forms of separation. And they're all driven by the belief in a less than human status of those, so that people must be separated from them. My daughter's metaphor in her book is the drained pool, where they actually drained and filled the pools in with dirt and covered them over rather than allow African Americans to swim in them. And she focuses on the drained pool. I focus on, why did they drain the pool? What was the belief that was driving that? The second key area of maintaining, or avenue for maintaining, racial hierarchy are the laws and the policies, not just the criminal justice system, although it is certainly where power is used, but our immigration policies, our state constitutions, our organizational policies and systems. And then finally, all of this fuels an economy that thrives on the inequities that it creates. So the good news is that cultures or communities across this country are taking this framework and applying it to transform the conditions where they live. A few years ago, Congresswoman Barbara Lee and Senator Cory Booker put forth resolutions. We gained over 250 co-sponsors, but in the political polarization, it's not going anywhere. But we have to, as a country, step up and do the transformational work, not just reconciliation, but truly transformational work. And we're learning and finding that this framework works for communities to adapt it so that they can actually make the policy changes that are necessary. I encourage you to read Healing Through Policy, which is a set of briefs that we did in partnership with the American Public Health Association, funded by philanthropy by the de Beaumont Foundation, where we curated the different policies and practices that communities are putting into place across the country that align with this framework. How are they changing the narratives? Quite often it's through the use of data. Data can help to drive a new narrative. Data alone won't move people past denial, but it is an important step. Denial, as you all know, has many aspects, many phases. I like to think of it as first denial of fact, and then denial of consequences, and then denial of the implication of those consequences, and ultimately the denial of the feelings that are spawned if we face the truth. And so while data efforts are critically important to changing narratives, we have to do more. We have to change media. We have to leverage social media to create a new culture. If you read Healing Through Policy, you'll see many, many examples of communities that are doing this work, and I can talk more about it when we get into the Q&A. But as I draw to a close, and I think my timing is right, I want to say kudos to each of you. Congratulations on the pioneering work that you are doing here at the National Academy of Medicine. If someone had told me 20 years ago, 40 years ago, that would ever happen, that this august institution would be tackling structural racism, I might not have believed it. But now that you are here and now that you are doing it, I beseech you to think not just about what we're against, but about what we're for. And what is the vision for the future for our grandchildren? How do we create an America where every human being is valued equally? It is a comprehensive effort, and it will require all of us. Thank you.
It's always a treat to listen to Gail. I enjoy it every time. Heather needs to know that she just got a new endorsement for her book from her mom. Gail, we're going to have some initial chat here, but I hope all of you will think about any questions you want to pose and raise your hand, or use, what's it called again? Slido. I'm not used to that, to pose your questions. And Ivory's going to monitor that so we can see what questions are being posed that way. So I remember you talking years ago about the hierarchy of human value, and that really sunk in with me. And I really believe it's true that's really at the root of all of this. One thing I'd like to just get out on the table before we get too much further is a bit of the elephant in the room when we're talking about history. And that's what's going on in our country right now in terms of the national conversation, where, we're living at a time where there's a social division, and a good part of the population that would be totally turned on by what you're saying and would feel very strongly about the need for confronting our past and doing the kinds of structural change that our program is all about, and promoting inclusion. And then there's another part of our society that's in a different place, and is becoming quite activist in actually banning the teaching of this history. In my state, we had made some progress, but a new governor that was elected in 2021 has issued instructions to agencies to remove the word racism from any of their documents. The new health commissioner has been questioning whether there's evidence of systemic racism. You mentioned the anti-woke policies that are being promoted in some states, where teachers are getting reported if they dare bring up the subject. So, our conversation has to be held in that context. And I wonder, given that kind of climate, how do you begin the process? You said we need to change the narrative. How do we begin the process of changing the narrative in that kind of climate?
Well, I really want to remind us that the loudest voices are not necessarily the majority. And we've been doing some polling, and we've been reviewing polling, and certainly the true election results of 2020, coupled with the midterm, they attest to the fact that those loud voices are not the majority. And we need to remember that. That doesn't mean we go to sleep or we become complacent, Steve, but it does remind us that we're in an age where we have cable news, and cable news can be very loud. I can say this with a certain amount of comfort after the news of the last 2 weeks. They can be loud liars. But they only reach the data on their population, their viewership is about 1.5 million. And that's for both Fox News and MSNBC. So we have to keep our allostatic load down and our stress levels under some control by not buying the okie doke and by not believing that those are the dominant voices. Now, where we're in trouble is when they get to be governors. Oh, God forbid they get to be a president again. And so that's the first response to that. The other response to that is embodied in my book, which is called RX Racial Healing. And I think we have to do the work. Do you know how almost every community in America has Alcoholics Anonymous programs? You can't walk into a church that doesn't say on Thursday nights, we have a 12-step group or something. Now, I know there are debates about, the evidence of that, but overwhelmingly, these programs have helped. We need actual programmatic efforts in every community that are designed to bring diverse people together to affirm our humanity. And there are methodologies for doing that. And once you have that moment of aha, where you actually see beyond the perception of difference, and you actually become engaged with another human being that you thought was different, but you become engaged with their humanity, there's something innate in us that won't stand for injustice. And so I'm happy that this work is happening in thousands of communities around the country today. Annually, the Kellogg Foundation sponsors a National Day of Racial Healing. And so bit by bit, we're chipping away at this hierarchy of humanity. But by replacing it, and this is the takeaway if you don't take anything else from my conversation today, know that we cannot just be against racism. We have to replace it with something that is much more viable, something that is we can do as a democracy. I hope that's helpful.
Yeah, I love that idea of not just being against racism, but advancing a new narrative. And I think you're absolutely right that one important facet of that is humanizing each other, and stories and relationship building that can help to do that, I think is so critical. Having said that, there is a bit of a phenomenon you've mentioned that I'm curious how you would explain. You said that over 40 countries have gone through this process, and a couple that I would single out is South Africa, but also Germany, which had a pretty difficult history to come to terms with, but in many ways has done that quite beautifully. If you've visited Germany, you're familiar with the fact that you can walk around Berlin and see markers that the government has placed and sidewalks and other areas indicating this is where the Nazi did such and such. So these and many other countries, you've said, have been able to come to terms with the truth. But there's this outlier that has really had a difficult time swallowing that pill. What is it about America? What is it about Americans that, unlike other colonial powers, others that have been engaged in this kind of atrocity, have had such a difficult time in coming to terms with the history?
I appreciate that question, Steve. What we fail to acknowledge is the long arc of enslavement and Jim Crow in our society. We're talking 4 centuries. Think about that. 4 centuries to build and create and embed systems that allow this denial to be perpetuated. When they drained those pools in Alabama, it was in the 1950s, in our lifetimes. And so this government reinforced the ideology of a hierarchy of human value. Now, we talk about racism and we call that out, but one of the reasons that I use the frame ideology of a hierarchy of human value, because I want all of it, is whether it's anti-women, LGBTQ, all of these decisions to make people less than, right? Anti-immigrant, it all stems from that same hierarchy that basically puts all the power and all the value, and this is uncharacteristic of me to say, but I have to say it, in white males. And so when we talk about doing away with that false ideology, we're talking about embracing all of our humanity in an equal way. So I think one of the forms of resistance is that it's gone on for so long, which is why I believe this moment is critical. The other reason I think the resistance is so deep is that the cruelty, the brutality, the denial of humanity, it was pretty barbaric. And the self-image of America, it doesn't align with that truth. America doesn't want to see itself as having done the atrocious things that it did to human beings for so many centuries. But in the midst of the atrocities was also amazing resilience, amazing leadership, amazing love, amazing coalition. I mean, when the true story of how we ended that is allowed to be told, it doesn't diminish America. It actually makes America someplace to respect more deeply. The abolitionist movement, the Underground Railroad, the many, many, many ways in which people came together and overcame the fallacy. We need to tell those stories and we need to reconcile the contradictions so that we can exhale collectively. But I really think it's a deep psychological pain. And that's why we need the community. We need the psychologists. We need the medical practitioners. We need science to not only tell us what was wrong, but to help show us the way to do it right.
That's very helpful. I mean, one of the questions I had jotted down I wanted to ask you is you had made an earlier reference to denial. And I was going to ask you, what do you think is behind that denial? But I think you've started to answer that question now, which is, you know, the discomfort of coming to terms with the atrocities and the horror of what actually happened. But like it happens with individuals in terms of their own individual self-healing, who've had difficult pasts. Your point is you can deal with those realities and come to terms with them, and then embrace, you know, a more wholesome sense of yourself and what's possible. And I think a lot of that history, we did a project. I think one of the links that was sent around, not far from here, Northern Virginia, the suburbs of Washington, D.C. We've done a lot of research over the years showing stark geographic health disparities by census tract, where, you know, life expectancy differs by 20 years. And as most of you are familiar who've done this kind of research, the people of color are disproportionately represented in those neighborhoods that have done so poorly. And there's this narrative, not the kind of narrative we want, that often prevails that says, well, you know, those neighborhoods are that way because of the people that live there. And an ignorance about how those neighborhoods came to be. So we often have said over the years, when we've talked to policymakers and others in the media, that there's a history about why these neighborhoods got this way. Well, a local funder actually basically said, I want you to tell that history. I want you to do the research and explain exactly what happened here that created this set of census tracts this way. And so because it was Northern Virginia, we started that investigation, we pulled the thread, it goes back 400 years. So the story starts in 1649 about, this very region in the suburbs here. And we tell the story of everything from the genocide of indigenous populations and enslavement to the Jim Crow era and restrictive covenants and all the other measures that were taken. But what emerged from that, and what our advisory group was so emphatic about, is don't just tell the story about those traumas, but talk about the resilience. And there were so many inspiring stories that came out of that. So I really agree with you about it. I think there's so much value in seeing that history, but unfortunately, our society really isn't designed to think that way. I'm coming up to a question for you, but with COVID-19, when we saw the horrific racial and ethnic disparities in COVID-19 mortality rates, doctors like myself were interviewed by the media to explain why is it that life expectancy is dropping by 3 to 4 years in Hispanic and Black populations and not so much in the white populations. And it was very typical to run through the list, they're more likely to be essential workers on the front lines, and therefore they had greater exposure to the virus, more crowded living conditions, employers less likely to institute safety precautions, less access to healthcare and vaccination. And people would often mention and higher comorbidities, because the research had shown that people with greater comorbidities, hypertension and so forth, had a greater risk of hospitalization and COVID-19 mortality. And it was very quick for people to just sort of check that box and move on. But the history comes in and asking, well, why is it that there are higher comorbidities? What scientific reason is there for it to be higher rates of hypertension in one group of human beings versus another? And of course, the conversation leads us back to how are we doing with any questions, Ivory? Do we have any? Okay, because I've got some more I want to ask, but I want to give other people a chance to get involved.
Hello. Can y'all hear me? Hi.
Yes.
Morning.
Thank you. That was an amazing presentation, and thank you for your work in truth and racial healing. I mean, this is one of those wonderful things that we would love to see all across the country. My name is Jose Rodriguez. I live in the great state of Utah, which has gotten some press recently, as you might have heard. And, we're talking about the age of really anti-woke legislation, and they're making this idea of wokeness into a bad word. And my question is, how do we form and create alliances to overcome this movement of anti-wokeness?
Well, thank you for the question. And as I answer it, I do want to really encourage you to read the amazing paper that Stephen Wolf recommended and wrote, the deeply rooted story of this region of Northern Virginia. We need that done in every region in the country. That's just the first, I hope, of many. The how, I want to remind folks that the concept of woke was associated with a Black Congresswoman. So there is some misogyny in this anti-woke stance. Don't forget that. How we overcome that is to not let that be the narrative. In other words, and this is, people ask me, why have we trademarked some of our terms like America Healing or RX Racial Healing or even TRHT, the Kellogg Foundation? We don't trademark it for commercial reasons. We trademark it so that we can stop people co-opting it for nefarious purposes. So one of the things we want to do, we need to stop repeating the woke narrative, because that's been co-opted now, and that takes us down a rabbit trail. We need to create our own language that focuses on things that align with what we are truly designed to do and to be as human beings. quite frankly, we're designed to be in positive relationships with one another. We're designed to love and care for one another. It's who we are as two-legged mammals. And so I think the work is really the work that was underneath the civil rights movement when Dr. King talked about the beloved community. We really have to reach out in earnest. Even in South Africa, I don't know if you've read much about the leadership there. When apartheid ended, there had to be some bridge building with the most extreme racists in order to keep that country from blowing up. And that work was done. It was done eye to eye with sincere intentionality to find ways forward together. You know, honestly, we need to sit down with the governor of Virginia, and we need to begin to chip away at the false perceptions there. It isn't easy work, but the road to healing is relational. It takes courage. And sometimes it's not us, those of us who are, you know, extremely liberal, but maybe it's someone that's more moderate, who has a relationship with someone who's more extreme, and he can get them or she can get them to listen. But I honestly believe we build the alliances. And one of our communities in the South that's doing TRHT work, they actually had what they call coffee sessions at the local coffee shops. And they invited some of the evangelicals and some who just were being very extreme. And they, month after month, they began to whittle away at these misperceptions and to build relationships. And now some of those very people are the strongest advocates for truth and healing. And so it really, it's the work of connecting and being intentional about it. Thank you for the question.
Yeah, excellent question. Is there another?
Dr. Christopher, could you speak more about how the racial healing processes you described move beyond shaming and blaming? What are the questions, processes, ecology of discussion that you believe help people connect in their common humanity?
I didn't pay you to ask that question, right? No. Let me say that over the years, the methodology that we developed, it brings people together in circles. But by the time they come together, most of the work has already been done, in the sense that you have specifically made outreach to make sure that the people in those circles would not otherwise be together, right? And so you've got indigenous, immigrant, evangelical, white, black, brown, you know, you got all these different people. And it's easy for foundations to do this because they fund so many different people, right? So, but you create a circle, and that circle is co-facilitated also by two people who are very different from one another. So we are modeling that it is possible to bridge divides. And the design of the process is grounded in breaking people initially into pairs, so there's more intimacy. But again, those pairs are prearranged so that there's a great deal of difference. And then they are, bit by bit, it becomes longer. The sharing, you know, the length of the sharing increases after maybe the third opportunity. But bit by bit, they're given prompts. But the prompts are designed to lift up our common humanity. And the prompts are designed to generate stories that align with our fundamental human motivational needs. For example, a prompt might be, share a story about a time in your life when you needed to feel like you belonged, and someone made that possible for you. So the prompts do not end in re-traumatization. The prompts deliberately invite agency, stories of agency and healing and success. So that's an important component. And so those are some of the basics. You know, we train facilitators in how to do this work. It's embodied in the book, RX Racial Healing, which is sold by the Association of American Colleges and Universities exclusively, and the proceeds go to support campus centers. We now have 72 campus centers around America that are doing this work. But basically, it's prompts that are designed to solicit stories that are authentically about our shared humanity. It's facilitation that is definitely safe and compassionate. It is co-facilitation always, and it's diverse groups coming together. So those are some of the components. And we found that if you listen to the story of 24 other people that are different from you, or 25, and you hear their response to a common prompt, somehow you begin to connect the dots consciously and unconsciously to the commonality in the human experience. And that process triggers a shift in awareness and understanding that, quite frankly, really never goes away. I hope that was helpful.
Could I follow up on that? It's fascinating and inspiring. I happened to be at a meeting in this same building on Monday, a symposium where this same topic actually surfaced. And several speakers applauded this exciting kind of work that's going on, what you described, some other examples that are happening across the country, but raised the concern, how do we bring this to scale?
Yes.
Because, you know, we're making a dent in these settings, but the larger trajectory is still very concerning. And you know, you mentioned the danger when a person who has these kinds of racist beliefs assumes power, becomes a governor, and so forth. You mentioned co-opting of terms, and I think of, you know, critical race theory, woke, and so forth. We even have a situation right now where one governor, who you all know I'm talking about, said in a recent speech that he's going to get rid of words that have political agendas, and he named intersectionality as part of some kind of agenda, which this is a graduate of a Harvard Law School who obviously understands that that's not what the term means. But he's pursuing this because he's motivated by politics and getting elected and retaining power. I believe that along with the hierarchy of human value, the other core problem in humanity is greed and you know, wanting power and wealth. How do you have conversations with people who are operating with that kind of incentive structure, who want to retain their power, who want to retain their wealth, and view this kind of dialogue as a threat to it?
Okay, I heard two questions. The first was, how do we take it to scale? And how do we intervene in situations like you described? Am I right?
Yeah, that's fair.
The scale question, I struggle with. It wakes me up every night. But I think in order to take it to scale, we're going to have to enlist the support of the three people who have the 1% that have 50% of the wealth in this country. Mm-hmm. I think we're going to need the technology industry and those who have that kind of power to see this as important to their bottom line. I mean, that's strategically, I think that's what it's going to take, you know, because this is going to take an investment and a strategic design that touches every census tract and every zip code. But I think, you know, we hope to be a part of that and to make that happen. Now, what do we do about Florida and Texas? This is going to sound a little hokey to some of you, but all of the world's great religions have some common threads. And one of them is the power of consciousness, the power of collective consciousness. Although, and as I said earlier, although these voices are the loudest and they are doing crazy things to be destructive for their own political gain, they are not the dominant voices. And so it behooves all of us to stay focused on the goal, just like they're focused on, ending critical race theory and ending anything that might speak to empowerment for women and people of color. We have to stay focused on what we're building. And we have to greatly expand the numbers who believe it's possible. The problem is we get afraid and we start becoming their megaphone. We start repeating their lies. And so I think most importantly, we have to understand what's possible in terms of transforming this country into a place that actualizes its democratic principles. And we have to continue to expand our circles of engagement about doing that. And then frankly, we have to turn off Fox News and to some measure MSNBC. And we have to start to send a message that is the opposite, a message that is about love, that is about caring, that is about kindness and the necessity of justice, not just for those who are, quote, oppressed, justice for all of us, because we all benefit if America works. We all suffer if it fails. And there are authoritarian regimes out there who really are working over night and day to try to see America fail. So one way to counter this narrative, Stephen, is to frame it as part of national security. So I know that the Institute of Medicine and the National Academy of Medicine, I know that you do work on issues of national security. Please see this work as an issue of national security as well, so that we can bring to bear the forces and the capacities that have scale capabilities. I hope that helps.
Excellent. Very, very interesting answer. Do you want to tee up another question, Ivory?
We do. And if we could take one more, the communities from our online audience, the communities I work with in Los Angeles often buy into the myths of meritocracy. Their quality of life is poor due to lack of ability and or resilience. What suggestions do you have in inviting the community to be part of this discussion?
So in all of the places around the country, the work begins, the TRHT work begins with a broad-based community coalition that is reflective of the 5 pillars of the framework. So there are representatives, for narrative change, all of that, both those who have the resources and the organizational heft, but also on the ground community folks. So they're usually, it comes to be about a coalition of anywhere from 35 to 60 people. And they engage in a shared visioning experience where they actually imagine what the future of their community, their zip code, their state, their county, what is the new narrative, right? When this work is done, what do the relationships look and feel like? How have we overcome the legacy of separation? How have we reformed and transformed our systems, our legal systems? And what does our economy look like if it embodies equity? And so these communities work together. And, if you visit the Kellogg Foundation website and even our website now, NCHE, we've recently been asked to take over the initially funded communities, and there are 15 of them around the country. And you'll see stories of how these communities bring community voice in. Now, sometimes they stop at the level of philanthropy, and I believe that's a mistake. We have to listen, and we have to engage folks who live this experience of denial of our humanity. I didn't tell the full story, but very briefly, I'll just say, when I lost my firstborn child years ago, she had a congenital heart defect. And the hospital that we took her to, first, they didn't diagnose it as they should have. It was only at her 6-week checkup that they diagnosed it. And they told us to take her home, and that maybe in 5 years, they would be able to do heart surgery. Now, of course, they knew she wouldn't live, and she made her transition a month later. But I found out 20 years later that the surgery that could have saved her life had actually been invented 25 years before she was ever born. And the deepest cut, it was invented by an African-American man. She was a blue baby. She was a African-American blue baby. And Vivian Thomas, who worked with Blaylock at Johns Hopkins, had invented the surgery that could correct that. Tetralogy of Fallot was the diagnosis. And that had gone on to usher in cardiology and the surgery of cardiology. The era we have today started with that work. But it was that lived experience of loss and that direct experience of racism, and more than others than I can count, that fueled my fire to do this work and to hopefully succeed in my lifetime. And if I don't, my daughter will probably carry on and do it. So.
Well, I'm sure I speak on behalf of everybody just to say that I'm so sorry for your loss. I know it was some years ago, but that's so painful to hear. Do we have time to squeeze in one more question? And then we'll probably have to. No, I'd like to give some member of the audience a chance.
So for our final question, Dr. Christopher, could you share your thoughts on developing community capacities? As these are not supported much by federal grants, communities are challenged to get the resources to raise voices against these structural inequities.
Community capacity. Capacity takes many forms. We sent around a series of papers that our senior scholars have written, and included in them is the paper by Alan Jenkins that describes the equity plans that all of the federal agencies have put in place. We happen to be living in a moment right now where there are more federal resources flowing into communities, and it really started with the pandemic. There are more federal resources available to communities than any of us have seen in our lifetime. And those resources have to be leveraged to build capacity from a financial sense. But I think we make a mistake if we only view capacity through the financial lens. Capacity has to be built, and it has to be viewed as this supermajority of human capacity, of people coming together. We have a leadership program at the National Collaborative for Health Equity. It's funded generously by the Robert Wood Johnson Foundation, where we work with community leaders from all over the country to affirm their leadership, to appreciate their courage, and to support them in their leadership, and to connect them with other leaders. And so in terms of capacity, I have been amazed at what people can do when they are confident, when they are affirmed, when they are supported, and they are allowed to create, because ultimately it's a creative process. And so I think those are some answers to the question of capacity.
Well, I think this has been a really fascinating conversation, and please join me in thanking Gail for sharing her thoughts with us. The program says we get a break now, so enjoy your break.
Hello, hello, and I'm going to welcome us back online and those of us in the room for our next session, understanding the social construction of race and the impact on data. And with that, I'm going to turn to one of our advisors, Jake Fidesimanu.
Talofa lava, mua lava, momoli atuele anganga whaftaimul ne avanoa. Good morning. I greet you in the language of my ancestors from the Samoan Islands and acknowledge, obviously, the indigenous people of this land, all of your ancestors and future generations as well. We're in for a treat for this panel. I'm really excited for this, and I hope you are too. This is titled Understanding the Social Construction of Race and the Impact on Data. So this is a heavy topic, but we've got heavy hitters here with us to help walk us through. My name is Jake Fitzsimanu. I work for Intermountain Health, one of the largest healthcare systems in the Intermountain or Rocky Mountain region. And I'm also very proud to be the director of the Utah Pacific Islander Health Coalition. So this topic is near and dear to me as somebody who clicks almost all of the boxes when it comes to OMB categories. And this topic today is one that hits me personally and academically, as I'm sure it does for many of you as well. I want to introduce our speakers because you don't want to look at me or hear from me. I'm just here to moderate this awesome discussion. And I'm going to introduce the panelists with some very abbreviated, and I apologize, I did have to make some cuts in what I'm going to say in terms of your bios, but the full bios are in your packets, so please go through and look. You know, we could spend this whole time going over accolades and credentials for sure. This session is really going to narrow in on race and the social construct of race, highlighting how racial and ethnic categories have shifted over time, how existing definitions have caused and continue to cause harm. And the panel will discuss impacts on diverse populations, including underrepresentation in data, heterogeneity within and identification across common racial categories, and the various purposes and sources of indigenous and tribal categories and assimilation. So first up, we're going to hear for a few minutes from Dr. Mark Hugo Lopez, who's the Director of Race and Ethnicity Research at Pew Research Center and an expert on racial and ethnic identity, Latino politics and culture, immigration, and the U.S. demographic landscape. Dr. Lopez has co-edited and co-authored several titles, including Adjusting to a World in Motion and The Future of the First Amendment. A graduate of Princeton University, Dr. Lopez served as a research assistant professor at the University of Maryland School of Public Policy and as the research director of the Center for Information and Research on Civic Learning and Engagement. Next, we'll hear from Dr. Andrew Penner, who's a professional, lost my screen. Professor of Sociology and the founding director of the Center for Administrative Data Analysis at UC Irvine. Dr. Penner received a PhD in sociology from the University of California, Berkeley, and researches inequality in education and the labor market, with a particular emphasis on racial categorization and inequality. Dr. Penner has been published in Science, the Proceedings of the National Academy of Sciences, and Nature, Human Behavior, among many other accolades. Professor Abigail Echohawk is the Executive Vice President of Seattle Indian Health Board and Director of the Urban Indian Health Institute, where she leads efforts to develop culturally relevant interventions with tribal and urban Indian communities. She serves on many boards and committees related to data justice and health equity, including the Robert Wood Johnson Public Health Data National Commission and the Data for Indigenous Justice Board. Abigail's co-authored numerous peer-reviewed articles, including CDC Morbidity and Mortality Weekly Reports, and helped start the Washington State Missing and Murdered Indigenous Women and People Task Force. Dr. Nina Ponce is a professor and endowed chair in the UCLA Fielding School of Public Health. She'll be joining us virtually today. The director of the UCLA Center for Health Policy Research and also the principal investigator for the California Health Interview Survey. Dr. Ponce is an elected member of the National Academy of Social Insurance and served on the board of Scientific Counselors, the National Center for Health Statistics. Dr. Ponce is currently the associate editor for diversity, equity, and inclusion at JAMA Health Forum, which champions better data, especially for people from marginalized racial, ethnic, sexual orientation, gender identity, and immigrant populations. And Dr. Janan Ghazal-Reid is the Sally Dalton Robinson Distinguished Professor and Chair of Sociology at Duke University. She's a Carnegie Scholar whose most recent work focuses on disaggregating ethnic groups classified as quote unquote white and examining social mobility outcomes when groups such as Arab Americans and Eastern Europeans are isolated from the generic white category. Professor Reid is the recipient of several awards and grants, including the Robert Wood Johnson Foundation and Russell Sage Foundation. Professor Reid grew up in Libya, Egypt, and the United States, where she earned her PhD in sociology from the University of Texas at Austin. So I don't know about you, but I think that's definitely whetted the appetite for the discussions that we're going to be having today. As previously instructed, questions from all of you are definitely welcome. And we're hoping to have a very robust Q&A following the presentations here. And we'll go ahead and turn the mic over to Dr. Mark Lopez.
Thank you very much. So I have a short presentation that I'd like to share with you that talks about both how the U.S. has measured race and ethnicity and how that's changed over time. The proposal actually that's up for changing the way in which we do this, that OMB has proposed after an interagency working group came up with some proposals based off of the Census Bureau's own AQE experiments. And then I want to talk a little bit about how we report out findings based off of some of this data and how we might consider alternatives to reporting that, including different measures for racial and ethnic identity. I think that because of the Census Bureau's structure, we've been kind of using the same way of approach. In fact, I might even say we're using the same approach that's been in place since about the 1970s in terms of even how we analyze data. I want to talk about those editorial choices that we as researchers make and how we can, even with the data that's already available from the Census Bureau, make some changes. So the Pew Research Center, just so that you know, is a nonpartisan, non-advocacy organization. We take no positions on policy. You might find me saying, if you ask me what should we do, I'll say, I don't know, or I will try to direct you to somebody else. But also we call ourselves a fact tank, and that's on purpose because we make no policy recommendations. Our communications team always asks us to do that. This is quite a beautiful chart, a beautiful graphic, but it's also got a lot of detail in it. And I apologize that it may look a little bit small up there, but this is literally the timeline from 1790 to 2020, showing you how we have asked about race and ethnicity in the United States over the decades. It's interesting here is that you can see that we've had a category for white, which is the blue line at the top. The reddish colored lines are anything related to Black. The yellow lines are Indian. The green lines here are Asian. And you can also see the orange lines down there at the bottom are Hispanic or Latino. The point is that we've been asking about and changing the way in which we ask about race for quite some time. In fact, just about every decade, it seems, we come up with either an addition, so let's add some new categories to the race question, or we change the labels that we use to ask the questions, or how we ask people about their identity. And this is really interesting and important because in some sense, this reflects the way the public is seeing itself. In some sense, this reflects some of the policy needs of the federal government when it comes to guaranteeing, for example, voting rights and so forth. And in some sense, this is a way in which people in the general public, researchers like us, want to know a lot more about the various diverse groups within the country. So let's have more detail than we've had before. I want to point something out here that I think is really interesting. The first is notice how these terms of or these questions have come and gone. If you look at the bottom on Hispanic, you can see that, for example, in the 1930s, there was a question added to the census then asking people if they were Mexican or not. Now, this was a survey. This was a census that was done by enumeration. So enumerators went door to door and assessing people. They might ask people about their race and ethnicity and other questions. Whereas from 1950 on, we start to have people self-identify and choose their identities in the census forms that we use. In other words, it's self-administered as opposed to done by an enumerator for the most part. But you can see we had Mexican there turned on for the 1930 census, and then they turned it off. And then Hispanic comes back in 1980. Actually, it's first tested on the 1970 census for a small portion of the entire census, but it gets turned on in the 1980 census. And then we also see the label change from Hispanic to Hispanic or Latino, or Hispanic or Latino, or people of Spanish origin. It changes and changes and changes. As a little side note, these categories also to some extent reflect federal definitions of who counts as part of these groups. Now, you might be wondering, what is Lopez talking about? When we talk about Hispanics, particularly, the Hispanic definition is actually very formal. It's actually legislation that defines who is Hispanic in this country. It's somebody who can trace their roots to the 21 Spanish-speaking countries of Latin America or to Spain. Does not include Brazil. So what happens is that people who are Brazilian in origin and indicate, yes, I'm Latino. They say, yes, I'm Hispanic Latino. They answer that question, yes, and they write in that they're Brazilian. They are then recoded as not Hispanic by the Census Bureau as part of the process of enforcing or putting into place the OMB standards for racial identification that have been in place since the 1990s. So whenever I give a talk before a group of folks who include Brazilians, I'll tell you that I usually get the question of, why don't you count us? Why aren't we included as part of the Latino population? I'm Latino. So also note that this isn't just about what people tell us in the census, but there is some backcoding that happens as well that may put the data in line with federal reporting standards on race and ethnicity. And it's that very thing that is now being considered to be changed for the next census. So how is all of this played out in terms of the data? Well, I'm showing you an analysis here that is using a set of race and ethnicity reporting standards from the 1970s. This is from the 1977 approach, and I'll tell you what I mean by that in just a little bit. But essentially, the country until 1965 had largely been a black and white country. The white population made up the vast majority of people in the United States. About 12% of the population was black starting in 1900, but you can see it stayed about the same. Hispanic, Asian, and multiracial people were either not measured or were a very, very small part of the population. You get to, though, 1965, immigration law changes and the diversity of the country changes substantially. By 2000, you start to see the Hispanic population growing quite rapidly up to 10% of the population. And by 2020, the most recent Census Bureau data that we have, 58% of the population is non-Hispanic white, single race. I'm going to be a little bit technical here. 12% is non-Hispanic black, single race. 19%, or 1 in 5, are Hispanic, 6% are single race, non-Hispanic Asian, and 10% are non-Hispanic 2 or more races. You'll notice that these are mutually exclusive categories. That's the 1977 reporting standard. And I want to come back to that because I want to argue that maybe we should consider changing that. Maybe these shouldn't be mutually exclusive categories because people can be more than one of these. And we should take that into account somewhere when we talk about outcomes. Now, speaking of changes, here's what OMB is proposing to change. Right now, the Census Bureau asks these questions about Hispanic and racial identity, as 2 separate questions. The first question of, are you Hispanic or Latino or Spanish origin? Yes or no. The second question is, what is your race? Are you white, black, or African American, Asian American, et cetera? When you take a look at that, this has been in place since the 1980s. So it's been in place for 50 years. But the proposal is to combine the Hispanic question into the race question. So there's only one question about race and ethnicity. That means that people will be asked, are you white? And then you're asked to write in your origins. Are you black or African American? You're asked to write in your origins. Are you Hispanic? You're asked to write in your origins. Research suggests that this will not change the count of Hispanics or other groups in the census. So we will get counts that are similar to what we were getting before. But one other addition is to add a category for Middle Eastern North African. Here's another case where coding changes people who indicate that they're Middle Eastern and North African, such as Egyptian, for example, or Moroccan. And if somebody says that they're that, and they've marked some other category, they're going to get reclassified into white as a category in terms of their race. There's been a movement on the part of groups who represent the Middle Eastern North African population in the United States to have a separate category. That is another proposal. And there's some changes to definitions and to technology wording and coding that are also part of this proposal. Here is what the form would look like. To give you a sense, this is what the new form would look like. This is the expanded version of it. This is what would be on the census. This would be on the American Community Survey. This is, excuse me, this is what the Census Bureau has proposed as the new form. As you can see, it looks familiar. It's not all that different from what we saw in 2020 as a census form, but it does have Hispanic as an included category here in the race and ethnicity, quote unquote, combined question. You can also see that there's a lot of check marks here. Look at for Middle Eastern North African. You can see there were check marks there for specific groups and an opportunity to write in your origin. There's also opportunities to write in origins for American Indian or Alaskan Native, Native Hawaiian, or Pacific Islander. Again, this is the proposal from OMB for a change to the way in which we capture racial identity. There is also a proposed combined question without detail, and I'm sorry, my mistake there in the headline. This is a smaller version that perhaps agencies can use on, say, an intake form or so forth. So this is an abbreviated version without all the options to choose boxes, but you can sort of select all that apply, and you can see it's essentially the top line categories overall. But that is the proposal on the part of the Census Bureau. Now, I want to step back a little bit and talk a little bit about alternatives to ways in which we might talk about race and quantitative research. So, as I mentioned before, we tend to talk about findings on race and ethnicity as white non-Hispanic versus Black non-Hispanic versus Asian non-Hispanic, Hispanic, Native American non-Hispanic. That's important, and I think that's a useful way to think about things. But we might want to consider alternatives, such as what if we allow for overlap between racial and ethnic groups? Census Bureau already has this data available. You can do what's called an alone or in combination grouping, say, of Black Americans. That actually makes the population bigger. It goes from about 42 million people to 46 million people. But it's one that includes two Black Americans who are of two or more races and Black Americans who consider themselves Hispanic. It messes with our statistical testing, but I think we can figure it out. We're pretty smart. Editorially, I think this is also something that we need to consider as a difference or as a change. We oftentimes talk about the top line findings for Black Americans. Here's what we know about all Black Americans. Here's what we know about all Asian Americans. But that masks the diversity within the group. Now, I know a lot of you have heard the phrase, these groups are not monoliths, and we should talk about these groups and do disaggregation of these groups in order to understand the nuances of stories within them. You'd be surprised that this is not something that everybody naturally wants to do or naturally does. We tend to do it a lot for white populations. We will tell you about white Democrats versus white college-educated people versus white moms, but we'll then say Hispanics as a comparison group. So disaggregation will be important for being able to tell the nuanced stories here of these groups. And finally, I think considering alternative approaches to measuring race and ethnicity is important because people aren't necessarily always thinking about themselves in these government classifications. In fact, you might even find people might say, I'm not sure, should I call myself Hispanic? But should I also mark white? Is that my race? I mean, you talk to people, there's confusion about how to answer these, but you ask them, so how do you describe your identity? They might say, I'm Mexican. So being aware that there are other ways in which people might do this, I think is important. Here's some graphics to show you about how these things would work. Here is a graphic showing you the Black American population using Census Bureau data to show you the alone or in combination grouping. You can see the single largest group is single race, non-Hispanic Black Americans. That's traditionally the group that we talk about when we talk about this population. But in 2019, that population would be about 47 million people above 41 million people. So that's a significant difference in terms of the size of the population. And you can see that the two or more races and the Black Hispanic populations are not insubstantial. They're actually substantial groups. This type of grouping, I think, allows us to tell more stories about Black Americans than just a single race non-Hispanic story, because there are many people who are, for example, perhaps of Afro-Latino identity, and they maybe we should tell their story distinctly in some ways. This data kind of allows us to do that, but that's one approach. What about in terms of how we tell the story? When you write about these groups, I would also recommend that you start with the group that we're interested in first. Let's tell the story of Black Americans in and of themselves. I'm not interested in the comparison to whites right away. Yeah, we'll do that other comparison later, but not start with white Americans are here, Black Americans are here. Here's the disparity. Here's the difference. Instead, I would say, among all Black Americans, here's what we know. And did you know that Black men and Black women are different here? Younger Black Americans say this versus older Black immigrants say this versus the US born. In other words, tell that story about the group first. This is the disaggregation. And this editorial shift is actually quite hard to convince even social scientists to consider. What about alternative measures of race? At the Pew Research Center, we tried measuring skin color, having people self-assess their skin color, and this is among US Latinos. And we found that US Latinos who are darker skinned, self-reported, are more likely to have discrimination experiences, even experience discrimination from other Latinos. So this is not about outside the Latino group towards the Latino group, but even within Latinos, there's just the Latino population, there's discrimination. This is one way that we might do this, as some social scientists have come up with. Can I advance to the next one? My clicker. What about Afro-Latino identity? I mentioned to you earlier that Afro-Latino does not necessarily equal Black and Hispanic. That's because not every Afro-Latino actually even consider themselves to be of Hispanic or Latino origin, interestingly enough. By the Pew Research Center's estimate in a survey of the entire US adult population, we estimate that about 2% of all adults are Afro-Latino. That amounts to 12% of Latino adults, but not every Afro-Latino says that they're Latino. Yet we estimate that there's about 6 million people overall who are Afro-Latino. Again, this is a group that is, I believe, understudied. And also because of the nuance of identity, the traditional race measures that we have at the Census Bureau may not capture this group. I'm going to stop there. That was a lot, but I hope that that you heard a little bit about some ideas that one might pursue, even with existing Census Bureau data, to approach analysis in a different way. And also, I hope that if you haven't already, that you also comment on the upcoming changes from the Census Bureau. The door is open for public comment, and you should certainly comment if you have any questions or concerns about the way in which they might implement these changes. Thank you very much.
Thank you so much. We're going to continue down the line. I'm sorry. I know you've got lots of juicy questions. We're going to go all the way through the panel and save our discussion for the end. So keep track of your questions there. And I will turn it over to Dr. Penner.
Thanks. And thanks, Mark. That was wonderful. And I think, does the clicker going to work? Because I think it got turned. Let's see. Yep, there we go. Okay, perfect. Because I have animations in my slides, so we're going to be saying a lot of next if it doesn't work. But I think we're good. I'm Andrew Penner. I'm here from the UC Irvine, a sociologist, and I'm going to be talking a little bit, sort of following Mark's, I think, wonderful introduction about the multidimensionality of race. I'm going to be taking that in a slightly different direction and talking about racial fluidity, right? So this is work that has been done together with Ilya Saperstein and a couple other co-authors, Jessica Kaiser on several papers, also Robert Pickett. And the question is really twofold. Let's go to the next slide. This is not... There we go. Okay. So sort of the broad research agenda is really sort of twofold. The first question is, is race a fixed characteristic of individuals, right? So I think in the sort of typical folk understanding of race that we have, you are given a race when you're born or even before you're born, right? And you carry that race with you till you die. We're going to show that this isn't the case. And we're also going to show that the changes in race, both self-reported and also how others perceive you, are going to change based on your social status and biographical events. So the sort of typical inequality story that we're used to hearing in the popular press, but also in standard social science accounts, right? You're given this race that affects the treatment that you receive in society, and this affects your social outcomes. And what we are going to show is that race, we shouldn't just think of race as an input into the stratification system, but race is something that's actually created by our systems of inequality. And so what does this look like for individuals? Okay, so it is working, it's just a little laggy. What does this look like for individuals? Here's, I feel a little bit embarrassed, but these were the data we had coming after Mark. So the NLSY asked everyone, all the interviewers at the end of the survey to record whether the respondent was white, Black, or other. So very crude categories, but nonetheless, I think informative, right? And what we see here is that the categories change, right? How individuals are classified at the end of the interview changes, and that this shifts based on whether they had experienced sort of a long spell of unemployment, right? So we don't find that it's sort of this like on-off switch, right? It seems like there's sort of a flexible propensity in how people are likely to be perceived. So that pre-unemployment, you're more likely to be seen as white and less, more likely to be seen as white, less likely to be seen as Black. Post-unemployment, more likely to be seen as Black and less likely to be seen as white, right? And it's not just unemployment that works this way, right? So we have a whole host of status characteristics that work similarly. So this is an experiment or sort of a thought experiment where we say, let's take a 29-year-old man who was classified as white in the previous interview, and let's see, what's the likelihood that they're classified as white again in the current interview, right? And so if we just look, sort of at baseline, we see that this is about 96% of the time they're going to be classified as white in this coming interview. But if this person is incarcerated, as a result, maybe has a long spell of unemployment, gets divorced, and is now, in poverty, this drops down to 85%, right? So still most likely classified as white, but much less likely than if they hadn't sort of had all these experiences. Based on this and some other evidence that I'm happy to talk more about, we sort of argue that race, we really shouldn't think about race as a fixed characteristic of individuals, right? It's maybe more accurately thought of as a flexible marker of status. And we show, this is, here we are talking about how you're seen by others, but we show similar effects in terms of how people self-report, right? And happy to talk more about that. We show this not just for, basically across all the categories we can find. We see that these kinds of stereotypes and biographical events shape how we understand ourselves and how we understand those around us. Here we are using data that were available to us, sort of a happy experiment. Or we asked the NLSY, why do you collect these data? They're like, we have no idea, but it's interesting. We're like, well, thank you, I guess. But we wanted to say, is what's going on really, can we sort of pin down that this is really causal, right? Is it the case that, oh, okay. Perfect, let's go. Okay. All right. Well, so we'll jump to the punchline. Actually, I think you should be able to, if you hover over, you should be able to play. There's a little video embedded. So basically, we have a bunch of faces that we show people with different clothing, and we track their mouse movements. This is work done with John Freeman, a social psychologist. And what we see is when you're in a business suit, even if you're classified as white, regardless of your clothing, your hand, the classifier's hand goes more directly towards white, right? And so even when the ultimate categorization is the same, we see that the trajectory, right? People are seen as slightly more Black when they're in janitorial coveralls than in this business suit. Based on this and sort of the larger body of work, we argue how Americans are racially classified by others is influenced by a host of life experiences. The processes at play across both, how we understand ourselves and how we are viewed by others, and different categories, many different kinds of stereotypes. This shapes how we see each other, even when it doesn't shape the ultimate classification that might show up in the census. We want to take intersectionality seriously, and so we show the factors that matter differ by gender, right? And so that sort of makes sense given our stereotypes and how we think race works. And also context matters, right? So for example, in high unemployment contexts where many people are unemployed, it's maybe less stigmatizing. It doesn't matter for racialization as much, right? As in low unemployment contexts. And I think that the last finding that I want to highlight is sort of the interactional nature of race. And so this is work using the General Social Survey. It's just coming out. And here, instead of the interviewer writing down what the respondent's race is at the end of every interview, the interviewer writes down what their own race is. So we have multiple measures of the interviewer writing down what their own race is at the end of each of these interactions, sometimes even within the same day. And we see that even within the same day, how the interviewer reports their own race changes and that it mirrors the respondent, right? And we sort of do everything we can to try and make this go away, but it seems remarkably constant, right? The interactions that we have with those around us shape how we understand ourselves racially. Oh, I think, yeah, I was like, there should have been one more slide. Oh, yeah, no, I guess that is it. There was another slide and it's not there anymore. So with that, I'll go ahead and turn it over to Abigail.
Thank you for these very informative presentations, and I'm going to totally throw us off. After listening to Dr. Christopher, I'm going to talk about something different than I had originally intended. So I apologize for how much I'm going to skip around on my slides because they don't make sense anymore. But sometimes that's what we need to do, is to adjust and adapt and recognize that time for truth telling is here. And so I appreciate Dr. Christopher bringing this. I'm actually going to tell you all what I did yesterday. My name is Abigail Echohawk. I'm an enrolled citizen of the Pawnee Nation of Oklahoma. I'm the executive vice president of the Seattle Indian Health Board, which is a federally qualified health center and also an urban Indian healthcare provider in Seattle, Washington, where 67% of our patient population, who we call relatives, are American Indian, Alaska Native, and 85% are people of color. I am blessed to walk in every single day to be surrounded by the strength and the resiliency of people who aren't in safe places or situations, but when they come in our doors, that shifts and changes. However, we know when they walk outside, it's not the same. So yesterday I was here to provide congressional testimony to House Appropriations, specifically on a study that I did 4 years ago. Specifically related to American Indians, Alaska Natives, and the crisis of missing and murdered Indigenous women and girls. So 4 years ago, I published the very first report ever done, the first study ever done on the crisis of missing and murdered Indigenous women and girls. However, I'd been sitting with tribal leadership my entire life as we talked about our relatives, including those of my own who had gone missing, who had been murdered, whose children were taken into the foster care system because their parents were no longer there, whose loved ones dove into substance misuse as a result of the maze of jurisdiction that allowed for our relatives to go missing and murdered with absolutely no semblance of justice, including our victims of violence, of sexual assault, intimate partner violence, domestic violence, because of that maze of jurisdiction that they weren't prosecuted. And so we published this report. It was on 71 cities across the United States, where we reached into law enforcement and asked them for the data related to missing and murdered Indigenous women and girls. And what we found was not only that was there a crisis, but it was one of epic proportion. However, we couldn't actually talk about it because they weren't collecting the data. What we found is that most law enforcement agencies, and I find this echoed across every health agency I've worked with, don't count us as significantly as being significant within their analyses. I went to one entire week where I was at a conference, and as soon as they popped up their data slides, down at the bottom it said statistically insignificant American Indians and Alaska Natives. I was told I was insignificant an entire week at an academic conference. And we find that that missing data was purposeful. So when the data was missing in this instance of missing and murdered Indigenous women and girls, it directly impacted whether or not there was both prosecution and resource allocation that is part of our treaties. All the land y'all live on, where your houses are, where you live, breathe, and work, was Indigenous land, is Indigenous land. And our treaties say that we are to have public safety, and yet we do not have it. And they use the gaps in the numbers, the small population numbers, as statistically insignificant to justify the non-allocation. We are a small population for one reason only: genocide. And when we acknowledge that, it shifts and changes why we need to think about race as a social construct, why small populations data analysis isn't taught, why it's not talked about, and why we can get by with the excuse as academics to just put the little asterisk that says not statistically significant. It provides us an excuse rather than looking at the root cause of why the data is not there. I come from a long line of Indigenous data scientists. That is where my family and my band comes from, the Pawnee people. And I recognize that as an Indigenous data scientist, that is my responsibility to reclaim that way of gathering information and using it for the good and well-being of our people, which is why we did this report. So why was I here 4 years after that initial report that resulted in 2 pieces of federal legislation, Savannah's Act and the Not Invisible Act? It's also cited in more than 40 pieces of state legislation across the country. The reason is because despite all of that, what we found is they didn't actually take any action. So sometimes we've been making the assumption that when we bring forward the data, action results. But as Dr. Christopher pointed out, just because we have the data, it doesn't undo the structural racism. One of the things we found not only in law enforcement databases, but in my work with hospitals across the country, that if they're not collecting race and ethnicity, it will actually default to white. So we actually see white as a default within data systems, which is how white supremacy has embedded itself, how structural racism has embedded itself in programming. I always think, what if in that room there was, people of color? What if there was a woman? As we think about who's actually programming these programs that collect race and ethnicity, why isn't there a checkbox for American Indian, Alaska Native? Why aren't they collecting tribal affiliation? This is what in COVID-19, my team and I termed as data genocide. Because right now we are being eliminated in the data and is directly resulting in the deaths of our community. And it is the modern day that genocide is being perpetuated against American Indians and Alaska Natives, because then the federal government does not comply with the treaties that say there has to be members. So during COVID-19, in a report we titled Data Genocide of American Indians and Alaska Natives, we found that bad numbers, data was used, census data and other numbers. And as a direct result, tribes who had large populations of people that they needed to serve received very little, and for some, no funds to address COVID-19. And what happened is people died. My relatives died as a direct result. So not only is it eliminating us in the data and the allocation of resources, but it is directly impacting the health outcomes and the deaths and the well-being of our people. However, despite all of that, there is opportunity. I'm just going to lead this kind of list of things. And it makes me think, I was recently consulted on YBRS, Youth Behavioral Risk Assessment Survey, done by the CDC, and they were looking to do an oversample of American Indians and Alaska Natives to increase the numbers because their numbers are very small. So they present the data to me, and I was like, well, why are you using single race American Indians and Alaska Natives? There is no scientific validity of using single race American Indians and Alaska Natives. And I asked them, and they're like, well, that's because that's the way we've always done it. So we need to begin to question the way that we have always done it in regards to gathering data, analyzing data, and disseminating data. The use of single race American Indian and Alaska Native very specifically goes back to old policies that the federal government had on blood quantum, on whether or not we were still Native. And their goal is they would prove that we're intermarrying or multicultural, multiracial, and then they would eliminate us and no longer have to comply with our treaty and trust responsibility. That is why single race data is used and why it's gathered. And yet most of the data you'll see put out by the CDC and other agencies, you'll see them use single race specifically, when at the very minimum, they're eliminating 25% of our population in the use of that calculation. And so we see, again, embedded racism, and that is directly impacting our legal rights as American Indian, Alaska Native people with treaties with the United States government. One of the things I also struggle with is little representation of Native people are relying on just a few, and I'm including myself in that, on those who are helping determine what data should be as we look to undo these colonial systems. And so we need to broaden our scope. I shouldn't be the only one up here all the time, although I really enjoy all of you. I know a lot of you. But we need to be also investing in the training of our people. So I'm going to close with what I told the members of Congress. There's a lot of things I could have said. When I think about the outcomes of American Indians, Alaska Natives, I really like to do what Mark talks about and just talk about who we are as a group. We'd be dead by now if all of this structural racism had actually worked. We clearly carry incredible strength, culture, community, connection. We clearly are going to make it regardless. However, we shouldn't have to struggle this hard. But when I go and I'm comparing to the white community, there's an argument, and a rightful one, that is like, when you're comparing to the white community, are you upholding whiteness? Are you saying we want the health outcomes, the safety outcomes of white America? I'm like, no, actually, I think y'all's standards are too low. You should actually increase them. I don't want the health of a white woman. I want the health of a Pawnee Athabascan woman. And that means something different than the health of an Oglala Lakota, like the one at the back of the room. It's a different measure of health and well-being. So when I measure against non-Hispanic whites, now my agency, the Seattle Indian Health Board and the Urban Indian Health Institute, one of 12 tribal epidemiology centers, all of our data that comes out now says we are measuring the outcomes of American Indians, Alaska Natives against beneficiaries of structural racism, non-Hispanic whites. I am not trying to achieve whiteness. Why we are doing our data is and we need to be blatant. And because people benefit from structural racism doesn't mean they're racist themselves. So when I sat in front of Congress yesterday and I shared this story in front of a Republican-controlled House who often don't listen, I shared this story. I work a lot in sexual violence, domestic violence, missing and murder, Indigenous women and girls. I work directly. I actually oversee sexual assault programs, domestic violence programs. And I was working with, had been asked to come to sit down with a group of young women who had been trafficked. They had been both kidnapped, they had left their homes for different reasons, and they had been trafficked. They had been forcibly injected with opiates. They had been brutalized. And their community, we're bringing them together and bringing women who have experienced similar things. I'm a survivor of sexual assault and rape that was never prosecuted as a result of the maze of jurisdiction and the way that this country treats American Indians and Alaska Natives. And I was sharing with them my journey of healing. And I was talking to them about a plant, very specifically a blueberry. So a blueberry in my community in Alaska is one of the science tells us this particular blueberry has the most nutrients. It has the most antioxidants. Where I'm from, it gets to negative 75 below zero and it gets to 108. It survives the hottest and the cold. When you go and gather it, you do it with your relatives and you create community and you sing. You sing traditional songs, and there's a reason, because there's bears, you got to be loud. And you pass down tradition and stories as a result of that. So there are also times where you just sit and pick, you're mindful, and you think about that plant and you think about our relationship with it. And I was sharing with them that I think about myself as a blueberry, that I've had to survive the hardest, the hottest, the coldest, that I've had to learn to reconnect to my family, my community. And I watched these young women walk out the doors to their different communities across the country, tribal communities who are doing the exact same thing. A conference about a year and a half later, a young woman runs up to me and she gives me a big hug and she says, "Abigail, I don't know if you remember me, but I wanted to tell you that I know I'm a blueberry now too." And we sat there and we cried with each other. And I know that it was this young woman's connection to her community, to her culture. All of the things that I'm talking about are actually seen in Western science as the impact of mindfulness, the building of cultural protective factors that prevent suicidality, substance misuse, all of the things. And our communities were doing that. And what I told the members of Congress, and I challenged them, I said, "What part of the blueberry are you?" So when I stepped down from that, I looked around and I realized that almost every single member of Congress, regardless of their political affiliation, was crying. And so were the staff, because what we had done is touch their hearts and had recognized that when we think about the impact of race as a social construct that has created inequities, trauma, the brutalization of Indigenous peoples and other peoples of color, that we can connect to the core humanity, because I guarantee every single person up there knows a young woman that they would not want to have to live through the similar things, or perhaps they knew one that had, and they wanted her to be a blueberry too. So we can bring that connection and those resources, and my agency does have a resources on best practices and data collection for American Indians and Alaska Natives that you can find on our website, uihi.org. And there is an opportunity, like Dr. Christopher said, how do we engage together to build forward meaningful change? Where do we connect with humanity? Where do we connect with hearts? And for Native people, I think it's easy for us because I'm not working in a community. I am the community. And we need to be where the people are. And until we shift into that, particularly within academia, quit studying, be part of. And if we're truly going to address the structural racism in the way that the health outcomes look for our communities across the nation, it is going to be together. It is going to be heart work. It's going to be hard. It's going to be uncomfortable, probably going to cry more than we laugh, but it is going to take bravery and it is going to take risk. So I live in a world where death threats are normal. And I think that it's important for us to recognize that as people of color, when we step in and challenge these systems, that we are taking risk. And it's really easy to write it into a report, but then what does it mean to support those who are doing this work and take this risk every day? So we can't talk about doing this work without talking about the risk, because when you're challenging systems don't necessarily like that. But we can build together our heart connection and think about how together, how big is our brave? What are we going to do? How are we going to challenge? And where are we going to build forward meaningful change?
Thank you so very much. We go ahead and queue up Dr. Ponce's slides.
Hi, I don't have slides. Thank you, Abigail. Thank you so much. I'm Ines Ponce, and thank you for the accommodation of joining you remotely. I am at UCLA, and I pay respect to the Tongva peoples as the traditional land caretakers of Los Angeles Basin and South Channel Islands. I feel like over my 30-plus career, and I was around when the Black and Minority Health Report came out, in the late 1980s, that I think I'm a health data revelator. And as a revelator, I do this in three ways: as a data producer, a data equity advocate, and a coalition and pipeline builder. So first, by producing race and ethnicity data and language data that is more granular, so that scholars and advocates and decision makers have the evidence to address unmet needs of people who are typically invisible in health data. Native Hawaiians and Pacific Islanders, American Indians and Alaska Natives, the LGBTQ plus population, and subgroups within the Asian, the Black, the Latino, and white racial categories, undocumented immigrants, and the many intersections of these identities by race, by gender, by SOGI, ableism, citizenship, and class. So my main platform is the California Health Interview Survey. I've been involved with that since 1999. It's a survey I lead. I've been part of. It's been used by scores of researchers and policy analysts to depict the experience of the general population, but importantly, marginalized, minoritized population. It is the nation's largest state population representative health survey. It's about a 20,000 annual sample. We collect information across the lifespan from children to older adults. It is the most comprehensive source of population health information on Californians. And this is important because population health surveys ask about access to care, living conditions, education, occupation, income, trauma history, piecing together this backstory that may explain the inequities in health access and health outcomes. So the root causes. How has just impacted data equity research? Well, first, I want to say that data equity is when data are collected, analyzed, interpreted, and distributed such that marginalized communities have access to and can use these data. So our impact on the body of research for invisible groups stems from these key factors. CHIS collects health and sociodemographic information for Asian and NHPI subgroups per the OMB recommendations, also Latinx subgroups, and Abigail, American Indian Alaska Native tribal affiliation, enrollment, whether in a state or federally recognized tribe, sexual orientation, gender identity, and in 2021, following the 2020 census, writing categories for the white and Black African American racial categories. We would love to collect on the MENA population. Again, as things change, then we would adapt. We would adapt the way we would collect. So CHIS uses oversampling for the Asian American and Native Hawaiian Pacific Islander. We also oversample for the American Indian Alaska Native population and the Black and Latinx oversamples in some areas in California. We conduct interviews in English and in Spanish and in Cantonese, Mandarin, Korean, Vietnamese, and Tagalog. And we recently conducted a tobacco survey of adults for two groups that have inadequate samples in probability-based survey, the Native Hawaiian Pacific Islander population and the LGBTQ population. So our values are simply put as centering equity in population surveys. And here's how. We have had explicit measurement objective to eliminate health inequities. And this started not just like the last 5 years, but nearly 25 years ago. And CHIS is co-produced by community-based partners through advisory committees, including one that is tasked with improving the value of the survey across multicultural populations. So I feel that with organizational commitment, community accountability, the measurement of race as a social construct will be more meaningful, and population health surveys will have the equity objective front and center. I also emphasize that it's not about equity versus quality, equity versus efficiency, but actually the quality of the insights of surveys or other data systems are much better if equity is front and center, because these insights formulate policies improving the population that we purport to represent and that we should be improving. But as a data producer, I don't stop there. Data equity isn't the only ingredient of health equity, but you can't get at health equity if you don't address data equity. And it has to be advocated and that it can be done. And I'm hoping some of my examples show that it can be done. The bravery is there. And our UCLA Center for Health Policy Research and newly funded Data Equity Center from the Robert Wood Johnson Foundation has been providing technical assistance and examples for other federal, state, and local health surveys grounded by the values of the California Health Interview Survey model. Our main objective for the Data Equity Center is to promote data equity by offering resources that will inform, support, and promote data systems becoming more representative, more inclusive, more collaborative, more salient with the communities that they serve. I underscore that I am an academic, but I'm an academic with roots in community organizing. Equitable data can't be built unless we build coalitions to advance better measurement of identities, life experience, and social and health needs of diverse populations. So I'm going to give some examples. We started the Native Hawaiian and Pacific Islander Data Policy Lab in 2020, started as a volunteer project that grew from linkages with advocacy organizations on getting COVID case and death data for this group, the smallest racial group in the United States. In over 20 states, the Pacific Islander population, Native Hawaiian Pacific Islander population, was grouped with Asians, so it was against the the current OMB standards. The lab was co-founded by youth and young professionals from the Native Hawaiian and Samoan communities, with staff and volunteer that now include Tongans and Saipanese, and now part of the UCLA Center for Health Policy Research. It's an important contributor to the NHPI community's COVID-19 response work by providing timely access to high-quality data. And the contributions to the community have resulted in the allocation of resources for NHPIs during the pandemic. The lab has launched also 2 NHPI data interfaces, one which captures national data sets and another for California's county-level data that identifies NHPI COVID-19 disparities. Another data interface is in progress to provide NHPI social determinants of health data for California's NHPI population and in the 10 largest communities across the United States. So we also just finalized an NHPI data policy platform that was developed with NHPI leaders across the country to capture the data needs, barriers, and recommendations for improvements in data systems to increase NHPI data equity. And as Abigail said, alongside these tools, the lab's developing, the training curriculum is really important. How can we have communities work with communities to understand some of the data assets, but the limitations? And so training curricula to help this community maximize utilization of these tools to improve and support their current efforts. So it's a valuable experience in building strong community connections, which align with the requirements for successful measurement and use of race data. Second example, a newly formed community-based organization, the Philippine XAO Community Health Association, is an interdisciplinary, intergenerational national group of amazing Philippine XAO pipeline of leaders to continue the fight for visibility in data, and when data is available, to generate insights on Filipinos, connecting these insights to informing policies, especially when in the impetus of starting this organization was not understanding what the burden of COVID is in this population. And yet we were hearing stories through media that the first death in Los Angeles County of health worker was a Filipina nurse. So in uncovering restricted data, sometimes through a FOIA, sometimes still waiting for a year to finally get this data, we access restricted data, and about 30% of healthcare workers' deaths are Filipinos, but only 3% of the healthcare workforce. And this is data from California, and it also is data from National Nurses United. So this was not knowable in public use data. So it's not just about measurement and collection, but democratized access. Academic collaborations also across disciplines enhances measurement insights. So absolutely, community academic partnerships are needed, but also within academics, silos exist. We worked with the UCLA Asian American Studies Center under the leadership of Gil G, who will be talking tomorrow, moderating a session tomorrow, to expand the metrics to capture evidence and experience and witness of hate incidents due to COVID-19, and fielded questions on these measures in CHIS 2020 and continue to do so in 22 and 23. So finally, data plays a key role in various federal funding formulas and grant making by prioritizing resources as well as informing program development. Due to emergency public health triaging of resources, place-based measures supplanted in many ways population-based measures. While arguably this is timely, the movement toward population-based distribution of resources as proxy for race-based distribution misrepresents the need of some groups that are smaller in size and not likely to be geographically concentrated. So informed by community partnerships, we are proposing constructing a new multidimensional measure, the Native Hawaiian and Pacific Islander Health Equity and Index, that may better indicate the needs of the NHPI population. So in sum, race as a social construct requires consideration of data equity. The process of applying an equity lens to the steps of collecting, processing, analyzing, modeling, reporting, and distributing data to improve representation and data access. And finally, because data for small populations is limited, these decisions have a larger impact on the visibility and representation of these populations. I leave it now next to Janan.
Good morning, everyone. I feel like I need to stand up, and I enjoy being up in front of you. So thank you very much. I really appreciate the presentations I've just heard, and I'm hoping as the last presenter that I will kind of touch on each of them. So this session is on the social construction of race and ethnicity. And that term, social construction, very rarely applies to whites in the US. So I want to sort of deconstruct who are whites and take us back in time, because I think this will tie in very well with how we measure racial and ethnic disparities, because disparities are always in comparison. So I'm not a historian, but let me start with our explicit racist policies in terms of immigration, starting with the 1882 Chinese Exclusion Act that was explicitly racist, and then followed by 4 decades of U.S. immigration policies that was really directed at anyone who was not of Western European descent. Let me repeat that. Our policies were directed so that only Western European, the Western Hemisphere, were able to immigrate. That's to the exclusion of Southern and Eastern Europe. So do I have control? I hope. I don't know what to point it at. There we go. So I want to put this into context of where this construction of whites came from, because I'm going to argue two things. That we persist in using this aggregate white category in ways that are not only harmful for measuring disparities with other groups, like groups are insignificant because their numbers are too small in comparison to whom. So it's also bad for the groups who are classified as white, who are masked when we use this aggregate category. So I start with the 1977 OMB classification system, which was changed in 97, but very little. So this is where the big five broad racial and ethnic categories came from. And I mention it because I want you to think about the historical context in which these the classification schema emerged. And a lot of it was in response to the Civil Rights Acts and needing to uphold and ensure equity and distribution of resources. So whites became the default category, and for good reason, arguably. They were mainly of Western European descent. They were arriving under free, sort of no immigration restrictions, and they occupied the highest rung on the social stratification ladder. And my colleague Eduardo Bonilla Silva talks about this privilege of whiteness. So today we still use whites as the reference category. And I want to talk a little bit and show you, hopefully convince you why that's a problem. First of all, there's growing diversity among whites. Mark mentioned the 1965 Immigration Act. That really was a watershed moment, completely changed the racial and ethnic composition of all our groups, including whites. So today we have over 100 ancestries included in the US Census. And in 1980, 55% of the total US population, not just whites, were of German, Irish, and English descent. Okay, so it was mainly Western European. And in 2019, that percentage dropped to 23%. So what happened to that group? Who's making up this group? Immigration, as we know, has been a driving force. So this next slide is busy, but I've got a pointer and I'm going to try to point this out for you. So this is showing us where white immigrants were coming from historically and today. Oh, that was not a pointer. So I see it. So in 1960, the white immigrant population was predominantly of Western European descent, and you only had 1.8% of Middle Eastern, North African descent, with 28.2% coming from Eastern Europe. Fast forward to 2019, and the proportion of white immigrants in the US dropped from Western European to 35.6%. And shockingly, like the jump for Middle Easterners and North Africans from 1.8% to 20.4% is dramatic. So there's shifts in the composition. Well, if it were just shifts in who these people were in terms of their ancestry, we could say, so what? But it also matters in terms of phenotype and in terms of the social context in which these different groups are coming from. Often politically unstable, economically unstable regions, and their reception in the US is much less welcoming than it was for Western Europeans in the 60s and 70s. So where do I get the data for these, broad claims? So I'm going to say, look, the OMB categories provide really critical data. Others have touched on this, like the need for methodological skills to be able to extract it. But if you have them, there's the ancestry question along with the race question that allows us to identify whites of different ancestral origins. So this is the current question on the OMB and the ACS American Community Study. Oops, I'm going to learn how to do this. Which, as you see, shows Egyptian and Lebanese as examples of white. And then you have the ancestry and ethnic origin. I won't get into too much detail, but just to say that you can use both of those to kind of extrapolate, if Arabs are both Arab by ancestry and in the write-in. So it's important because, look, this is just a snapshot of the diversity you can capture with these categories. So for the Middle East, North Africa, these are some of the major countries, the same with Eastern Europe. So there's a great deal of diversity in the current white category that we don't use often. And again, just to show within the Middle Eastern North African, this is pre-1991. If you looked at the MENA categorization in America, it was mainly Lebanese. Lebanese came into the US under different circumstances than have Iraqis in the post-2001 era. So all of this is by way of saying whites are heterogeneous in ways that are impactful and meaningful for inequality. The OMB revised question that Mark showed, I'm hoping to pull it out to show you more closely why this matters for categorizing whites. So the current question I showed you had I'm Libyan. I'm going to keep going back to that. Lebanese and Egyptian as examples under the white category. So there's two things to note here. This is the new combined question. You're not supposed to be able to read it. So if you can't, that's fine. What I want to pull out is this is the white question here. And what you notice is the prompts for respondents no longer have Arab origins as examples. So it's limited to Scottish, Norwegian, and Dutch. That's one thing. The second is the MENA category is way down here away from the white category. So I testified in front of the interagency working group who is working on this combined question recently. And I said, look, what happens to someone like me? A year ago, 2 years ago, if I filled out the ancestor, I would have said I'm white and written in Libyan. When I first saw this, I thought, well, I wouldn't check Middle Eastern North African. I don't really identify as such, but white no longer has a category. Like, am I not white now? So in discussions with them, one of the things that they are considering doing is making sure that it is clear that all is highlighted. Currently, let's see if I can show this. Up here, it says, select all that apply, and the and is what's bold and in caps. And this may sound so small and technical, but it matters. Testing of it matters. And it shows that if you highlight all, that people are more likely to put, for example, mark Hispanic and white or Hispanic and Black. So it's small things like this that will really be crucial for us moving forward in understanding who whites are. My argument today is this. One, if the OMB is going to continue with the revisions, which I think they should, and include the MENA category, which I think they should, we need to ensure comparability. My biggest concern is if I'm going to do a study on white disparities in 10 years from now, do I trust the comparison to 1980? Do I trust the comparison to 1990? And this is something hopefully the moderator can bring up. I was talking to Mark about Pew being a good checks and balances in terms of how they measure it to see the extent to which there's changes. Be consistent in the guidance and prompts for respondents is going to be really important. And I say all of this because we all rely on these data, whether we think we do or not. Whether you're a community organization or a data analyst, we use these data to make broad-based claims about inequality in the US. And I'm going to end with recommendations to researchers. We just need to be more mindful. So one of the things that I've done in my research is to pull out whites by nativity. We often say US-born non-Hispanic whites, and then we say, well, we took care of any diversity. We just dropped the immigrants as if that solves it. So one is paying real attention to what do non-Hispanic white immigrants look like, taking that seriously. The second is if there are questions on region of birth to also examine this, because what I'm finding, sorry, can I grab my water? Sorry about that. What we're finding is that Eastern Europeans who are mainly Russian and Ukrainian are coming over phenotypically white, but much, much difference in terms of a host of socioeconomic characteristics that we know over time accumulate to bad outcomes. And then we've got a growing number of MENA categories that are also coming in under different circumstances. So this white aggregate category, the social construction of whiteness that started in the 60s and 70s, that persists today, is no longer an accurate measure, not only for whites themselves and subgroups within it, but for measuring inequalities for other groups. So I will stop there. Hopefully I stayed within my 8 minutes and turn it over to the moderator. Thank you.
Okay. Got a couple of questions here for each of you, and hopefully we have some time. Let me do a check for some from the audience as well. But Mark, you've suggested that we rethink the editorial decisions that researchers are making when conducting race and ethnicity analysis. What do we gain from that?
We gain an understanding of the diversity within a population that we might want to focus on. So when we talk about, say, the U.S. Latino population or the nation's Black population, to just talk about that top line overall finding for here's what the situation is, or here's what the measure is for Black Americans alone, and then compare that, say, to whites, that's helpful. It's important. But within the Black population, there are differences. And some of those differences are related to origins, nativity. Some of it might be due to age, educational status. In other words, we need to recognize the diversity of these populations that we're talking about. And that's true of just about every group. I think the points you just made about white diversity are really important as well to understand, because there's been substantial changes, since immigration law changes in 1965 of the nation's white population. All of this is to say that the editorial decision to change our focus and to tell the within group story is an important one. And I might say it's something we should do first, as opposed to starting with the comparisons, the big top line comparisons across the 5 or 6 major racial ethnic groups, depending on your data.
And along with that is combining the Hispanic / Latino, if combining the race question, I mean, is that going to impact what we know about Latinos in the U.S.?
It'll be interesting to see. The Census Bureau's own research suggests that we won't lose a count. So the count of Latinos will be unchanged, at least statistically speaking. There is concern about losing 2 things, though, among scholars, which is first, the detailed origins of Latinos. Some people may not mark the Hispanic box, and may mark someplace else and therefore not give us their origins. But before, with a 2-step question, they would have given us both, yes, I'm Hispanic and here's my origins. The second part of this is, because Hispanic is now combined with race, we may not have the same racial profile of Latinos that we have now. That's important because Latinos, too, are diverse, and racial identity is distinct from the countries that they come from. It's not the same as here in the United States. At the very least, it's good to know something about that racial distribution within the U.S. framework, but we also will lose that more than likely if we don't have the detailed race breakdown, and not everybody's answering a racial category that might just mark Hispanic on that combined question, and then we don't know about what their racial identity might be.
Thank you for that. Yeah, that was interesting to me, as my wife is from Brazil, and my kids also then have that dynamic, right? Mm-hmm. And arguments not arguments, but discussions among her family about whether they are Latino or not, or what do they put in these forms, and the recoding or the additional coding on the end it plays in really heavily. So no, appreciate that very much. If I can read my own handwriting here. Let me check. How about for Dr. Penner? What are the implications then of racial fluidity when it comes to inequality?
Yeah, thanks. That's a great question. I think oftentimes we think about racial fluidity as being liberatory, right? Like, oh, if individuals can sort of pick their own race, like it's great, like it'll all end well. But I think it's perversely what we find is the opposite, right? So if we sort of think about, data as, I think others have mentioned, it's sort of, about power and race, certainly about power. When you have individuals shifting racial categories, right, being reclassified based on status and things like this, individual fluidity actually serves to reinforce group boundaries, right? So if we take all the rich people and say, like, we're going to reclassify them as white, that's going to change what those disparities look like, right? And so far from actually sort of being this, kumbaya, we all sort of come together moment, it actually serves to separate us and divide us and recreate systems of racial inequality. And I think that's, it's one of those things, like a lot of social science, like it feels very obvious once it's said, but it was not obvious to us until we saw it.
Thank you. A question for Abigail. You talked about the invisibility of American Indian and Alaska Natives and data genocide. Specifically, that term is very striking to me and I think very applicable, very descriptive. And you also mentioned the excuse of then not having to uphold trust or treaty relationships. Can you go maybe a little bit more into that or provide maybe an example or two of how that's currently playing out?
Yeah, sure. Like the example I gave it was the CARES Act allocation. It's in our data genocide report, and it really specifically goes into who received resources and who didn't. When we think about the law enforcement example that I gave, we actually find that there is a lack of investment. And actually, there was a study that was done that found that the Department of Justice and the FBI, who are the ones who prosecute crimes on reservations as a direct result of being in a government-to-government status, that they would decline up to 67% of the cases brought forward to them, not because they weren't ones that could be prosecuted. It was because of lack of resources. And if you can't see me online, I'm doing it in quotation marks. And that lack of resources is directly related to whether or not the data existed on both the number of crimes, the number of people, and whether or not they were being held responsible to upholding the treaty and trust responsibility. And again, as we talk about the invisibility, and I really appreciate you talking about the diversity within white Americans, but it's also really important for us to recognize when we talk about race and racism is that you cannot be racist against white people. It doesn't exist. You can be prejudiced. You can use stereotypes. You can give unequal resources as a result of where they're coming from. You cannot be racist. And so when I talk about the way that we compare data, when we talk about benefiting from structural racism, is white people benefit from the power structure of racism that gives them access to resources regardless of where they originated from. But the experiences of my son walking through a mall is different than that of somebody's white son walking through the mall. My experience of my 13-year-old son interacting with the police for the first time because he walked through a white neighborhood is different than somebody's white son walking through a neighborhood. The same with the difference of a Native woman who's giving birth as opposed to a Black person birthing or a Hispanic Latinx person birthing. And so as we think about the power constructs, and that plays into both the invisibility because that power dynamic doesn't want us to exist. It doesn't want to give resources. It doesn't want to acknowledge our treaty and trust responsibility. And it doesn't want to acknowledge the structural racism that has inhibited the ability for us to reach the health and well-being that we had prior to settler colonialism. And so we have to be cognizant of how these power structures are directly related to the health outcomes and where data plays into that. And again, I believe in data. I worked in academia for a long time before I left it. Well, I'm still in it, I guess, just in a nonprofit setting. And so it's important for us to do, and we were always data gatherers, but what does that mean to apply our tribal sovereignty? And that's part of it too. Indigenous data sovereignty, and my some dear friends who have been working on that. I'm part of the Indigenous data sovereignty group here in the United States, is that our treaties say we have the ability to govern any bit of information that comes out related to our people. So what does that look like in practical application? That means a researcher can't come onto tribal land and do research or publish anything related to that research without the explicit permission of those tribal communities. The same is happening in the urban Indian communities, and we're having conversations nationwide for what that looks like for other Indigenous peoples who may not have treaty and trust responsibility, again, because of the outright racism and the attempting to take our resources, whether that be land and I also believe people. So all of those power structures come into play, but there's an opportunity right now around Indigenous data sovereignty and our ability to apply our treaty rights and the legal laws that exist for us to not only govern what data comes from our communities, but how it is shared and what it is used for.
Excellent, thank you. And as a follow-up, just interested, some of us in the room have served on the National Advisory Committee for the Census and other committees that frequently address or try to improve self-response and those type of things with the census. When it comes to ethnicity, I guess, descent, genealogy versus tribal membership. I mean, there's all these different dynamics there, but I think one thing that we frequently encounter is that the perception or the reality, right, is that ACS or the Census Bureau or other federal agencies will rely on the census data, even if it's incomplete or inaccurate, over data that's actually from tribes in tribal jurisdictions and in the nations. Can you talk a little bit about your take on that?
Yeah, and so it's another one that's currently under consideration from OMB as to whether or not and to include the collection of tribal affiliation or community attachment. And so I am a strong believer in collecting tribal affiliation. That is not tribal enrollment, and at no point should the federal government or any agency outside from a tribe themselves ever be collecting tribal enrollment, because it is only under their purview as tribal nations to determine who is a member of their federally recognized tribe or state recognized tribe. Tribal affiliation, when we do, so I have worked on projects where we do data linkages, where we look at, okay, this is what was gathered. What we find more often than not is that I know there is some questions about whether or not, Ancestry.com, 123andMe. Also, those aren't good science. Let's just throw that out there. But people using that and be like, well, now I'm Native because it says I'm 3% North American, Native American. And so there is this belief right now that folks were like, well, that must be being used in a way that is inflating numbers. But when we actually do data linkages, what we find is that we're still seeing a significant underreporting. In fact, some studies have shown up within vital statistics, more than 44% racially misclassified American Indians and Alaska Natives, regardless of what could be seen as that effect of this bad science that's coming out and people thinking that they can claim ancestry that they don't have a cultural community connection to. And so those data linkages and vital statistics have shown us, and again, within other data sets, that that isn't something that's actually impacting. We still are seeing an underreporting. And then for tribal communities, they have, I have some partners who link their tribal data again to large national data sets, and they continue to find an underreporting, but they are the only ones who can determine what tribal enrollment is. When we collect tribal affiliation, that allows us to sort down to, let's say, Pawnee, my tribe. And then my tribe could then do a data linkage that would be able to look and see and identify tribal members and create correct counts. So that collection of tribal affiliation is very important. The community attachment one right now from within the tribal communities that I work with, both urban and rural, is they're more comfortable with collecting tribal affiliation than whatever community attachment is, because it's seen as a little loose.
We knew this was going to get heavy, didn't we? Great stuff. Nina, as you emphasize that community collaborations are really key in constructing race. If you're not from a specific community that's being researched, or if you don't necessarily have a background maybe in community organizing or engagement, what do you think about having to have some kind of a mechanism to broker relationships between researchers and respected community leaders, or vetting trusted researchers? I mean, what's your opinion there?
Yeah, thank you, Jake. And I wish I was there because I wanted to follow up with Abigail on some of the measurement issues, but I think that's where there's an awareness of this community-centered approaches, but we have academics that say, I really would love to work with communities, but I don't know how. I know we have community organizations that come to me and say, well, who else is trusted? So I do think some kind of broker meetup way, and maybe we can use the national academies, because it's the process of the networking and the vetting is a start, but also you don't want it to bias it, towards the researchers that are maybe scientifically curious, but not necessarily part of the community that, or not even like members of the communities. Part of it is a pipeline problem. So you do want community, as Abigail said, the data piece is a community piece. And so researchers and community folks should be the ones producing it. But in the interim, as we built that pipeline, I do think there has to be some kind of health data equity network. And maybe that's something national academies can do. I know my colleague, Ray Samoa, is thinking about doing this through the White House Initiative on Asian American, Native Hawaiian, Pacific Islanders.
Thank you. Also interested in hearing your take, because you mentioned that targeting resources and policies using location-based versus population-based obviously isn't effective at addressing inequities. Can you talk a little bit more about maybe some possible solutions or suggestions in addressing that dynamic?
Yeah, thank you. I mean, I think this gets at more of, like the use modeling techniques that get at these multidimensional measures. And for example, in California, we have a Healthy Places Index. And because of Proposition 209, which is don't use race and ethnicity for allocation of resources, there is an input to this multidimensional index does not include race, ethnicity, or language. The Social Vulnerability Index does have a dimension on race, ethnicity, and language. And then the Office of Minority Health has a Minority Social Vulnerability Index that further disaggregates the race, ethnicity to the 5 OMB race and ethnicity categories, as well as the top 5 languages spoken in a county. So I think that that's the way of getting at some of the granularity in these indices that are really important because, in California and across the nation, in California, they use HPI, and in other states, they use the SPI in targeting resources, like where to put where to put the CARES money, where to have the vaccine pop-ups, where to, have deploy outreach in certain communities. So the problem with that is for smaller populations, for American Indian, Alaska Native populations, Native Hawaiian, Pacific Islander populations, and also in our analysis looking at Asian populations in California, is that these one-size-fits-all geographic measures then in targeting, say, the poorest, quintile, the sickest areas, miss populations that are in need, that do not necessarily cluster in these multidimensional measures, largely socioeconomic, that get at what's a healthy place and what's a sick place. So I do think that we need to evaluate these geographical measures on how well they perform for smaller racial and ethnic groups. And as I said, there's also these intersectional experiences that aren't captured in these multidimensional measures. And then, as I had mentioned, and I do absolutely, agree with Mark that it's changing it's the editorial shift, it's the narrative shift, which I know Gail Christopher talks a lot about. It's this narrative shift of looking at what's going on within communities first versus comparative. So with that, that's why we propose doing the Native Hawaiian Pacific Islander Health Equity Index. So a specific index for a population that is overlooked and may actually be harmed by looking at these one-size-fits-all index.
Thank you. A question for Dr. Reed. You've compellingly argued that whites should no longer be treated in the aggregate and in terms of research and policy. You've also showed the current census form and the proposed, and do you or can you describe, or do you have an idea for an alternative approach of how that could be done ideally?
Yes, so thank you. And I'm glad I had that question, because I also want to make clear, this isn't an immigrant story. I'm very aware of in DC and all of the conversations around immigration policy. It's not just about the white immigrants who are arriving now. That's not it. It is also about white immigrants who came before and their second and third generation offspring. So one way that we can do better is if we are trying to address disparities truly, we would look at the subgroups who are most in need. And to the extent that we have either their ancestral origins and or their place of birth and or language. I mean, especially for MENA, the Arabic, for Arabs, Arabic it's not like the Spanish category. Do you speak Spanish at home, which is, more complicated. So I think that we could do a better job, at least of acknowledging who it is we're studying, because we don't. And Mark's example was perfect, like Democratic moms and, Republican whites. It's that phrase alone is disaggregating whites by, party affiliation or gender, but it's not complicating who the whites are to begin with. And that's really the message I'm trying to push home.
As you're speaking, I'm kind of seeing a thread here in my mind in terms of a question about data systems and data collection when it comes to fluidity. And so I guess I'll just open this one up there, but what are to anyone, what are the implications then of racial fluidity when we're focusing so hard on accurately categorizing individuals and groups and allowing them to self-respond in the way that they identify? But if there is fluidity and that can change, how does that? What are the implications for that comparability that you were talking about when we change categories systematically? What about when we change our own expressions in how we respond to forums and those type of things?
Do you want to take it first?
No, that's a great question. Anyone who uses the census tries to avoid it at all costs because it is self-response. And so to the extent that we continue to use the same data sources, this is where the consistency comes into play, because in absence of being able to measure incarceration, or, because obviously the census and others are of the civilian population, in absence of that, at least having consistency across so that you at least know that if you're biasing it, you're biasing it the same way over and over again. That's not a great answer for the fluidity question, but I'm going to kick that to Andrew.
Yeah, I mean, I think a lot of our approaches to policy and data collection are based on folk understandings of race, which just don't reflect reality, right? And so we want to fix race so that we can sort of address these disparities, and we have to fix it. And there are even scholars that say, like, you can't let people change their race because that's going to mess up my model of how to fix racial inequality. And I'm just kind of like, well, you got to meet people where they're at. I mean, it feels it's a very different example, but it feels sort of similar to sort of the data genocide, right? Where it's like, who owns the data, right? Like how do you sort of think about, what this is, and do the data exist to serve the researcher and, to make the world a better place? I mean, we think that that's a thing that we hope we can use data to make the world a better place. But I think, understanding that data are sort of fundamentally about power, right? And are part of a system of racial power, I think is really key to sort of thinking through, how do we think about racial fluidity and other sort of challenges, around multidimensionality of race? Is it how you self-report? Is it how others see you, right? I think for most health outcomes, how you're perceived by others seems to be a stronger correlate of inequality. And so, thinking through sort of all of that complexity and multidimensionality, I think is important.
So Jake, can I give some perspectives on that?
Sure.
So fluidity could also be an artifact of bad prompts for data collection. And so this is where getting at the disaggregated identity. So, for example, I have Filipino American friends that think they're Pacific Islander and or identify as Pacific Islander. And so part of it is because of the prompts that we have. So I do think part of it is that as we get more granular and have more, acknowledging the heterogeneity and identities within these aggregated groups, that's a measurement piece that we can get at. Of course, it changes. And we did a survey where we asked race in the beginning and then race in the middle of the survey. And yes, there were folks that changed, depending on the context, because the second time we asked was centering it on experiences of unfair treatment. So I do think that that's one piece is that we got to do better in terms of acknowledging the identification opportunities, just because that's partly where the fluidity, could be one piece. And the other is in terms of, Janan's concern about bridging over time these measures that, that we may be changing, that I do think that there has to really be a concerted effort, an agreed effort on the roll-ups, on where these, where identities can roll up so that we can bridge. And I have to say it here, because this is like ringing around several rooms I've been at, is that, for example, the Hmong population are in the roll-up in the census is under East Asian. And yet in talking to community leaders, they strongly believe that the Hmong population should be rolled up in the Southeast Asian category. But again, these decisions, we're trying to figure out when were these decisions made? Who makes up these decisions for roll-up? So that's really another important piece on the identification and the data to power data and policymaking.
I just want to add in a piece of the conversation. For American Indians and Alaska Natives, we're actually not considered a racial group within the United States. We are a political group. And so I suggest, if everybody has not already read The Political Determinants of Health by my friend Daniel Dawes, an incredible book to read, although I think he needs to have a whole chapter on Native people because he's go into it as good as he could, but good guy still. Is that it really talks about where and how the political components of health disparities have been built through policy. So American Indians and Alaska Natives, because we hold treaties with the United States, if we are enrolled members of federally recognized tribes, we are considered a political entity. And with that comes very specific rights. So when we think about gathering data for folks who are not governed under that political entity as a result of colonialism that tried to cut our family ties, limited tribal enrollment, or eliminated, according to the U.S. government, tribes completely, although they still exist. We want to be doing that in a good way that is including tribal affiliation and the opportunities for them to identify themselves. I will say one of the things I struggle with in my own clinic is that it is at times, and not at times, almost all of the time in the mainstream medical system, unsafe to identify yourself as a person of color. So I will have people who come into my clinic who I've known for decades, who are Native, and they will mark American Indian, Alaska Native. We use an EMR system, electronic medical record, that connects to other hospital systems, right? They go to big hospital system and they identify themselves as white. They did not do that because they identify as a white person, but they did it to protect themselves, because if they felt they had the opportunity to pass for white, that perhaps, and actually we know from the research, they receive a better quality of care. And so there is also fear set within the system that impacts the racial fluidity in the way that data is collected, because people will identify themselves as white, particularly for my community, because it actually protects them and gets them a better level of care within the healthcare systems, within other systems. And so we also have the other side of that dynamic, and we want people to be able to, again, they should be able to identify for where they are, but it is not always a safe thing to do.
I have to apologize, family. I lied to y'all. I said there'd be time for your questions, but we are at time, and this was fabulous. And you can catch all these fabulous folks at lunch or during a break with your other questions. But please join me in giving a very, very, very hearty round of applause for our guests today. Please.
Can you answer a question in a chat?
Yeah.
I think you can in the Slido. If you click the link and you see the questions, you can respond in Slido, just as another comment. Oh, you can't? Oh,
okay. I can see the question, and it's a really good question to ask Mark. Can I just...
Can folks bear with us for another 10 minutes? Okay,
yeah,
we're going to
it's a really good question. So I actually want to hear what Mark says about this. Do you see it, Jake, or do you want me to read it?
I don't see it.
Okay, I can read it. How do you think OMB's, this is for Mark, How do you think OMB's proposed changes to combine a race and ethnicity question will impact the count, though, of Afro-Latinos? So you talked about Latinos in general, but what about for Afro-Latinos?
It's a great question. At the moment, I think that even though the census products do measure people's racial and Hispanic identity, and we have an estimate of the size of the Black Hispanic population, that is not necessarily equal to already the Afro-Latino population. Yes, some of those folks may identify as Afro-Latino, but there may be people who didn't say they're both Black and Hispanic in the census data collection that would if you asked it in a different way, might self-identify as Afro-Latino. So I think we're already not really well measuring the size of and the characteristics of that population with existing government data sources. How might this change this? It's possible that we might have fewer people who will say they're both Hispanic and Black because they might just mark that they're Hispanic and not indicate that they're also Black, or the other way around. But I would say already we have limited data with government sources on the Afro-Latino population and need to do more to understand that identity.
Okay, and Dr. Chin?
Marshall Chin from the University of Chicago. A question for the panel. The multiracial category, how should we be thinking about the multiracial category for a project on structural racism where the current papers are divided by the traditional OMB categories?
A multiracial category alone that does not collect the individual identities is what I call a trash data category, completely meaningless. And so if we are going to be, and we need to be collecting all identities, folks need to have the ability, and we need to be disaggregating the data based on the identities that they identify for themselves. So again, whenever possible, my organization publishes data related to everybody who identifies as American Indian, Alaska Native. And we are, along with Pacific Islanders, one of the largest growing multiracial groups in the country. Again, our connection to our communities, to our culture, and to our political status are what make us American Indians, Alaska Native. My kids identify as Filipino, Mexican, and American Indian, Alaska, and they're also Alaska Native. So I want them to have the opportunity to identify with everything that makes them a meaningful part of this community in this country.
Can I add to that, please? So I think it depends on your question too, what you're trying to do. And this gets up to the roll-up part that Nina has mentioned. So if you're just I think it's valuable in some sense, like changes in the percent of the population that identifies multiracial. But if you're trying to actually address disparities or things within that, then to Abigail's point, it's not really telling you a lot. So I think it really matters as to what your project is attempting to do.
Yeah, and I might add that that the multiracial category, as you mentioned, Abigail, it's a grouping of a whole bunch of different folks. I'm not sure if I would think of them as a political group, for example. I'm not sure if I would think about it as a group that has the same issues in mind. So disaggregation is important here, I think, for understanding the two or more races group of Americans.
And I'll have Anna Ricklin with our last question.
Thank you. I'm Anna Ricklin with Fairfax County Health Department. We have a growing population of Native Americans from Central and South America, and they are folks who don't speak Spanish as their primary or maybe even speak Spanish at all. And I'm wondering how we're thinking about counting those people to meet their specific needs. And I'm sure we're not the only locality that has this growing population. They're not Native American in terms of having treaties with U.S. government, but they do consider themselves Native American, from what I understand.
That's a really good question, and we've had a lot of conversations. So when you use the category American Indian, Alaska Native, it needs to specifically be pointing to those who have those legal rights within the United States, and it's actually policy language. So I work in policy, you have to use that language, but that's why the use of other terms such as Indigenous, Native American, and making sure that you have clearly defined what that means and how you're categorizing that is really important. And so the other thing, as populations begin to, shift and move, how we adapt our data systems to them is absolutely what community engaged work means. And we need to ensure that we're properly counting as folks do shift and move. People are always saying American Indians, Alaska Native are transient. It's like transient. We're migratory. We've always been migratory. And so even thinking about the words that we use that I consider to be violent and harmful when we talk about populations who are migrating to different places, and the way that we adapt and shift and change. And so that is an emerging need that you're talking about. And the current work that's being done on that is to say Native American or, native to North America, native to South America. But it's not confusing it with the political designation of American Indians and Alaska Natives.
My guess is they're being nested under Latino or Hispanic currently?
They could be at the Pew Research Center. We do ask people if they consider themselves indigenous by giving examples. Are you Mayan, Quechua, et cetera? And maybe about 15% of the adult U.S. Latino population will say so. The Census Bureau, though, has also published a tabulation based off of people's responses to the race question, indicating whether or not they're one of the indigenous groups from the Americas. And so that is also something that the Census Bureau has done differently than they used to do. It was done for the first time, I think, with the 2010 census. We learned that, but I forget if they wrote it in on the American Indian Native, Native American, Alaskan Native question, or if they wrote it in on the Hispanic, Latino, the Spanish origin question. I forget exactly where it comes from.
I posted the response to your question in the slide deck. It technically they are under first. Indigenous and Central American Indians are classified under American Indian, Alaska Native, and that's a conflating problem. So it's a problem. And also some Asian subgroups are classified under Native Hawaiian, Pacific Islander. The census and OMB has to do a lot to clean up their methods.
Yeah, and I'll give you an example of how that harmed us. And so during COVID-19, when the vaccinations were released, there was a individual who put out a he published and got into all the Native American Indian Alaska Native media saying that the Johnson & Johnson vaccine very specifically did not work for American Indians and Alaska Natives. And it caused huge uproar. It was very difficult because we were already struggling to get people vaccinated. And what he did was use bad data, exactly like Miley was talking about, that also included South Americans and other identities. And he used conflated numbers. And again, let's just add in, he did very bad science. That was a whole nother issue. But when he used those conflated numbers, it did make things look like it shifted within the information that Johnson & Johnson had put out on the efficacy of their vaccine at the time. And so it is a problem and one that we're consistently struggling with. And the question is in the American Indian Alaska Native one right now. And it is one that we're consistently working to correct because, again, we want to get the resources and we want to understand what is happening in different populations appropriately. And so it is often used inappropriately in this instance, ended up being something that very drastically harmed the American Indian Alaska Native community during COVID-19.
And I would say that the Census Bureau's approach may also be an underestimate of exactly how large this population is.
So thank you for giving us that additional time with our speakers. Thank you to those that are joining us online. I'm going to ask my colleagues to put up our closing slide. Just as a reminder, this does conclude the open session portion of our meeting, but we will be meeting again tomorrow from 9 a.m. to 12:10 for the second day of this meeting. So we look forward to having those of you that are online joining us online and those of you in the room returning to join us for that meeting as well. And we'll put that slide up and we'll close ourselves out. So thank you so much. And could we give another round of applause to our speaker panel here? Hello and good morning and welcome back to day 2 of the Culture of Health Program's stakeholder meeting on impact of systems on health equity. We're looking forward to another very engaging session today, several sessions today. And we're excited to have you join us again here in the room and those of you that are joining us virtually. So I'll go ahead and get us started. Next slide, please. Again, as indicated yesterday, we in the Culture of Health program do like to acknowledge that we gather on the traditional lands of the Anacostan and the Piscataway people. Past and present, we honor with gratitude the land itself and the people who have stewarded it throughout the generations. We honor and respect the enduring relationship that exists between these people, nations, and to this land, and we thank them for their resilience in protecting this land and aspire to uphold our responsibilities to their examples. As we engage in our conversations today, similar to yesterday, we invite you to participate via Slido by either going to the slido.com website and entering in the event code 335-8660, or using the QR code that's on our screen. And then for those of us that are joining virtually, you have the Slido option right at the bottom of your screen. I'm delighted again to welcome you all to this conversation, and I'm going to invite my colleague, Dr. Kimber Bogard, up to the podium, who will be offering some welcoming remarks and recapping from some of our conversations from yesterday to kick us off and inspire us in our conversations today. So Dr. Bogard, thank you.
Hello, good morning, everybody. It's great to see you. Morning. It's great to welcome also our guests who are online. So welcome to you as well. So I had the very challenging task of summarizing the entire day yesterday in about 5 minutes. I can't guarantee I will stick to 5 minutes, but I can guarantee that I will give you an overview from my perspective of what happened yesterday. So we heard from Gail Christopher, and what we learned is we learned about racial healing and a transformational framework. And we heard what is needed as a supermajority to work together across diverse lines to see community or commonality in our humanity and to eliminate the current hierarchy of human value, which is humanity theft, in Gail's words. We need narrative change. We need racial healing and relationship building. We need to tackle structural avenues that maintain this hierarchy. We need to do true transformational work. We need data to drive a new narrative. We need to leverage media to change that narrative through a massive campaign that engages everyone as human beings. We learned the anti-racism framework is important, but what are we for, not just against? What are we creating? What is new? What makes a culture? What are the things that we hold most dear? And how do we create a vision where everyone is valued equally? We also learned racism is an economic and a national security issue, so it should concern everyone. We learned that the loudest voices are not the majority. We learned that over 40 countries have been through a reconciliation and healing process, but the US is an outlier and not on that list. As a colonial power engaged in 4 centuries of creating and embedding systems that allow denial to be perpetuated. The denial of humanity was barbaric. The self-image of America today denies the atrocities and denies humanity. We need to deal with these atrocities and we need to begin healing. This is another hidden story that Gail alluded to that shows love, coalitions, the abolitionist movement, the Underground Railroad, and how people came together to overcome fallacies. And this is the story, Gail says, that will show us the way. We learned the road to healing is relational. We need to see eye to eye and chip away at false perceptions. We need to do the work of connecting, but in an intentional way. Next, we had a panel that was moderated by Jake and joined by several of his colleagues. And there they talked about the social construction of race and the impact on data. We learned how racial categories shifted over time by the US government from 1790 to 2020. We learned the pros and cons of coding changes proposed in OMB categories and race reporting standards. Combining Hispanic and race questions into a single question is one thing that they discussed, and adding a response category for MENA as distinct from the white category. Also, the potential to write in origins for different groups. We also heard about a potential alternate measure of race, which would be identified by skin color. We learned about racial fluidity in the US by self-assessment and also assessment by others. We learned about data injustice from our colleague, Abigail Ecohawk. She said, there's no data collection on missing and murdered Indigenous women and girls. These are too small of sample sizes. They have statistical insignificance. They're a footnote in papers. What is that telling people? tells people that through data, they're insignificant. Are they a footnote, or are they not important enough to even have their data collected at all? Why is this important? Why is this question of data important? It's important because we learned it drives resources and allocation of resources in places that need them the most. But sometimes they go to places that need them the least. This is, as Abigail Ecohawk calls it, data genocide for American Indians and Alaskan Natives. So we must reclaim gathering of data and information for Indigenous peoples. We need to focus on strengths in culture, connection in health, and well-being. And by the way, why is white the default? We measure outcomes of American Indian and Alaskan Natives against non-Hispanic whites instead of health as defined by the American Indian tribes. Why is that? We then heard from Dr. Ponce, who said people are invisible in data systems, and she's working to make their data and everyday lived experiences visible through her work. We need to center health equity and data equity to be representative, inclusive, and salient for communities. The Native Hawaiian and Pacific Islander Data Policy Lab was actually started and created and began by advocacy groups to have quality data during the pandemic. So this can be done. They're a small group. They're not an insignificant group. They're not a footnote. Then we heard from Dr. Ghazal Reed. When groups are defined as too small, she questioned too small for what? What about ancestry and ethnic origin in addition to the race question, which would allow us to provide critical information about the white category and immigration patterns over time? The social construction of whiteness is no longer accurate, and it masks inequities among subcategories of people by origin, nativity, age, and socioeconomic status. Next, we heard from our author groups who actually presented some of their outlines and some of the directions they were going to take with their papers. I don't have time to go into each one of them. It's quite a large series, but I've collected some of the cross-cutting issues that I heard. US imperialism as a system and the macro context within which structural racism has happened and allows to be continue to happen. Government and inequity, the hand of government in perpetuating inequality through segregation laws, military bases, for example, in Puerto Rico and in the Pacific, systems of exclusion, like through taxation policy and school funding, health system financing, incarceration as a system of exclusion, and racism as a system of exclusion. Multiple racial and ethnic experiences and intersectionality, especially immigration to the US and the different kinds of treatment that different groups get when they come upon our shores. Othering and marginalization, masking of diversity within groups. The impact of racism on health for groups is deliberate, and it's operating as a system was precisely designed. It's not by mistake. Violence and traumatic stress, it cuts across all of the groups. Racism as a root cause of disease and how structural racism works to actually harm health. Addressing racism is for everyone's benefit and interest. Erasure of childhood for Black children, but also others across other population groups. Through schools and the juvenile justice system, the school to prison pipeline impacts the future of these populations. Storytelling and narrative to couch the data and the importance of that. And then finally, I'll end on an up note, which also as a cross-cutting theme across the papers is the importance of community, solidarity, strengths, and uplifting culture. There's one thing that really struck me yesterday. So in closing out our meeting, we heard from Tipiziwa, and she stimulated my own thinking. And she made a comment that made me reflect on it basically for the entire evening. And what I concluded is that it is the job of people who benefit from white supremacy and structural racism and the hierarchy of human value to give the message. It's our job to activate our power in ways that break down the system of oppression, marginalization, and dehumanization. Thank you.
Thank you so much for those powerful remarks, Kimber. It's now my pleasure to invite Dr. Julie Morita, who's the Executive Vice President of the Robert Wood Johnson Foundation, up to the microphone. Dr. Morita is also a Culture of Health Program Advisor and a strong partner in this work. So thank you, Dr. Morita.
Thanks, Ivory. Good morning, everyone. Thanks so much for that warm welcome and all the kind words that people shared about RWJF yesterday. I was sitting in the room kind of blushing because you all were referencing us so often and so nicely. So I really appreciate that. I really want to give a shout out to Ivory and the team for pulling this convening together. It's really been fantastic and really want to acknowledge you all for doing that. And I want to thank the advisors and also you all the authors, because you're spending a lot of time on this with us today, but I know that all this work will continue on for weeks to come. Just really appreciate all the effort that you're putting into this. I shared Kimber's sentiments about the power of yesterday's sessions, and really, I can't believe the notes that you took because you did a phenomenal job. I was trying to pour through my notes as I was preparing for this today as well. I could not have done as nice a job as you did. It was just wonderful. I did also leave the meeting feeling very inspired, very motivated, and convinced that this paper series is really necessary. And this group is the right group to be doing this critical work. These papers can help shift the narrative away from the hierarchy of human value towards solutions to address structural racism that's driven the long-standing health inequities that we have in this nation. Today, we have the opportunity to go deeper into the solutions and what we need to move to action. What I want to do a little bit is talk about, so why does RWJF care about this and why are we funding this? So talk a little bit about our journey to how we got here. Our vision for the Robert Wood Johnson Foundation is a vision we share with all of you in this room and online. It's to achieve a national culture of health rooted in health equity. And that means a future where everyone in America has a fair and just opportunity for health and well-being, no matter their race, their ethnicity, or their class. And while RWJF's work has always been rooted in a vision of health equity, the last few years of the pandemic and the movement of racial reckoning have crystallized our understanding that there are policies and social practices that privilege some and disadvantage others. We realized that we needed to be explicit about structural racism being a persistent and pernicious barrier to health equity, because structural racism intensifies every other form of discrimination and impacts all the conditions that affect health. And as we discussed yesterday, it leads to fewer opportunities in jobs, education, lending, and housing, and unfair differences in the legal system for people of color. Building a culture of health demands that we understand and confront the ways racism, powerlessness, and discrimination play out in the structures and systems of our society, and that we find ways to interrupt those consequences. The good news is that since people created these policies and social practices that shape these barriers and opportunities, we can reinvent them. Addressing structural racism as a pathway to health equity reflects the evolution of RWJF strategies, informed by the knowledge and insight that we've acquired from our work, the work of our grantees, the field, and from populations who've been historically marginalized. This journey around health equity will continue to evolve as we work in partnership with all of you, and we welcome your feedback and your input along the way. As we evolve our vision, we're also honing in on our role, the role that we at the foundation will play in getting there. Together with our grantees and partners, we're aiming for a future where all families have the resources they need to raise healthy children, and where public health and healthcare systems prioritize individual and community well-being and remain accountable to them, and where communities foster the conditions that allow all residents to reach the best possible health and well-being. As we move forward with this work, we need a comprehensive understanding of the evidence base on how racism is embedded in our systems and what solutions work to transform these systems to center health equity. These papers in the upcoming series will likely touch on some of these systems, along with other systems critical to health equity. In our efforts to go deeper, We're looking to analyze how diverse communities are affected by historical conditions of structural racism. What are the present day disparities and what solutions will work to address structural racism as a root cause of health equity? And it's critical that this evidence base is driven by the voices of those populations who've been historically marginalized. That's the strength of the work that you're all here to do. You're making previously ignored populations not just visible, but an integral part of developing the evidence base and the solutions for health equity. Rather than lumping populations together under people of color, you're looking deeply at the unique assets and barriers faced by each population. This is the kind of keen focus and deep commitment to equity that we'll need to make real progress to building a culture of health. We're deeply grateful to you all for stepping into this hard work with courage and with humility. The evidence that you're building is urgently needed, and we're eager to learn with you and from you. Thank you all for joining us on this journey, and I look forward to hearing the rest of the presentations today and the conversations. Thank you so much.
Thank you so much for those additional opening and welcoming remarks, Dr. Morita. And now it's my pleasure to invite our first panelists up to the table. I'll introduce our moderator, who will then introduce each of our panelists. Dr. Gilbert G. is a professor in the Department of Community Health Sciences, Fielding School of Public Health at the University of California, Los Angeles. He'll be joined by Dr. Carlos Rodriguez Diaz, the Associate Professor and Vice Chair at George Washington School of Public Health. Dr. Michelle Johnson Jennings, a professor and director of the Division of Environmentally Based Health and Land-Based Healing at the Indigenous Wellness Research Institute at the University of Washington, and Dr. Joseph Kiave Kolokula, professor and chair of the Department of Native Hawaiian Health at the John A. Burns School of Medicine, the University of Hawaii at Manoa, and Dr. Reuben Warren, who's a former professor of bioethics and the director of the National Center for Bioethics and Research Healthcare at Tuskegee University. So I invite you all up to the table and we'll look forward to your presentations.
Yeah. Okay, good morning. It's great to be here with all of you. I am here to moderate this wonderful session. It's titled Levers of Systematic Change for Advancing Health Equity. And the key objective of this session is to describe how structural and systemic racism moves through systems to drive health outcomes and provide examples of the levers of systemic change for advancing health equity across our many communities. I regret that Juliet Choi, who's president and CEO of the Asian Pacific Islander Health Forum, is unable to join us today. She's feeling under the weather, but I know she sends her regrets. Okay, and on the right side, it gives the speakers a couple extra minutes to give their presentations. Okay, so our first speaker is Dr. Carlos Rodriguez Diaz. He's an associate professor and vice chair at George Washington School of Public Health in the Department of Prevention and Community Health. He's the founding director of the Gil Lebovich Center for Community Health in the Caribbean and Latin America. His research focuses on health equity and the social determinants of health, particularly regarding Latinx, sexual and gender minority communities and people affected with HIV. Next will be Dr. Michelle Johnson Jennings. She's a Choctaw Nation enrolled tribal member. She is a professor and director of the Division of Environmentally Based Health and Land-Based Healing at the Indigenous Wellness Center Institute and has a joint appointment at the University of Colorado School of Public Health. She also holds the Canadian Research Chair in Indigenous and Community Engaged Research. Her therapeutic expertise lies in working with Indigenous communities and decolonializing healing. Kawe Kaholokula, I'm sorry, is professor and chair of the Department of Native Hawaiian Health at the George Burns School of Medicine at the University of Hawaii. He is the co-lead PI for the Center of Pacific Innovations, Knowledge and Opportunities, and also co-leads the Native Hawaiian and Pacific Islander COVID-19 response recovery and resiliency team for Hawaii. He currently serves as a data disaggregation subcommittee for the White House Initiative on Asian American, Native Hawaiian, and Pacific Islanders. His research and advocacy work focuses on systematic improvements to healthcare delivery, outcomes, and policy. And Dr. Ruben Warren, he's the former director of the National Center for Bioethics in Research and Healthcare. He's also professor of bioethics at Tuskegee University. He is also the former director of the Institute for Faith Health Leadership, and he holds so many other numerous leadership positions in other venues, including the CDC, and serving as former dean of McCary Medical College. This is just a snapshot of the many accolades and accomplishments of our esteemed panel, and you can see a lot of the rest of it in the bios that are provided to you. So without further ado, I'm going to turn this over to our first speaker, Dr. Carlos Rodriguez Diaz.
Thank you. Good morning. Buenos dias. First of all, thank you for the invitation. I feel very humbled to be surrounded by you and having the opportunity to share my thoughts and experiences regarding race, racism, and health outcomes, specifically with Latino, Latina, Latinx communities. Let's see, okay. So I would like to start with the elephant in the room. Shall we use Latino, Latina, Latinx? Well, so the intention of using Latinx historically over the last few years have been to share gender neutrality. However, gender neutrality is not equal to gender inclusivity. So when we use Latinx, we might be erasing identities that are fundamental for the populations, communities that we work with. For some women, self-identifying as Latina is part of their identity, brings power and power. So the best way to determine how we're going to use the term is asking the people we're referring about. Throughout my presentation, I would use Latina, Latino, and Latinx, depending on the population that I would reference. Also, we need to acknowledge that Latinx is a political term, and it's political twofold. On one hand, it's an example of the historic erasure of our identity. By not using the words that we use to identify ourselves, we are erasing part of our identities. On the other hand, some scholars have argued that is a way of making it more visible the use of indigenous languages that in which X was part of the lexicon and it was more common. So if you, as a quick example, if you look at the map of Mexico, you will find many places, geographical locations where the letter X is much more common than in other geographical locations within Latin America or Spanish-speaking populations. And that is because of the indigenous language or languages that were used there before colonization. And if you don't think it's political, look at the newspapers and look on the web, what's going on in terms of the political discussions. It's happening. And one of the first things that some politicians are looking at is how we erase identities that we don't feel comfortable with, right? So that's why we as scholars, thinkers, researchers need to take a stand with our communities and understand how our communities are using language as something that empowers us. I recommend that if you if you want to have a reference when arguing on the use of Latino, Latina, Latinx, or a combination of them, look at the paper published last year by my colleague Ana Maria del Rio Gonzalez in the American Journal of Public Health, when she make really good argument and provide very specific examples of how we can use and basically argue on the diversity within the use of Latino, Latina, and Latinx. I also included here in the slide an example of how I introduce the populations that I work with when I am writing about the communities or people that are part of our research activities. Because throughout the manuscript or throughout, as is happening now, the presentation, we might interchangeably use a term or specifically use form of Latino, Latina, or Latinx. So that being said, I was invited here to talk about the health inequities and systems of oppressions affecting Latinx communities. And honestly, it is a talk call, mostly because all of our experiences matters. And in 8 minutes, trying to identify how systems of oppressions have affected the health of Latino population is impossible. So I would like to start by sharing my story because I cannot speak on behalf of anybody except for myself in the same accurate way, right? So I'm a queer, cisgender, gay Puerto Rican. Then when I'm not in Puerto Rico, I'm Latino. That's a label that was given to me. I don't use the label Latino when I'm in Puerto Rico, because when I'm in Puerto Rico, I'm Puerto Rican. I recently moved to the continental US. So for my scholarly work and research started in Puerto Rico and continued to be in Puerto Rico. And now I work from Washington, DC, of all places. I moved from a colony to a jurisdiction. And so I know how it feels. I'm also the son of a couple of an Afro-Caribbean man and a white presenting Puerto Rican woman, meaning that I grew up experiencing racism vicariously, but also being a white presenting Puerto Rican, experiencing the racism because my father was Black, but not understanding the privilege that I had as a white kid. Now I understand that privilege very well. I'm also an educated person and I work in academia, and that is very powerful. I speak more than one language, and in the context of the Latino experience, that is very important, and I will provide some examples. I'm also married to an Afro-Caribbean man from Trinidad and Tobago. So I experienced the racism toward Black people again in Puerto Rico, where he's perceived as a gringo because he's a Black person who speaks English. But now in the continental US, as a Black person or African-American, identities that he never used because he didn't grow up having to use those labels coming from the English-speaking Eastern Caribbean. I'm also a scientist, and I conduct community-based participatory research. And I am very privileged that I work with communities that I self-identify with or that I have gained entry and I feel that I belong to. And that comes with a lot of power. And I am very happy to say that all the research that I've conducted is because the community have identified the need and have guided me to contribute to whatever is the issue and how to solve it. So yes, that means that I have perhaps done less research than a peer with the same years of experience or same rank in academia, but I personally don't care because I rather have the opportunity to do research that is relevant. So all this to say that Latino is not a homogeneous group, and we need to understand the diversity within our communities. As a quick example, colorism has been mentioned in this discussion over the last 2 days. And there is research that demonstrate that understanding colorism among Latinos is better than the categories that OMB uses. So this is a case study for Puerto Rico. Puerto Ricans who self-identify as being of a darker skin color have worse health outcomes when compared to Puerto Ricans in Puerto Rico who self-identify as having a light skin color. And talking about Puerto Rico, I argue that colonialism is a social structural determinant of health. We have not been naming it as so, and we need to do it. I've been working with some colleagues developing a framework so we can use in public health and to use this framework to understand the root cause of the health outcomes that we see in communities that have experienced colonialism. And this is a reference to some of the work that we have published on this topic. And if you don't think of colonialism as a determinant of health, please go back to 2017. Hurricane Maria affected Puerto Rico. We had a president at that time that decided to go to Puerto Rico and throw paper towels. This image is real. Many people remember that, particularly people from the continental US, because you had access to television and cable. We in Puerto Rico didn't. So fortunately, we never saw this except after the fact. But it is a physical action of how colonialism interject in the response to public health emergencies. I also want to highlight that not all communities are equal. And I think that we have mentioned resilience several times through this conversation. And I don't think resilience is always the way of describing how some communities are responding to not having resources. In fact, I think that communities can be resistant because if you don't have the resources, if you don't know how to use the resources that you have, you cannot be resilient. And as an example, I will illustrate the inequities among Latinos by the work that we did very early in the pandemic, using data from the first 3 months of the pandemic in 2020. I was supported by a brilliant set of scientists who helped me conducting a very complicated study in which we used data to demonstrate or try to understand why we're seeing so many Latinos dying and getting infected from COVID. So we used different sources of information, and we identified that COVID infections were more common among Latinos, where we had more proportions of monolingual Spanish-speaking Latinos, lower unemployment rates, and less social distancing. So this is a very good example on how language matters. Early in the pandemic, we didn't have resources in Spanish. CDC took 4 months to have information about COVID available in Spanish or in any other language for that matter. So it is true that people who are monolingual had less access to information. And another example that I want to highlight is that we saw more COVID deaths in Latino counties with crowded living conditions, elevated air pollution, and employment. And this is consistent with what was shared yesterday, that it's not asthma, is the air quality where Latinos and minoritized populations live. So it's a matter of environmental justice. So during the pandemic, we saw many signs like this. We are on this together. Well, the fact is that we are not on this together. And although it seems innocuous and often well-intentioned, the phrase reflects the intersectional color and class blinding that functions to obscure the structural inequities that befall marginalized groups. And to wrap up, I want to share some anti-racism for a culture of health. First, my recommendation is to avoid health equity tourism. That means that an approach in which the community is us rather than them is more effective. We should build capacity in the communities. We should invest in the pipeline, and we need more people like us working with us for us. And if you are unwilling to take a political stand, stay away of health equity. And with that, we all share a privilege here, and I hope that we take that privilege to disrupt the privilege, because we shouldn't have that privilege. Thank you. Gracias.
That was a fabulous presentation. I invite Dr. Johnson Jennings to take the stand.
I do have slides, but we'll see if we can pull them up here. All right, well, while we are getting those going, just for the sake of time, I can do a brief introduction. So, halito sa chafaya Michelle Johnson Jennings micha aina English hopokona chaktasio hoke stikbat ya aba uma yatok. So I am Michelle Johnson Jennings. I hail from the Choctaw Nation of Oklahoma, though my ancestors actually mostly came from the place we call Aba Oma, or the place where they gather the sacred medicines. And today, being a health psychologist, I would like to talk to you a little bit about psychology and its foundation within eugenics, and just briefly introduce some concepts. I know we don't have a lot of time, and because I'm notorious for going over, I'm actually using a timer. All right, and if I can just get this to advance. Great. So I would like to also just recognize, I appreciate the land acknowledgement that was done prior. And I also want to just acknowledge the ancestors that we bring in the room with us today, including my own, and pay respect to them. And also just briefly say who I am. I am Choctaw. I also like to give the disclaimer. I've had over 10 years of formal training within the field of psychology. So as my ancestors taught me, be sure I disclose that, because though I was born and raised in my community, I also carry a lot of that bias through my training that I need to be aware of. Overall, I'm a storyteller. You'll see my family in the lower right corner there. And so everything I do, as my ancestors before me, is focused on the future for my children, as well as their children and their children after them. Again, I'm just going to briefly introduce these topics, but I'm happy to have more discussion later on and to go a little bit more in depth. We know that Indigenous well-being frameworks differ from Western well-being frameworks. In particular, in my work and working with communities, we go often back to ancestral stories, the discussions around health and well-being surround love, women as sacred, interrelationships and responsibilities, and trying to restore relational restoration and balance, as well as keeping in mind those future generations, because we're all future ancestors in the making. Now, in the Western colonial framework, we know that we focus on ancestors as having diseases or curses for us, right? You walk into a primary care clinic, in which I've worked for years. The first thing I ask is, what have your ancestors cursed you with? Diabetes risk, cancer risks. What else have they done to you, instead of what have they gifted you to be well today? And I think that's a fundamental difference as we think about health and well-being within Indigenous communities. As well as systemic racism is alive and well today. We know genocidal attacks is a matter of policy for Indigenous people. And I know you've talked about this a little bit before, so I won't belabor the point. But I think we need to remember, not only were there genocidal attacks upon us when we were a threat to colonization, then there was removal, including enslavement, massacres, starvation, land allotment, and then assimilation policies, in which the policy was to kill the savage and save the man. And so all of this led to our current structural racism that exists today within our healthcare access and self-determination restrictions, as well as my colleague mentioned, the environmental pollutants that are proliferate Indigenous territories and lands. Now, historical trauma is a concept I know was introduced as well yesterday, so I won't belabor that, but I will say, when you have historical trauma and a collective distress and mourning, as Dr. Evans Campbell has pointed out, then you often have historical trauma responses. And that can include not only our responses and disruption within our families and how we react, but down to the cellular level, in which we find with all populations, just not Indigenous, those other ones like Dutch famines as well. We've seen that when massive groups experience massive trauma, the future generations have higher rates of disease, right? So switches get turned on, and those switches say it's a hostile world, be prepared. And whatever is within those switches actually then produces these risks, right? So risk for addiction, risks for diabetes, all of these autoimmune disorders, heart disease, et cetera. And from an Indigenous standpoint, it's also really that historical trauma disrupted our connections to the land and our ability to heal ourselves. Now, within the field of psychology, it was founded, I would say, based upon eugenics. So even in the 1800s to the 1900s, there was a lot of work done around making sure that Indigenous people were seen as inferior. The continuous performance task that we still use today for ADHD testing was actually normed upon Indigenous children in boarding schools and in communities. And at first, Indigenous children did quite well on this test. And then they modified that so they wouldn't do quite as well. And again, still used today, right? Majority of cases for ADHD until recently were among Indigenous children. At first, they called it feeble-mindedness, and then they changed the term to ADHD. And so that's now went out to other Indigenous children of color are also increasing in their numbers. So there have been some like Walker, who calls us to question what that terminology means and what we're doing with that diagnosis. Is it a form of structural racism? As well as the IQ test was normed upon Indigenous children in boarding schools. They went to boarding schools. When they performed too well, they have modified the questions. Terman and his research assistants both blatantly were racist, but also unconsciously racist, presuming that Indigenous children were inferior, white settler children were superior. We still use this test today in our educational systems and our psychological settings, right? A test that was utilized to term Indigenous children and then others as the deficit. Now, the whole field of psychology, I could go on and on, has journals, books, tests, where they examine Indigenous populations and make sure they were seen as the inferior. Now, at the same time, this is going on, they were taking children from the homes. If the mother was deemed feeble-minded, she could be sterilized, children could be removed. And up to over half of all Indigenous children lived in boarding school or foster home, mostly boarding schools that were rife with assaults, physical, emotional, and also sexual. Now, also, more than 25% of Native women of childbearing age were sterilized by 1976. Some would say this number is actually higher than that. And there's still instances of women being illegally sterilized today. This has all led to high health disparities within Indigenous communities, not only physical, but also mental, because we know it's all connected, right? As integrated primary care psychologists and health psychologists, we know that we're not able to just separate the mental, the spiritual, and the physical at once. We know that when we have these assaults upon us and our communities, it affects all of us. We also know that violence, sorry, my slides just want to jump around and speed me up today. We also know that violence is more likely to occur among Indigenous women and men, and I apologize, we don't have a breakdown for Two-Spirit individuals with this information, but we know it's also very high among others. And the majority of those who are committing the violence are non-Indigenous. So it's up to 90%. So Indigenous people have been objectified. They have been erased from our lands, erased from even our society in a lot of ways, and erased from the data that I'm sure you spoke about yesterday. And we also know that they're more likely to be killed by law enforcement. And that often goes underreported. Thank you. All of this, we see structural racism in healthcare. Findling et al. Has shown this, but also students I've been working with have been finding the same results, that we're still finding that Indigenous women, Indigenous people are not feeling safe when they seek healthcare, and they're feeling threatened or harassed many times. Through this, we know that trauma is cumulative. So if we have historical trauma, present trauma, our risks become higher for disease and food addictions, substance use addictions. But we know that loving, supportive relationships can help reduce this risk, and our Indigenous ways can also reduce these risks. But I think as practitioners, as researchers, we need to be aware that trauma and love is just as powerful when we think about it, right? So we know that both are enduring. We know that a loving, supportive environment before the age 5 can reduce all of these switches that get turned on the epigenetic risk and can help us be well. And when they're both affected by the past love of our ancestors, what we do today to promote that love and how we think about the future generations. I won't go too much into this, but we also need to recognize Indigenous ancestry within psychology and health and medicine. I mean, a lot of these theories, Erik Erikson took a lot of his theories from the Yurok and Pine Ridge. Jung took from Pueblo. Maslow went to visit the Blackfeet. They're reclaiming that, saying Maslow got it wrong. So now there's scholars correcting this. But we know that we have contributed much, at the same time being referred to as primitive and savage. So we need to be aware that we have a lot of contributions to society as a whole, and that we can reclaim those narratives by decolonizing and indigenizing. And while we indigenize from building up, decolonizing means to look at how we've changed and adapted and what permeates our everyday life, thought, ways, and practices. But all in all, Indigenous communities must be in control. And I think as we think about decolonizing research, Professor Tui Weiss-Smith reminds us this can be really risky business. We need to know that as we create voice for the silence, challenge racism, challenge colonialism, challenge oppression, that we may not move forward in our careers as readily as others. We may come under attack by others as well. But I find that through land-based healing and helping communities reconnect to the land, we've been able to recenter. We've been able to find that it's very beneficial for communities to get back to the land. And we can restore through going back to the land and stop centering the colonizer and the colonizing process, as some of our participants have noted. And with that, we can build and start weaving thrivance. So taking the weft of ancestral knowledge, warping that transformative resistance to decolonize and indigenize as we move forward and look at different ways. So I'll conclude with this. We're introducing some new models of even social determinants of health. Recognizing, as my colleague pointed out, yet colonialism is definitely a social determinant of health. But more importantly, how do we define ourselves as individuals? And how do we think of ourselves as we move forward? Thank you.
It's wonderful. All right, I invite Dr. Kahola Kalua onto the stage.
Mahalo. Velina me ke aloha. Ia o ko na kupuna a me na kanaka oiwi o ke ia aina ma DC. Velina me ke aloha ia o ko e na kanaka like ole mai ke ia aina nui o Amerika. Velina me ke aloha e na kanaka oiwi o ka moana nui a kea. Aloha mai ka ko. That was in Hawaiian, that was a way of saying good morning to everyone in the short version. I think we need a little laugh sometimes in the work we do and find some joy and aloha. But in all seriousness, I actually recognize the indigenous people of these lands that we now meet upon, as well as their ancestors, and joins our ancestors. I also recognize all of you have come throughout America, or this country called America, as well as my Pacific Islander colleagues from the Great Pacific Ocean, the islands of the Great Pacific. I'm going to focus a little bit differently because, you know, Native Hawaiians and Pacific Islanders, although OMB Directive 15 lumps us all together as a single racial ethnic category, and then one time with Asians, yeah, still doesn't make sense. We are very, very diverse. And I need to emphasize that. We are diverse in our political statuses within the US, our political relationships with the US, and our political aspirations in the US. Although we all suffer from structural and systemic racism, we do so in different ways. And we also have different aspirations, again, to work ourselves out of that system. And so what I want to share really is first, educate all of us, because us outside of the Pacific, you may not understand Native Hawaiians and Pacific Islanders. And by the way, Native Hawaiians are Pacific Islanders, but Native Hawaiian and Pacific Islanders are more than a racial and ethnic group. We are a political group as well. And I hope to share some of that with you. So I'll come back to Hawaii as the 50th state and how we became the 50th state, because that's very unique among our Pacific Islander communities. But we also have other US affiliated Pacific Islands represented here in the United States. We have two territories, if you didn't know, aside from Puerto Rico, we have two territories in the Pacific, American Samoa and Guam. Really interesting. American Samoa is an unincorporated territory. What does that mean? They're not citizens of the US by birth, right? They don't have representation. So interesting enough, they can join the military though. By the way, did you know that Native Hawaiian and Pacific Islanders are the largest racial ethnic group in the United States military? They're 6 times represented, highly represented, 6 times greater than their representation in the general US population. But yet they're not born natural citizens if you're born in American Samoa. Guam is an incorporated territory. They do have, I believe, citizenship from birth, but they do not have representation in the House. They cannot vote on the floor in the US House of Representatives. There is tremendous political disenfranchisement for the territories. And I'll come back to some of the other issues. There are also US affiliated sovereign nations that entered into treaties or a compact of free association with the United States. And those are the Commonwealth of Northern Mariana Islands, the Federated States of Micronesia, and the Republic of Palau. Now, yesterday, Dr. Christopher mentioned the importance of contextualizing our work in our historical context, and also that we have a history before colonialism. We have a history before contact. And I want to share a little bit of that history really briefly, because it's important that when we talk about structural systemic racism, we contextualize that in the history, pre-Western history because it was a great history for our people in the Pacific. When Captain James Cook stumbled upon the Pacific Islands in the 1700s looking for a Northwest Passage, what he found was a thriving, healthy, robust, jovial population in the Pacific, counter to the false narratives that were put forth by the missionaries that eventually came to justify their existence in the Pacific. And of course, our European and American settlers that came to our islands. So the false narratives, we were thriving. We had abundance in our islands. We had the ocean, we had the mountains. We had sophisticated forms of government and resource management. In fact, so sophisticated that in many places now, we're looking at these indigenous practices to save our world from climate change and so forth. So it's important to contextualize that we were healthy, we were well, and then came Western intrusion into our islands. And throughout late 1700s and throughout the 1800s, and yesterday we talked about how decolonization is bad, and we emphasize that. We need to talk about occupation is bad. There's a difference between colonization and occupation, although the consequences are the same psychologically, socially, et cetera. We were occupied in the Pacific by foreign powers, to include Imperial Japan at one point. Okay, this has affected our populations. We suffered depopulation to the point of nearly extinction. And give you an example in Hawaii, roughly 700,000 natives were on the islands in 1778 when Cook arrived. By 1893, the illegal overthrow of our kingdom, there was barely 30,000 natives, mostly due to infectious diseases. Christianization, there's exploitation of our people and our resources have led to marginalization and defranchisement within our communities. And of course, immigration from other countries such as Asia and Europe. 1893, I want to focus in a little bit on Hawaii's situation. If you're not familiar, under international law, Hawaii is considered occupied territory. The US military occupied Hawaii, just never left, right? We never relinquished our sovereignty, and that's been recognized in federal laws. So we do have a special relationship with the US, but we don't have the same relationship as American Indians, Alaska Natives. In fact, we tried to get a similar relationship through what was called the Akaka Bill for a government-to-government relationship. It was never enacted, and it was quite contentious even back home among Native Hawaiians. Many of our people felt it was a sellout. So there was never really got any momentum. However, something like that is what is needed for our Native Hawaiians to have a government-to-government relationship similar to American Indians, Alaska Native. And that's a big structural systemic racism issue for us. Of course, the Kofa migrants. If you don't know, after World War II was basically fought in the backyard on the sands in the Pacific, Pearl Harbor. And US enters because of the bombing by Imperial Japan at Pearl Harbor. But in the Eastern Pacific region known as Micronesia, South Pacific, literally the battles were taking place on the islands. So, and because of that, subsequent to World War II, right after, there was the nuclear testing in the Marshall Islands, and that displaced people. Atolls and islands are no longer inhabitable, increased the risk for cancer and other chronic diseases among many of our Pacific Islanders from that region. The good news is we are people on the rise. We are growing, especially here in the United States. We've increased 31% since the 2010 census. We're now 1.6 million. We only make up 0.5% of the population, so we're a small group still. But I'm hoping that our voices are strong and that people can still hear us. We cannot be ignored. We cannot be invisible in the data. And we talked about data disaggregation yesterday, and that's so important for Native Hawaiian and Pacific Islanders. We continue to have a strong cultural identity, strong community ties, and connections to the Pacific. I talked about our aspirations. It's all different. Some people aspire, let me put it this way, fairness and justice that was mentioned earlier as a health equity, looks different for Native Hawaiians and Pacific Islanders. And within our group, it looks different. For Native Hawaiians, they want their government back. They want their sovereignty. Other groups might want US citizenship and so forth. So the aspirations are different. The acculturation strategies and aspirations are also different, and we need to account and understand that. When we look at the studies we have done, looking at the effects of racism on the health and well-being of Native Hawaiians, talk about how does racism get under a person's skin, as we talked about yesterday with allostatic load and so forth. We've done studies. We find racism associated with almost self-reported health, depression, psychological distress, chronic disease, to name hypertension and diabetes, and indices of physiological stress. We know misclassification, racial misclassification in NHPIs are related to poor health. Historical loss related to depression and substance use in our people. Maltreatment, implicit biases are found among our healthcare providers in Hawaii, among diverse healthcare providers, by the way. Still, implicit bias in favor of whites and Asians over Pacific Islanders and Native Hawaiians. There's a tremendous mistrust still towards medicine and science because of our history. And that's another issue. We're not accessing care. Although in Hawaii, we have great medical insurance. Actually, the Obamacare is modeled a bit after Hawaii's insurance laws. But although a majority, greater than 90% of Native Hawaiians, for example, have medical insurance, they're just not using it. And part of this is mistrust for science and medicine. Now, I'm going to end just covering, there's a lot of things up here, a lot of issues, all the major issues, but I'm going to focus in on decolonization, deoccupation should be focused on, and looking at indigenizing, as presented earlier by Michelle, indigenizing our systems, introducing our traditional concepts that are holistic, that have aloha or love in it, that we're looking to make the world a better place and more inclusive. You know, data disaggregation needs to stop. Although OMB 15 since 1997 has taken the Asian and NHPI, separated us, we continue to get aggregated, and every excuse in the world from small sample size to privacy issues is used, but it does us no good. It does no good for the Asian populations by having our data with them. It has no good for us in HPI. It masks the true differences or the true prevalence of or incidences of these diseases and the issues. And there are national data sets for which our US Pacific territories are not included in. Aside from the census, they're not included, unlike Puerto Rico, in many of the other national data sets, the American Communities, for example, survey. And we need to get them that, because that resources are allocated based on that. I'm told my time is up, so mahalo nui.
All right, thank you. I invite Dr. Warren.
Good morning. I had to look and to see where I am and what time zone I'm in, so pleased to be here. I'm encouraged by yesterday's conversation. The session was excellent. I was particularly pleased by the speakers placing their comments in a historical context. Right now, it's important to reflect on history because there's so much going on around this country that's trying to eliminate history. So I was excited about that reflection. Dr. Christopher encouraged us to think about what we don't want, but also to think about what we do want. The discussions of anti-racism are becoming acceptable conversations, but we also need to talk about and focus on respect and appreciation for the assets that different racial and ethnic groups have and can contribute to humanity beyond the science and to all things in this world. My context is really around environmental justice and optimal health. That's the context. It's impossible to separate our health from the health of all that's around us. Environmental justice considers the physical and social environment, and optimal health encourages us to go beyond illness, sickness, and disease, but to be our best selves individually and collectively, and have our best health individually and collectively. Physical, intellectual, emotional, socioeconomic, and spiritual, our best selves. The levers of structural and systemic racism are major, and you've heard much of that by my colleagues' previous conversations. I chose to not focus on that so much, but to prompt a conversation, because much of what we need to hear, you need to say. So I hope my comments prompt some thoughts in your mind. My presentation is really based on justice as fairness, which has a central place in health, healthcare, and all that we do. Justice, a central place. Justice, according to John Rawls, says that each person possesses a vulnerability founded on justice that even the welfare of society as a whole cannot override. Therefore, in a just society, all the rights secured by justice are not subject to political bargaining or to the calculus of social interests. Justice. And one of the major barriers to justice, as we've talked about yesterday, today, and we've been talking about for the last few years, and for some of us for many, many years, is racism, structural racism. What I'd like to do is try to break that down into concrete measures and tenets so we can better address it. Dr. Carmela Jones discusses racism in 3 constructs. She talks about institutional racism, personal mediated racism, and internalized racism. So it's not just the same thing for everybody. Institutional racism, she says, is structural and systemic. Initial historical insults, structural barriers, societal norms, biological determinism, unearned privilege, and I might add things like using Black and African American synonymously. They're not the same. It's a microaggression. Every time I hear it, then I pause with my Black colleagues from around the world in the United States that pause and say, I'm not African American. So I'm thinking we need to rethink that. I was at the Centers for Disease Control when that conversation was going on, and I said it, but they didn't hear it, so I'm saying it again. Black and African American are not the same. It's a microaggression, and we need to get over it. Personally mediated racism, Dr. Jones says, intentional, unintentional, acts of commission, acts of omission, maintain structural barriers, and condoned by social norms. That's the personally mediated racism. Let's separate that, but again, also deal with it. And another one that we don't talk about loudly enough is internalized racism. Reflects systems of privilege, reflects societal norms, erodes individual sense of value, and undermines collective action. Even though I don't believe if you're Black, you can initiate racism, but if you're Black, you can surely participate. So let's not get it twisted. Let's not get it confused. Now I'm going to go on and talk about structural racism as an impact upon Native Americans, human rights violations. And I had a long list, but I won't go through that. But I want you to know that I recognize that racism is more than just in one population. And I could talk about the Trail of Tears, but my colleagues can talk about it much more specific than I can. But I recognize it is there. And I spent some years at Tuskegee, and Tuskegee is a native land. The word Tuskegee is native. So I had to recognize whose land I was on and repeatedly apologize. Wasn't my fault, but my circumstance. I was going to talk about the African diaspora human rights violation. I can speak to that. I can talk about the transatlantic slave trade, 1619, enslavement, slavery, emancipation, Black codes, Jim Crow, segregation, eugenics, and the United States Public Health Service syphilis study at Tuskegee. I spent the last 30 years trying to better understand. But I won't belabor that either. I could talk about, and I had Hispanic human rights violation, but Latinx, I need to learn. So continue to teach so we can say what we need to say in ways that you understand and can help us to understand. So I had the history of that kind of effort, 1848, and how this land, quote unquote, belonged to somebody else. I grew up in California, and I understood from early on where California came from and where California belongs. An Asian American Pacific Islander human rights violation. I'm learning as we speak. And I knew they wasn't the same, but combining them does more harm than good. We need to be very intentional about how we allow others to describe who we are and what we do. And we talk about this movement of health equity. And it's exciting, but it's got to the point where it's confusing. And what I think health equity is, I don't know what you think it is, but what it's becoming is dangerous. So we need to be real intentional about what we talk about when we talk about health equity. I specifically talk about optimal health in the context of the African American experience. And optimal health is the best possible emotional, intellectual, physical, spiritual, and socioeconomic aliveness that we can achieve. That framework was developed by a colleague who practiced primary care in East Baltimore for many years and stopped practicing what he called sick care and started talking about optimal health. He said, we're not in a healthcare system, we're in a sick care system. So he stopped and he started working on the concept of optimal health. He says optimal health is optimal intellectual health, optimal emotional health, optimal physical health, optimal spiritual health, optimal socioeconomic health. And he talked about it in his book called Pyramids of Power. And it really talks about how we translate what we think into what we do. And last, I want to conclude by, I started talking about justice and fairness, but I want to expand that to talk about social justice as a foundation for public health, where I spent most of my career. And hopefully the practice of public health can help us to better understand the practice of equity public health. Let me close with two comments from two heroes, and I guess I should say heroes and sheroes, but let me start with Dr. David Satcher, the 16th US Surgeon General. And he said, we must know enough, care enough to do enough to make a change. He said, we know enough, but the question is, do we care enough to make a change? And Satcher and I worked with him for many years. The scientists and scientists talk to scientists, and we seem to understand each other. At least we act like we do. In many forums, you know, I shake my head, and I ain't got a clue what you're talking about. And also, I want to close with a more prolific, more expansive quote from another colleague, Dr. Maya Angelou. And she says, history, despite its wrenching pain, cannot be unlived, but if faced with courage, need not be lived again. Thank you.
All right, what an amazing set of speakers. If you haven't put your questions into the silo.com website, I invite you to do that. I have a couple of seed questions, and I definitely invite questions from the audience here. So I have a question for all of you. You know, and I'd like to start maybe on something positive. You know, how can we best support our communities? How can we help them thrive in terms of health and well-being, given this context of structural racism and given the history of resistance in all of the communities that we have? I invite anybody to start.
Let me start. I think from my perspective, we need to learn how to listen. You know, we go through years of higher education and before, and we learn how to talk. But very seldom are we taught systematic how to listen. And I think we need to learn how to listen, because of the communities that are in greatest need know what their needs are. And if we listen empathetically, I think we can do a better job in what we're doing.
And I would just add with that, I think that's very true. We do need to listen. We also, I think, need to do some introspective work, right? We need to look at how we're utilizing forms of oppression in our everyday life and our training and in the research that we do. And in that way, you know, we're focused on decolonizing that, right? Providing space for others, looking at what we're doing might be causing harm, how we approach, for myself personally, being in a primary care setting, walking in and saying, what your ancestors cursed you with, and having patients be like, whoa, we're not going to talk about what tribe I'm from first. We're not going to talk about, you know, my ancestors from which I hail. You know, we're not going to talk about love or care that's supporting me right now. We talk about what's wrong with you and what's wrong with your ancestors from which you come, right? So I think just in that example, listening is critical and key, and also being reflective on every practice and every interaction that we have, which is hard to do, especially where we're in our practice, or when we're, having to get deadlines accomplished and outcomes and outputs and what have you. But I think it's really critical as well.
Was the question, how can our communities thrive?
Yeah.
That was the question.
Yeah.
And to add to the excellent responses, what we're learning in our communities, especially in Hawaii, and I got to say, most of my work are with Native Hawaiians. What we're finding is that returning to our cultural values and practices might be the answer to health promotion, health equity for us. We were made to remove our Hawaiianness or our Pacific Islanderness. We were asked to give up our languages to assimilate. We were asked to take on different belief systems. And that didn't work for us for over a century. We had higher rates of substance use and abuse, domestic violence, chronic diseases. So we started in the 70s, we started to return to our traditional worldviews and practices. And since then, we have accelerated our progress towards health equity, increasing the number of Native Hawaiians in education. We've revitalized our language in Hawaii. There's more speakers now today than there were in 1980 when we started. And the research we've done using hula, our traditional practice, and leverage that for health promotion to address cardiovascular disease risk. Through a randomized control trial, we found it to be very efficacious in not only helping those that have uncontrolled hypertension to get it under control, but also to reduce their 10-year risk for cardiovascular disease using a traditional dance form. It's physical activity, but it's also cultural, it's also social. And what we also found was really interesting, and I'm interested in racism, ethnic identity, and so forth, especially hypertension. As a result of undergoing a cultural base, and we had non-Hawaiians, by the way, mainly Chukis, another Pacific Islander group, participate, and they improve as much as the Native Hawaiians. What we found was, over time, as a result of participating in a cultural-based health promotion program, they started to report experiencing less racism around them. The control group, no change. And it was significant, and it was for both Chukis and Native Hawaiians. So we can do something different. We can either do the mainstream evidence-based interventions designed for other groups and get okay clinical outcomes when they're translated to our communities, okay clinical outcomes. Or we can do our own cultural-based activities and practices and get great clinical outcomes, but also great social and cultural outcomes that we want, which is strengthening our identity, finding a space and place for us to exercise without discrimination that identity. And how does that identity strengthens us and gets to that atostatic load issue, taking that racism from getting under our skin and creating a shield, if you will. And we have evidence for that, funded by the National Institutes of Health. And so we need to get those into translation, into implementation, and we need to look at other practices. We all have them in our own cultures, our own dance forms, our own ways of being. I'll stop there. I'm going too much. Thank you.
I'll be brief. As we're talking to scientists and scholars here, I would say if you want to contribute to the communities, spend time with the communities. Spend time, listen, experience what they're experiencing. And yesterday, a lot of time was dedicated to healing as a process of working towards dismantling racism. I want to also highlight that healing is not a process that works for all the communities, and that not always take us to achieve the goal, in this case, to address racism. Some communities are working from rage, and we need to listen to that too. And rage has been a source of power that have changed systems. Just to use one example, ACT UP in the 80s, 90s, they changed the way communities engage in research, and they act from rage. We have community advisory boards now because of ACT UP. So there are different ways in which the communities can achieve to get to this place of addressing racism and how racism impact their health. So I think we need to, and the only way we know what works for our community is spending time with the community. I'll stop there.
I appreciated that last word you used, which was communities at some point. And this is the diversity within all of our communities is something I think everybody touched upon. I was wondering if maybe the panelists could say something about how you think about the diversity within your communities and how we can best leverage this into a systematic response towards health inequities.
Well, with Indigenous people in the U.S., American Indian, Alaska Native, we have, over 576 Indigenous tribal groups. We have state recognized groups as well. We have urban communities. We have over 200 different languages. With that, we have great diversity. And I would say anytime that I'm engaging with Indigenous communities, I also work in Canada. And with communities that don't recognize the border, right? So they go back and forth fluidly. But there's a lot of diversity that we work with community advisory committees, right? Or councils or boards. We try to be in the community, as was said, is really important. Get to know what are some of the issues, where are the overlaps. Even in my work with urban Indigenous communities, we've identified similar worldviews and approaches to health and well-being. We've had committees composed of diverse groups, representatives, but also it's rather fluid. People who want to come in and speak to the issue can come in to speak. And the more the better is our approach, right? Of hearing those different views and finding out what works for them. So though, for instance, I've worked with a community where it's primarily two different tribal groups, we have some broader categorizations that they utilize, like plains groups or woodland groups. And so they had some different practices around diet and exercise and well-being. And so we talked about what would work for both of them and what would that look like in practice. And so that was quite helpful.
I always pause when I hear the word community, because people seem to think that's geographic. But community is far more than that. It's behavioral, it's social, it's experiential. And so I think the first thing is, how do you operationalize your community and what brings you in that community, and sometimes what alienates you to that community. I grew up in South Central Los Angeles. For some folks who know California, it's known as Watts. And the farther I went in higher education, the more alienated I became from Watts. So I had to go home every year and just sit and listen so that I stayed grounded. So critically important, I think, is understanding community. It's more than geography. And you can maintain your community connection regardless of where you are. And you must, as we say, revisit and spend some time listening in addition to talking.
The question about diversity and how to leverage that. I mentioned our NHPI, a very diverse group, but we are unified in our diversity, and more so during COVID-19. COVID-19, although we heard about every other ethnic group having the highest rates, in states that disaggregated data, NHPI had the highest rates of cases for COVID, hospitalizations, and deaths. And we came together as a community, both in Hawaii, here on the continent. These people are in the room, the leaders in this area, and we worked together. And prior to this, I must say, Native Hawaiians, because of our different political relationship and aspirations, did not work as closely with our Pacific Islander cousins the way we should have. But COVID changed that. And I think going forward, unity, because we're a small number, 0.5% of the population. We need that unity to have that voice and platform. We need to share our resources and figure this out. And what's going to work for one group is likely to work for another. Thank you.
I focus the diversities within our communities. I have to keep thinking of who is Latino, who's Latina, who's Latinx, because for some people who are labeled as Latino, their roots were here before the colonizers. So that label has been assigned to us, but we might not belong to that label and the identity that has been created around it. Currently, as we do work with Latino communities, it's not only about where the people come from, it's also where they are at, their levels of acculturation. And there is some research already evidencing that the first generations of Latinos in the United States tend to identify as Latinos, but the second, third, fourth generation, the percentage of people who self-identify as Latino, even coming from a Latino household, is decreasing. And just to use an example on how we can operationalize this issue of diversity within the Latino community, I think the most common that I see is in the use of language. Frequently, people who are not Spanish speakers tend to say that, oh, but you have different Spanish, right? Like Mexican speaks Mexican Spanish, Puerto Rican Spanish, the Dominican Spanish, and no, it's Spanish. We might use some words that are different, that are perhaps because are influenced by our indigenous roots, maybe influenced by the Spanglish and use of English. But my answer is always, in the United States, in the continental US, you speak English. You might be from the South and have a Southern accent. Maybe you're from New York and you have a New York accent. You speak English, right? So still, when we operationalize the use of language in interventions, it's very important now that we are sometimes forced to use evidence-based interventions in our communities. Adapting an evidence-based intervention is not translating the intervention for Spanish-speaking populations. And I can go for hours with a rant about that, but often, as previously shared, if certain counties, and in the case of Puerto Rico for the whole country, if federal funding is allocated to do certain kind of work at the community, we are required to use evidence-based interventions, but those interventions were not developed with the people or for the people that we're going to basically impose an intervention. So the likelihood of having success decreases significantly. So that's why we need to do more research to develop interventions that are culturally congruent with Latinos, where they are, who we are now, which is different than where we were 10, 15, and 20 years ago.
Okay. I know there are some questions in the audience, so I'm going to grab the mic.
Thank you for that incredible panel of talks. And I can't wait to study your slides. My name is Erica Blacksher. And for those of you who were in the room yesterday, which is I think most of you or all of you, I'm an author on the paper that will look at the white population. We still haven't figured out a name for that paper. I have a question for you all, and maybe a question for you all in the room. And I just want to situate the question make sure that you understand that it's asked from a place of solidarity and from a place of recognizing the white privilege that I have. As I have listened to your talks and the talks yesterday and the comments yesterday, I've seen something that I have often felt over the decades of my own living, which is a question about where am I? This issue of the way we use data, often in single axis ways, that paper over the significant heterogeneity within categories. And I guess what I want to ask is, and maybe it's a question you can't answer now, but over time as we all work together on this paper series, I know I'll be trying to figure it out and would like input from you all. How do we talk about poverty and adversity in white people? And there are, as we all know, the majority of poor people in this country are white people, without trying to, and without talking about, without saying that, avoiding the false equivalency. I want to give you two examples. that were raised for me by your talk, Dr. Johnson Jennings, and someone else mentioned it as well. So when we talk about eugenics, what is often papered over is the 1927 Supreme Court case, Buck versus Bell. Carrie Buck, her sterilization, her forced sterilization was upheld by the Supreme Court. And she was white. And I think some people don't know that. When we talk about, for example, to give another, adverse childhood experiences, when you show data and you break that down intersectionally and you look at race and the family income at the same time, you see this thing that you wouldn't expect to see perhaps, that when you look at poor white kids, they actually have these super high levels, higher levels of adverse childhood experiences. So I guess what I want to ask is, how do we begin to talk about that without the illusion of false equivalency? I'm acutely attuned to the privilege of my skin color and have scrubbed and combed my past, which, as you all heard yesterday, I was reared in a toxic brew, but I see the white privilege along the way and understand how that helped me find my way out of that thicket. But I am looking to colleagues to help me figure out how to talk about that in a way and write about that in a way that is inclusive. The other thing you said, Dr. Jennings, you talked about restoring, which I think is really beautiful and important in this room, is a question of how we build inclusive stories and how we heal. So that is the space from which I ask this question. How do we tell these stories in an inclusive way? So I hope I haven't triggered anyone. I hope I haven't committed microaggressions. I'm aware that I might have, but please know it is asked from a position of genuine sincerity and trying to work through this. I'm sorry that question was so long.
Well, first I want to say thank you for being open to exploring these issues and concerns that you have. You know, I think as I'm listening to you speak, there are instances in which, yes, you know, other people than just Indigenous people were forced sterilized, for sure. Definitely other people of color and some white settlers as well. You know, I think when I discuss this, it's in context, right? Like 25% of all women by the 1970s, if not more. It's still happening today. So, and it was based on the terms of being racially inferior, right? Or feeble-minded. So when I think about your question, how can you discuss it? I mean, I think the issues still lie in that those who are disenfranchised, those who are oppressed, those who don't have a voice might also receive similar treatment, especially women who may have been from poverty-stricken areas, even if white. However, you know, you're right, there is a tendency to dismiss the large-scale events with a collective group or dismiss the systematic approach upon different races if we can justify, well, it happened to others as well that were white too. So is this really racially focused, or is it just, you know, this is what happens if you're poor, period? So I understand why you're feeling a bit hesitant to discuss it in a way, because it does feel like it's pulling from. At the same time, I think that's good work for your group to talk through, right? Like you know, I immediately think about in my grad school, we talked about Bacon's Rebellion, like one of the rebellions, right? In which indentured servants who were white, you know, got together with Indigenous people and Black people as well. They came together. Well, actually, before we were all called those names, right? So we didn't have those names yet. We were all identified as who we were. And then because they were rising up against those who were oppressing them, then they codified the word white and said, you know, if you just work hard enough, you too can be an elite and have land one day. But don't associate with those over here. Those are Indians. Don't associate with those over here. Those are Black. They will never have access to land, right? Or have the rights that you have. So that then spurred this division to where, you know, we instead of joining together, we kind of didn't after a while, right? So I'm thinking, you know, that could be somewhere, you know, I don't want to be blunt, but I mean, I think that's your work to do, right? So as white settler populations coming together, how can you discuss these? Talk about poverty, which is very real. Talk about economic inequities that might occur within our population or society that continues to oppress, everyone involved, right? If we have racism within our society, if we have injustices, then we're all suffering from this and we all are hurting and being harmed. But how can we utilize what privilege we do have to speak out and say, no, this is not okay to keep occurring. It's not okay to continue to have poverty. It's not okay to continue to oppress others. This hurts us all in the end. I mean, that would just be some of my initial thoughts to restore it, to say, look, this is what's happened within our history. This is the context. We do still have massive poverty. We're not doing well. You can look at many states. We're not healthy in a lot of our states. And we're getting worse and worse, especially as we pollute our lands and not listen, right? And I know, as Cave discussed, we have environmental pollutants that are harming all of us together. So unless we start taking care of each other and paying attention and seeking that, we're not going to be able to move forward as a society at large. And so that story does need to be told. I think it's really powerful for those white settler ancestry to tell that story because it's speaking to others that are like you as well.
I got a title for your chapter. Provocative one too. Being American is bad for your health, even for white people. No, American culture is killing us. Being American is bad for our health, even for white people, because white Americans have higher rates of heart disease than your European counterparts. So if it was genetic and biological, that shouldn't be the case. Obviously, it's cultural and environmental. I'm serious. American culture is toxic, especially this is the last presidential. Well, okay, I won't go there. I'm in DC. I might get followed. Yeah. Well, yeah. You can. All right. Well, yeah. Thank you. Get my back. No, seriously, I think if provocative chapter, but that's what it's about. Being American is bad for your health. Even for us health professionals, we were talking about it with someone yesterday, today, maybe it was with you. I don't know. We work in the health field, and we don't have time to exercise or eat healthy because we're always working and doing something. Our communities are always doing something, and they can't have time for taking care of their health. That's your title. Being American is bad for your health, even for white people.
And if I can add, that's great. I love that title. I was thinking about how to answer your question, but perhaps providing examples of how can it be illustrated. I think you can address the fact that poverty and race should not be conflated. And that is often the case. Researchers often try to measure structural racism by using indicators of socioeconomic status. So I think a good example could be, as we discussed yesterday, deciding when do you want to compare groups. Because if you use data for the United States, that would happen in terms of the health outcomes of white Americans. And then you can decide if you want to compare to other groups based on race and controlling for socioeconomic status. Because if we go to the roots of the understanding of the social determinants of health, no matter your race, those who are in the lowest socioeconomic status are always going to have the worst health outcomes. So, and that could be very difficult to illustrate with some data, mostly because we are also taking the conversation about, let's talk about our group rather than comparing us with others. So yeah, I commend you for taking the lead on writing about this. I think it is important, and you got a title.
I just might add that we have to be real thoughtful about comparing, segmenting. When we're talking about a certain group, let's talk about that group. You know, in 1985, the the Secretary's Task Force on Black and Minority Health found that there was 60,000 excess deaths in the Black population, regardless of income or sex. And that 60,000 was compared to their non-Hispanic white counterparts. So it was the first time that the federal government acknowledged that you can chronicle health disparities or death and disease based on race, and that was clear. I spent some time at Centers for Disease Control, and we tried to replicate that work using the Hispanic population and found excess deaths in the Hispanic population. So I think it becomes almost dangerous to continue to compare. And they replicated that study in 1985, Satcher and all, not in 1985, but 2000. And they found that the 60,000 excess deaths went to 83,000 excess deaths. So the time to compare is over. We need to begin to look within ethnic and racial groups and find out the differences. Income is not, income does not separate, does not isolate race. And so we need to be sure that we keep that race issue constant.
Actually, let me pass it over here.
I actually want to respond to you, Erica. Wendy Ellis from George Washington University, because you first pointed out the fact that when you look at ACEs exposure by race, that you have a higher prevalence of ACEs in the white population. But I also want you to connect that to the science of resilience, because it's not enough to look at the instances of of ACEs without looking at the outcomes that are associated. And so despite the fact that you have a higher proportion of individuals of white race who are exposed to ACEs, you do not see the same proportion of individuals who have the negative outcomes that are associated over a span of a lifetime. What that speaks to is access to the supports and buffers that the science of resilience shows us that help people not only bounce back, but also bounce forward to thrive. And so I also would like to say, that's not privilege. And I disdain when I hear the term white privilege being said, because that's not what we're actually describing. What we're describing is access to redemption, access to healing, whether that is second chances, whether that is an opportunity to have a community that supports you, to have some of those things that we know from the science of resilience actually help people to heal, despite the fact that they might be coming from a lower economic or social strata. They still have a greater opportunity to access redemption or opportunity. So I think, words matter, but also connecting the exposure to outcomes over the lifespan are going to be really important. So it's not a criticism. I'm just inviting you to think about longitudinally, what does that exposure, the difference across the lifespan, mean for different people?
Let's keep this focused on the panel discussion rather than the individual chapters for now.
Real quick, thank you for the paper title. Also, it is so I've been working in the realm of intersectional health inequalities and intersectional health justice for some time now. And that's what I was giving a talk to the NIH about on Wednesday. And it is really hard to get those data when you look at one health measure by both, or make it more complex, by race, by education, by income, by early life exposure, by gender. It's very hard to find. And so in my view, you always have to look at these things intersectionally. And just to say to you, and I promise I will quit, the data I was looking at was not just by race. In other words, if you're looking only by race, those differences by class of origin are papered over. And what I'm saying is we have to pull away the paper. And I hear a lot of you saying exactly the same thing, which is that we need to look at heterogeneity within the group. We need to look at heterogeneity within the white population. I think we also, and maybe this is where you and I disagree, Dr. Warren, I think we need to look at not just intra-categorical comparisons, but inter-categorical comparisons, because to your point, Wendy, about white people let's not call it privilege. I've always had a rankling that's always rankled me a bit in some ways as well. You have to look at outcomes. You have to look at second chances. You get to, you have to look at many things. But the opportunity structures are there for some people more than they are for others.
No worries. All right.
Just to respond, we can agree to disagree, but what I'm saying, at the end of the day, when you look at the health outcomes, certain ethnic groups, particularly Black ethnic groups, still have greater adverse health outcomes. That's the only point I'm making. Okay, well, that's the point I've been making.
Okay. I'm sorry. Okay, great.
So thank you. This has been just a wonderfully enlightening conversation. I had originally written a question up there, but I want this one that's on there right now to, if we can answer that one. How do we measure structural racism? And how do we talk about racism being perpetuated in systems? And the other thing is, we're in a very diverse group right here, but I think all of us in our professional formation, we're also taught to be racist, to be sexist, to be anti-LGBTQ plus, to be, really oppressive. And I just wondering if you all could address that.
Yes, again, we were all taught some of those things, but we were not all taught all of those things. I think we just be clear.
Education, particularly higher education, was not built for us, people of color from diverse backgrounds. And we just have to dismantle the systems of oppressions within our institutions so we can have better higher education. Now, that's very hopeful, but we need to do it. And it's not by tokenizing, it's not by just bringing faculty of color or creating the DEI, it's actually changing the rules. And let's do the good trouble.
Ditto. But what I want to share is, we struggle with this in Hawaii. You would think the University of Hawaii would be very diverse. You would think the University of Hawaii, 26% of the state's population are Native Hawaiian Pacific Islander. Guess how many of our faculty are Native Hawaiian Pacific Islander at the University of Hawaii? Close to 5%. That's about 6% Native Hawaiian, altogether with Pacific Islanders, 9%. Compare that to 26% of our state's population. That's a huge inequity there. And we struggle at our university to put more emphasis. They even have statements in our mission and in our strategic plan that we are a Hawaiian place of learning and they're an indigenous serving institution. It's aspirational. They have yet to even get close to it. And we struggle. And we struggle with our curriculum in medical school. I always say we want Hawaiian in, Hawaiian out. We don't want them to go through this process and think their Hawaiian culture and perspectives are no longer valued. It's important for medicine. It's important for them as physicians practicing in our communities to contextualize medicine so they understand it's more than a prescription, it's more than a diagnosis, it's more than 5 recommendations in 15 minutes. And that has to change. And again, it's the culture. Even in Hawaii, where we are a significant population, you would think, at least there, we would get Jedi, correct. I like Jedi, Star Wars, go figure. But we're not. And talk about internalized racism. Talk about accepting the false narratives and allowing it to continue. And some of our own people sometimes are afraid to push back because they already made it so far and they don't want to lose that privilege that they were able to gain through education. But we need to make those changes. Thank you.
And I'll just echo that. I mean, being a first generation high school graduate, education's never been a friendly place for my community, my family. And thank you for that. Dr. Moore, we are not all taught to be anti. We have many Indigenous values and values of love and acceptance that I was raised with as well. And I appreciate my ancestors and family for teaching me those. But as well, I had the privilege of, I am no longer the Canada Research Chair for Indigenous Community Engaged Research. I ended that term with them, but at the University of Saskatchewan, I was really excited to go there about 5-6 years ago when I first made my decision, because they were indigenizing from the presidency down. And so every department, every college was tasked with decolonizing and indigenizing their curriculum and their departments, right? And so through that process, I was involved with a lot of structured roundtables, talking circles, what have you, in which we discuss how can you possibly address the structural racism that's embedded, for instance, within the field of psychology or within the field of medicine or within the field of public health. How can we do that in a constructive manner when we're built upon this racist ideology and superiority of this white modes of thinking, right? And it was really interesting. I think we made some great advances. It was really a privilege to sit in the middle of a room of senior white male professors seeking to understand their biases and being open to that. That was really, in some ways, healing for me to be in that situation and be the only person of color there to watch them go through this process. But it takes an openness, it takes awareness, it takes reflectiveness and non-defensiveness, right? So when someone says, oh, your whole field's built upon these concepts of superiority, to not say, oh no, well, I'm trained in that field, I want to protect it. Instead, it takes, okay, so what can we do better? And I think that's what we need to be asking ourselves at all times, not only being aware, knowing the history, knowing the effect that our practices and our research, our fields have on others, and being open to what can we do better, and holding ourselves accountable to that, right? Even if that means it might change how we do everything, just being open to that. I think that's important.
Let me say something about the question about measuring structural racism. And I think part of it is, we've gotten to a place where we have started to learn how to measure the behavior of institutions, institutional racism perpetuated by specific institutions like medicine, by the mortgage system, banking, and so forth. And we should continue to do that. But when you think about what structural racism is, it's actually the connections between institutions. And what we don't really have a good handle on is how do institutions work together? So for example, we can say that there's discrimination by the policing system, and we can actually do studies looking at police bias and so forth. But one of the reasons why the police can get away and continue to get away with what they do is because they know the courts have their back. They even know that the coroner's office has their back. I don't know if you've seen the article about how a lot of the people who died in police custody, Black men in particular who died in police custody, their death certificates said that they died of sickle cell. Right? Not because they were bludgeoned to death or anything. That was a New York Times article that came out last week, and there's some scholarship on that. So it's these institutions that are collaborating to uphold white supremacy that we need to, when we get at this issue of measuring structural racism, we need to measure the connections across institutions and not just individual behavior or not just the behavior of specific institutions. So it is time for us to close. I want to thank our panel and all of the audience for their great participation.
Welcome back from our break. We're looking forward to our next session, where we will now have the opportunity to discuss the publication series that we've all been alluding to throughout both of our days. I'm honored to welcome to the podium and stage Dr. Velma McBride Murray, who is the University Distinguished Professor of Human and Organizational Development at the Peabody College at Vanderbilt University. She's also the University Distinguished Professor of Department of Health Policy at Vanderbilt University School of Medicine. Dr. McBride Murray is a nationally recognized expert examining ways in which racism affects family processes, behavior, and health outcomes, particularly examining the significance of context to everyday life experiences of African American families and youth. Specific consideration is given to the implications of racism and other structural stressors that marginalize families for cascading influences on parenting and family functioning, mental and physical health, quality of life, and developmental outcomes and adjustment among youth. In addition to her role at Vanderbilt, she is the president of Society for Research on Adolescence and serves on a number of boards as board director and on governing councils, including the National Academy of Medicine, and she holds positions on numerous editorial boards. Dr. Murray is one of the 100 newly elected members to the 2020 class of the National Academy of Medicine, and I've had the privilege to know her as a Culture of Health Program Advisor. So, Thelma, thank you for joining us, and we look forward to hearing from you.
I didn't realize Ivor was going to read all of the information in my bio, but I'm really delighted to be here, and I've been a part of this project since its inception, when Dr. Bogard was able to receive the first grant from the Robert Wood Johnson. William T. Grant's on my mind. Robert Wood Johnson Foundation, and I'm delighted that they are here today to be a part of this. But it's great to see this after the second funding round of this, where we are today. So my charge from our esteemed leader, Ivory, was to talk with you today about the paper series, to give the audience in person as well as those online a sense of where we're going with these publications. And so, and the overview is the pathways of how we've gotten to papers that focus on equitable systems. And I also will say to the audience that I hold the Lois Audrey Endowed's Best Chair, and I wanted to make sure that that was recognized as part of the funding of the reason I'm able to do what I do. So as Ivory mentioned, I'm also part of the Culture of Health Advisory and the privilege of sitting on the steering committee. So I've watched these paper series evolve from the very conception of the idea by Dr. Bogard when she came back to the National Academy of Medicine of what she envisioned this particular project evolving into. And I'm a team of the Black and African-American paper under direction of our paper leader here today as well, Masherie. So I'm excited to provide an overview of the paper series. And so I'll start by saying that we actually started this process some time ago. And so over the last few months, what we've been doing is working closely with staff to develop the publication as a whole, and have been developing individual papers as well. And so the papers as a whole, meaning what do we want this product to look like as we bring these series together? And then how might each of the individual papers reflect the vision or the goal that we have? So there isn't a clicker here. I just magically blink my eyes like the witch and it happens. Okay, and so today I'm going to give you an overview of the paper, going to talk about the next steps, and then I want you to listen closely as I describe what we're doing for you to begin to identify where we might think of adding or taking away from, and questions that you may have for greater clarity of what we're planning to do. So I'll start first by introducing the intent of these papers. So the papers really are going to be organized in the following way. There's going to be an introduction, and I'll talk about, in essence, what might be included or what will be included in each one of them. And then we have a paper that's going to focus on what we call cross-cutting solutions. And then we have these various papers that you see here that focuses on specific populations with a charge of what we'd like to see in those papers. And then there would be an ending bookend with a conclusion that brings and synthesizes all the information together. Okay. So today I'm going to provide an overview and share with you what we've actually asked people to do in each of these papers. So each paper is going to have an introduction. They're going to illustrate in the papers ways in which historical and cultural contextual issues or structures of racism impact those particular populations, demonstrating ways in which there's this marginalization flow through systems that perpetuate inequities. And I really enjoyed the last panel because they gave us ideas about ways in which systemic racism should be not only measured, but illustrated to demonstrate the flow and the connectivity across these systems that explains ways in which this is sustained and perpetuated. And so I mentioned to my Cherie after and talking with Gilbert that it's important, I think, for us to begin to think about how do we illustrate, not just tell the narrative and focus on a specific outcome, but demonstrate ways in which these outcomes emerge as a consequence of the corroboration and collaboration of these systems to sustain those things that we know facilitate and perpetuate inequities. And this is the third slide, is that right, Christy? Or because I just talk. So what I want to tell you is that we really started the idea around these papers was really for us to begin to think about identifying not only the extent to which these systems perpetuate and sustain inequities, but to also identify opportunities where we might be able to dismantle these particular systems of oppression. And so as we're looking through and writing these papers, in essence, what I'm saying, where are there critical windows of opportunities where we might be able to dismantle? So not just telling the story, as Dr. Christopher mentioned yesterday, don't just talk about what we're not for because these things are so bad, against, but also what we're for and identifying what we're for. To me, it's looking critically at ways in which we can identify what might we propose or recommend for the dismantling of this. So the goal of the goal of the audience for the papers really, and someone asked the question yesterday, who are we writing this to and for? And so if you think about various groups of people or decision makers in each of these systems, if we're going to look at all these systems, then who are the players in these systems that make decisions about what happens in these systems, policies, practices, and the implementation of those? And so that means then that we could be targeting researchers, we could be targeting legislators, we could be targeting school systems. And based on what the panel that just talked with us, we could be targeting communities. I love Dr. Rodriguez's focus on this notion of resilience, such that Rodriguez-Diaz, such that we begin to talk about not only the fact that people are navigating these toxic waters, but what are they doing to resist having to swim in these toxic waters? And so we want you to also be cognizant of who the players are and whom you want the message to be conveyed to as you're writing these papers. We also recognize the importance of historic context and the way that the historic context continues to be perpetuated even today. The stories that we've heard on all of the speakers really demonstrate the historical connectivity to trauma that families and communities are experiencing. And so we want these papers to provide a mobilization for action, to encourage the authors and the readers to think about what might we be able to do and undertake over the next 5 years, with the thought of what might be those immediate actions, because a lot of times when we say 5 years out, people are thinking that it's overwhelming. And so it may be looking at more immediate goals or recommendations, and then spanning that out to what we might be able to accomplish over the course of 5 years. I loved earlier listening to the person from RWJ. She says, this is an opportune moment for us to shift the potential of human value and change the narratives. And that's also a common theme that I'm hearing in the presentations that happened yesterday as well as today. We can shift the narratives. And the question is, what stories do we want to be told about these populations as we begin to release these incredible papers. So as it stands now, and I'm assuming if it says stands now, that there may be some room for negotiation because we've already begun to say 26 pages is not enough. But an introduction, as I mentioned earlier, a cross-cutting solutions, 7 populations papers, and then the conclusion. And so I'll talk about each of them now in terms of what to expect. So in the introduction, this is what we envision, is that there's a lot of information that is overlapping, and we want to make sure that, one, that the whole context or the setting of how these papers have come together and the message that we want to be conveyed in the papers. Oh, thank you for shifting the slides. We want that to be in the introduction. It's the overarching framework and the context. It's going to define systemic and structural racism. It's going to provide the overarching context of what we know about structural racism and how it impacts, and also the root causes of inequality. And we also want the introduction paper to focus on harms, shortfalls, and the muddiness or the messiness of having these artificial categories of race proposed and imposed by OMB. And so we've adopted them because that is the model that we currently have, but we want the writers to talk about new theoretical models and epistemologies of ways we may want to think about measuring what separates us as a function of culture that now has been deemed based on those categories. In the early discussion, what occurred is that there was an importance of looking at intersectionality, and that has occurred throughout all of the topics that we've had, and that's going to be a main topic that each of the papers are going to address, because we want to highlight in the papers that these groups are not monolithic, and that the heterogeneity within them, as our speaker mentioned earlier, we want to make sure that we look at these within group differences, because it allows us to know, as one of my colleagues on the advisory board said, the fact that there are some groups within that are doing better than others, and to understand why that is, that within groups, certain groups have greater advantage than others. And lastly, we want the introduction to frame the series as a whole in terms of its implication for health. So how do these systems come together then to help us understand the reciprocal relationship between health and racism? The next paper is a cutting edge paper, which we think, as the note says, too long, didn't read the whole papers. So the cutting edge is for those that really want to know what's included in all these gazillion pages of paper that this series has evolved into. And so the cutting edge paper is going to be the paper that really will lay out a summarization and analysis of the solutions found across the populations in each of the papers. And this paper will ask the question, what are the commonalities and common levers of change that we've seen across these populations? We started identifying some of them yesterday, and Dr. Bogard eloquently described some of them during her summary this morning. But what are the key actions that we may begin to mobilize in the next few years? And it's in that vein that we may want to begin to think about, then as we look at these commonalities, these may be places of entry that we want to start in our efforts to promote social change. We anticipate a sense of power sharing, seeding and shifting, and that these will be critical elements of this particular paper, such that we'll all have a part of thinking about the shaping of this paper, each of the authors, advisory and steering committee members. In addition, we want to identify ways in which there can be return on the investment noted in this particular paper as it relates to not only the cost associated with structural racism, but the value that can be gained by our society when we begin to focus on some of these changes. And then lastly, next I'll talk with you then about each of the papers. And so I'd like to now, so for each of the papers, we, as mentioned earlier, there are these categories of populations, and we want these populations, as a result of the OMB imposed categories to give some insight on modifications that were really rendered by your particular writing group as a consequence of thinking about the extent to which these structures are confining. I think our MENA group yesterday really illustrated to us that it's confining when you're forced to select one of these categories for which you're asking the question, is that really me? But you're forced to do that. What does that mean in terms of our understanding issues of inequities? The general outline, as seen on this particular slide, is what we want. The introduction, while the introductory paper will give an overview, what we want these introductory papers to do is do a much deeper dive. Deeper dive not only in looking at the population itself, but the intersectionalities as it relates to specific groups that you're focusing on. And as our speaker mentioned earlier, Black and African Americans are different groups of people. And so there's a need to really think about that in the writing of that particular paper. There may be a need also to look at what this might look like within groups. And we anticipate that because of the heterogeneity across these populations, that the papers will look different. I was talking with someone yesterday that said the outline for the Black and African Americans just seems just right. And I said, it may not be, because it's unique to the experiences of that particular population. And so if you look at the outlines, in my view, reflect the populations for which we're writing about. And so some populations may have a very wide introduction that folks on the historical context. It's important because for many populations, a lot of what you shared today, we don't know. And so it's an opportunity also to educate about the historical context and its implications for various populations. One of the things that is noted in the notes here is that there should be examples. For example, there should be examples of specific historical contextual processes that really impact where people are right now. An example is Chinese Exclusion Act for Asian Americans. That should be recognized. It's a critical historical moment that influenced a lot of what's happening within the Native Hawaiian and Pacific Islanders paper. We also have asked the papers to focus on two systems, but I'm changing my mind about that now because it isolates the connectivity and the linkages across these systems that's perpetuating what we see as inequities. And I don't know how we might do that, but I know that we're smart enough to figure it out. But the way to tell the message, in my view, is for us to illustrate, and someone gave a great example yesterday when Maisha was talking about the Black African-American paper, to illustrate really how maternal health, mortality, for example, goes all the way through these systems such that you end up when a person is aging to see the manifestation of cognitive deficit as a consequence of things that happen in utero. So if there's a way for us to weave through this, and I know we can do it, but if there's a way for us to weave through this and pull these systems together as examples to show it's not occurring in isolation, that healthcare access or lack of it thereof is related to redlining. So we just need to connect the dots, as someone said in one of the meetings yesterday. And then we want them to have a conclusion and then identifying some health outcome that they want to focus on. But in the conclusion, it's more than just writing about it, but the goal is to be able to identify tangible next steps for the readers that will be part of the cutting edge paper. So they'll close with the conclusion that brings everything together or synthesize everything. And we're excited then about the opportunity for the audience to reflect on this structure that I've shared with you thus far. And so then the next step is to look at the timeline. So I can't believe we started this in August. It just seems as though it was last year. And I think it's because we've done so much. But we just started this process August of last year, but it just seems way back like 2021 or January. And so we started out by having a standing committee, and this committee worked in the role of really serving as in a consultative role to help us think about what might happen as this vision of developing these series of papers. And I must tell you, it seemed overwhelming when we first talked about doing this. I mean, totally overwhelming. Lots and lots of meetings, as my colleagues sitting here know about those meetings. And from the conversations that we had, what we decided was we developed an overall framework for this series of papers. And then we began to start thinking about, well, who might be writers for this particular series? We have a spreadsheet that is many, 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 many pages long with lots and lots and lots and lots of potential authors by race, by topic, by discipline. I can't imagine what the staff did in pulling all this together, but it's massive. So from that list, then, it's to begin to think about who's doing the work that specifically addresses what it is that we would like this paper series to evolve from. And thus, you are here and online as part of the selected group of individuals that's going to really create this land-breaking piece of document that I have begun to focus on as Neurons to Neighborhood, the next phase of the NAM's critical delivery product. So we're now in the phase of, so from late fall until now, we've been planning with the authors. The authors have been meeting, developing and refining their outlines. Some of them have begun to write. Some author groups have begun to write. Some authors groups are still looking for authors. Some authors group have had other people added to their group. And so it's an evolving work in progress. But the ultimate goal is that by the spring of 2023, there should be some writing and editing happening in these groups. And then we're planning to have a convening kickoff to really, which is part of what we're doing now too, is the convening. But the goal is to have these papers ready for us to be able to take a look at and release by winter of 2023. So the next step then, as the series progress, we will continue to have convenings to inform the development of each paper, and also the date and times for these convenings will be publicized so that those of you that's in the room and online will be able to join us again. And we want you to stay tuned for the papers and the release of this incredible document as we progress forward. So I'm going to move now to the opportunity for the audience to engage and give us your thinking and reactions to what we've done, to share your reflections, to pose questions, to provide comments that we may or may not have thought about in the formation of this pretty gigantic product or project. And so there are a set of questions that we can start the process with, and that is, what do you think the steering committee and authors are missing? Or are we overlooking in our plans for the publications? What should we consider from our work, experience, or community contexts? And what would you like to see from those contexts in these publications? And so we'll just start with those two. Do you see any missing pieces? Yes, Erin.
Thank you for the overview.
Oh.
Thank you very much for the overview. I think.
Is it on, Ivor? Okay.
It's on. Some of these things aren't, it's okay?
Yeah.
Yes? Okay. Some of the issues we've discussed during our other meetings is who's going to be the overseer in a way, who's going to read the entire document to assure that we don't duplicate particularly, broad general history, and that it sort of falls together within the aims that you have laid out. I don't remember if we've have an answer to that or if we're working on it.
I know that we're going to have, like all NAM projects, there will be an external review group or consultative group, but I'll let Ivory and or Kimber or any other member of the team provide more insight. But it's going to be reviewed. But what you're saying
Yeah,
is
not
reviewing
saying-
it
yeah.
along the way to ensure that we're not covering the same thing. And the vetting of that has great implications for the cross-cutting solutions paper. So
Exactly. That's what I know the review process. I know everything
yeah.
after, but among us.
Who's going to
gonna-
be vetting and screening and
Yes.
yeah.
So-
Ivory, yes.
And that's why we have a steering committee. So within each of the author groups, there's a steering committee member that is bringing those insights, the discussions that are happening, the focus of each paper to the overarching steering committee conversation. So we do have oversight of all papers coming together for continued conversation. But you also have staff who are a part of each of these papers looking at what systems are being addressed, what elements are being raised. And then to Velma's point, we do also have the Culture of Health Program advisors who will be informally reviewing papers throughout their development.
So they're going to be iterations of it, in other words, such that the people that are placed on each of these committees, steering committee members, staff, will have meetings to talk about the progress and give advice back to the authoring team on ways in which there needs to be some massaging. Yeah, Hutch.
Great. Velma, thank you so much. That's your excitement, enthusiasm is contagious. So thank you for doing that. I want to ask that the steering committee and all the authors keep a healthy skepticism on data. I say that because we've had speakers today just talk about the erasure through data, the genocide through data. We know the IQ test. Data informed and data driven are terms we often use to shut down conversations. When someone says the data says this exists, a lot of times we stop and say, okay, that's great. But I remind people that drapetomania, the idea that slaves ran away was a mental condition. That was data driven. That was data informed. The EFGR is still now being dismantled as a racist change to the glomerular filtration rate. And we need to keep going forward, thinking about the data we look at and realize that there's data that's not published because editors don't think that it's significant enough.
I love that comment, and it may be a cross-cutting issue because this invisibility of the critical data is across all of these populations. And the mere fact that most of the studies that we have about white populations are really about white middle-class populations suggests that those that are very, very poor aren't represented. That's another data invisibility that can be highlighted, but it's a great, great point. Yes, Jose.
So that's great. I mean, I would like to help us think about sort of who the audience is going to be, and then think about how the solutions that are proposed are communicated. Not that I'm sure it's a very difficult task, but because when I open a book, like this, I want to see pretty pictures and tables, but I want to also see what do I get out of it right away that I can implement. So maybe there's a process in which chapters are being worked on, because I expect some chapters will get really high level, some will get in the weeds, and you have a way of calibrating it so that you end up with, and then what is cross-cutting, right? So thinking through that.
That's also a really great point. And it is, again, it's 26 pages. And so if you think about the 26 pages, and if we want to make sure that that groups that are part of each of these systems see themselves and how we've written this, then how do we do that in a way that it hits the point, it doesn't get in the weeds, but it shares enough of the information that you realize what these particular groups are experiencing as a consequence of structural and systemic racism. It's a real dance And I love to dance, but I don't know that I dance that well. But so it's really going to require a lot of, and I love what you said earlier, there has to be a lot of collaborative processing through this entire journey. And it means being nimble enough to realize when author teams get feedback from staff and the steering committee, don't think it has anything to do about the fact that your lovely words aren't useful. It's really trying to get to a product where we hit the message, key in and key on. So be nimble enough in the process to be open and willing to realize it's a live document until it ends. Yeah, my good trouble colleague.
There you go. I'm going to cause some trouble for you right now here. So thanks, Velma, as always. And again, I think part of the joy I have in working in this Culture of Health program is working with colleagues like Velma and others around the table. So thank you for that. I am going to disagree with you on one component. I know that you talked about the need to focus in on systems, maybe not something that we do. And I'm going to say I disagree with that. I think we have to. I think the papers are so huge. I mean, I get nervous when I see all these outlines and it's like, how in God's name are we going to fit this in 26 pages? Yeah. It really is concerning, but the papers have two components. And I do like the idea of the integration of not just a system. These are things that are cross-cutting across, but one of the things that we wanted to do was to share with, and again, the commonality in the systems that we choose are so important, because what we want to show is that these issues are not unique. The issues of incarceration, the issues of misrepresentation in the media, the issues of education are expressed, impacted differently and in unique ways in groups. But the answers and the solutions really are attacking those systems, both in isolation, not I say in isolation, both uniquely. I mean, there may be specific things, but also broadly. So I don't want to lose sight of what the systems are. The second thing that we haven't talked about here, and since we have some of our community members here that we have been talking about and struggling, is how do we authentically include community voices in what we're doing? So we've had some discussion about this, and I think in whatever meeting we were yesterday, we had, we went crazy and had some good ideas as well.
Committee.
We had, you were there too. You were there too. But we had talked about, we want to make sure that, I like your idea of the case studies. I think that's one way of inserting community voice. We had also talked about a separate paper, a different, the NAM has a different mechanism other than these big 30 papers that our community members could take charge of and frame in whatever way they wanted to that would be complementary. I know that there was some discussion about, well, does that make them a lesser component? No, it just gives them, I don't think so. I think it gives them a wider voice. It's a way of extending those 26 pages. It's a way of having the communities have ownership of what they want to say, how they want to say, that's related to the paper. And we present these as unique components. And then yesterday in our group, when we were talking about a compendium of research, we got crazy and thought, well, why does it have to be an academic paper? Why not we have communities use a spoken word, art, whatever, to illustrate or to, and again, not to respond, but to be as complementary to what we're saying, to talk, because we're talking about how narrative matters. So anyway, those were some things that we were thinking about in different groups, and I'd be interested in your thoughts, but I heard your thoughts yesterday.
Well, you don't have to tell me again. I heard
and others,
Well, one comment, and I get one comment is accepting Tony's friendly amendment. I always defer to her. Tony's amendment, and maybe we could illustrate these multi-level connectivity in either the introduction or the cross-cutting paper. We're putting lots of things in those cross-cutting papers, but it may be a way to show how, frame it in the way that this is how these cross-cutting issues are manifested in the, so I totally agree with that. And one of the things that I thought about when Tony mentioned the community voices, it reminded me of a consensus study that we did, I think on young adulthood, where we had young adolescents voices included as shout out boxes to further illustrate the stories that we were telling or what we were writing about young adults, mental health and well-being. So there's a way we could integrate really the community voices. You know, I just dream big. I'm looking at Ivory. The way that we can integrate community voices as part of the narrative to further illustrate, as I was talking with G earlier about ways, and you know, this the multi-level, and also my Cherie, the connectivity between early exposure to the child welfare agency, the Child Protective Services, and linking it later to juvenile justice involvement of kids, because early in the stage of the entrance for being there because of family kinds of issues that are oftentimes poverty driven, these children then end up later not getting the care they needed at that entry point, entering systems again. So there may be a way for us to illustrate that in the cutting edge paper, and I totally agree. But opening it up for, I'm probably out of time, but Ivory, tell me what to do.
I'm happy to bring in some comments we've heard from online, but then yes, we will move to our closing remarks. So if you don't mind, in terms of what do you think the steering committee and author groups are missing or overlooking in their plans for the publication? There was a comment, will there be a bias statement to acknowledge that we are all products of the historical bias, racism, and whitewashing of history? So this data may change as more transparency in history and correct data gathering based on segments of society are reached, meaning these papers are not an endpoint, but a starting point.
That's a great point.
Another comment, I wish to read papers where the problems, in this case, systemic racism leading to inequalities, provides me with the implications and application of individual resistance while addressing the involvement and responsibility of the community and its subgroups. And then I'll introduce this final comment, international experiences from countries like India with nearly 120 million population of indigenous communities. And I will only respond to this comment to say that these papers are focused on the United States. So just to flag that. And then for our second question, what considerations from your work, experience, or community context would you like to see addressed in the publication? We had several responses. The first, more than addressing, showing examples of successful communities and individuals thriving or at least moving in the right direction. Another response, culturally embedded beliefs, practices to promote mental health and prevent mental disorders and facing life stages like old age and loneliness. Another comment, homelessness effects on health and how systems in place sustain and increase the amount of people experiencing homelessness. And then the final consideration that we received is the nurses' roles in helping to successfully build a culture of health.
The nurse's role. Okay. All right. Well, those are great comments, and I don't think we have time to answer them, but I'm assuming there's going to be a way of responding from staff to various chats that we've received along the way. And it's been a delight speaking with you today, and I'm going to bring up my colleague, Ms. Tolman, who is going to talk with us about her part that she was assigned to. And it's been great. So she's been a part of this gang too since we got started. So Tippy, it's great to have you take the podium.
Thank you, Velma. I first want to acknowledge the Piscataway Trama Khoche La Unkinajipe the Piscataway people whose lands we are now on. My name is Tipizui Tolman, which means I greet each and every one of you with a warm, heartfelt handshake from my heart. In the way of my people, I want to share where I'm from. I'm Hukapapala Kota, Wichinenda Kota, Tizaptana Isanti Dakota, born and raised in my homeland at Standing Rock and what is now known as North Dakota. But you can, that's the short version. You can look at my bio. I want to share that being born who I am as a Lakota Dakota, Velma gave me the language, shared the language for me to be able to say that my lived experience in my daily life is a culmination of tens of thousands of case studies on the realities of the structural and systemic racism that exists in this country. And I know that I'm not unique in that. But I wanted to quickly share some of my most recent experiences in structural and systemic racism. This is a short, fast list. Indigenous erasure, the uplifting of rapists and murderers of my people and curriculum and the names of towns that I grew up around. My 8-year-old brown boy son with long hair who was reprimanded for chasing a white child, then called a young man by the school administration when he was 8. He was a child. Being the singular Indigenous instructor in a predominantly white institution in a preparation program for predominantly white students. My youngest son assumed to be in drug withdrawal and taken to the NICU at birth. My children's school seeing a classroom build an army fort, celebrating the violent settling of our lands. The fort to my Lakota and Dakota people was a place of violence, of sexual violence. And we had to give up our rights, our lands, our ability to hunt and gather our own food, to harvest. We had to give up our sewing needles and our knives at these forts, and then to go into a school where a fort was being built and celebrate it. Being born and raised on my reservation, whose boundaries were created by Congress, having a number and a blood degree that was created by Congress, living in a food desert, federal restrictions of the building of our own homes, financial institutions, and a complete lack of infrastructure. And we didn't decide any of it for ourselves. Having our maternal protocols not allowed, every single baby born from my reservation is held first by a white doctor and not our own women relatives. From our birth to our death, we have no autonomy. Being the great-grandchild of families who survived massacres by the US Army, but nobody in the mainstream population or public know about those massacres. Being raised in the tenets of generosity, sharing of food protocols is very strict among my people, yet school districts do not allow children to share food. Again, I have thousands of more examples, and many of us here do. The culture of health has informed the critical work that we are all engaged in, and Velma and many others have gifted me the language for me to effectively work at the root causes of inequity in higher education and to change the narrative of the future for the better. So what we've been doing here, we've been listening, we've been sharing, engaging authentically, deeply in a safe space to critically and rigorously examine these systems that were all built intentionally. And we are all here to work together to intentionally dismantle what Dr. Gail Christopher calls the hierarchy of humanity. Some of us, if not all, come from the results and the fallout of war, and we have to rebuild. And we need each other's help to rebuild a system that's based on midakuase. Midakuase, again, I talked about it yesterday, but it's the tenet of my people that we're all related to everything in creation and that we're in sacred relationship with each other. And it also means that we are all worthy and capable of gifting and receiving humanity and dignity. This is my people's framework for our daily lives that has survived despite colonialism and genocide. And I'm happy and blessed to be able to live it and still believe in it and share it with you all today. And it aligns with the vision of the culture of health. So with that, I will invite the audience and the room participants to use Slido to respond to the following 3 questions. The Slido at slido.com is number 3358660. And our first question is, how do you experience or witness structural and systemic racism perpetuating oppression? So again, the question is, how do you experience or witness structural and systemic racism perpetuating oppression? Do we have any answers? Any takers? Okay, so the first question is, how do you experience or witness structural and systemic racism perpetuating oppression? Shall I read all 3 of them? Oh, is that supposed to be me that does that? We have a couple answers: unfair access to resources or discriminate treatment in politics and the justice system, as well as the media. It is witnessed and experienced as I see differential treatment of students and residents based on their identities rather than, I can't read the rest. Underfunding of IHS, Congress has literally placed more value on non-Indian populations, including federal prisoners. Race-based medicine continues to perpetuate a hierarchy of care. Should I move on to the second question? So the second question is, what common misunderstandings about structural and systemic racism have you encountered? Some of the answers are that it no longer exists. Race is a biological difference. The existence of poor, uneducated whites mean white privileged and advantage isn't real. Minority is defined to include just one or other race. One I would like to share is in my instruction of my pre-service teachers, they really personalize the systemic and structural racism, and that doesn't serve to really help remedy it. It's a system that exists. Minority is defined to include just one race or another race. And the third question, what actions would produce structural and systemic changes that improve health and well-being in your communities? What can we learn from past and current failures to enact change? Education, early intervention, redistribution of resources, unfair treatment and unjust policies. For myself, I really believe this is where that tenet of my people come in, that we really help each other and show up for each other and protect each other in all situations that structural and systemic racism exist. Investing in communities after generations of little to no investment, integrated communities, more funding for IHS and CHCS, viewing other cultural ways of knowing and being as valid and requiring space to promote thrivance, equitable resources, dispel the myth of white supremacy. Y'all can read. Am I good? Okay, in the language of my people, say thank you to you all. Pila mayayapi.
Thank you, TPZUN. So at this time, we're going to leave for our virtual folks and folks in the room. We are going to leave the poll up for another 5 or so minutes. We do want to hear from you. We want to hear your feedback and utilize it in carrying forward our work. So we'll leave the poll open. But this does formally conclude our first virtual in-person after many years away from each other convening. And I'd like to thank all of the speakers that joined us yesterday and today. If I could get another round of applause for them. I want to extend a thanks to our authors who are also here with us today, to the Culture of Health Program Advisory Committee, who was instrumental in pulling together this meeting. And then I would like to especially thank my team who is running all of the behind the scenes, making the magic happen. For those that are online, I know you can't see them, but for those in the room, if I could ask my teammates to stand up, this meeting would not have been possible without you all. So thank you. That includes you, Kimber, and Shania. My other 2 team members, Kimber Bogart and Shania Taylor, didn't stand, but. So yes, I just want to thank all of us for joining, commenting, including such thought-provoking presentations and questions. I want to acknowledge the toughness of this work. The difficulties that we undertake in having uncomfortable conversations, but we do it in a way where we bring together a safe space. But as I tell my colleagues at the NAM, we're also asking you to be in a brave space with us. This is hard work. We will not shy away from it. We will bring the strongest science and evidence to bear because ultimately what we seek is to advance a culture of health. We want to advance health equity, and it's only going to be done if we stand together, work together, bring all of the voices to the table to do this work, to inform this work, and to move this work forward. So thank you all for joining us, and that does conclude our meeting.